Would everybody like to make their way into the hall, please? Because we're starting now. It's 8 o'clock and it's going to be live streamed, so people online will be waiting. All the people outside can take your seats, the ones who are inside, please. Thank you very much. Good morning, everyone. Thank you very much for coming this morning. Welcome to all from Médecins Sans Frontières, Doctors Without Borders, and the Faculty of Medical Sciences at the University of Sri Jayawardenepura. My name is Helen O'Neill. I'm the Strategic Advisor to the Management Team in Delhi for MSF, and I'm here just for this event, in fact. I work as lead and MT sponsor for the Asia Scientific Days for MSF. We are here today for this international conference on medical sciences and MSF Asia Scientific Days 2022 in Sri Lanka. The need for humanitarian efforts is stronger than ever, and a continuous attempt to bring the scientific community, public health organizations, and academics together in a space to build an ecosystem of sharing knowledge, expertise, and experience is very important. The Faculty of Medical Sciences and MSF have been organizing medical and scientific conferences in their respective domains for years. However, this year, this joint endeavor and collaboration will create a larger platform for research and innovation in medical care. This year is a unique one. While we are finally meeting in the offline world after the COVID pandemic, it is live streamed for our global audiences, and there are many people from all over the world joining in, I believe. The two institutions aim to bring together researchers, practitioners, academics, senior scientists, and students to catalyze improvements in the quality of care provided to patients and populations at risk. The This expands MSF's continued efforts to place patient-centred care at the centre of our existence. We are anticipating a stimulating day with knowledge-based interactive sessions for the next couple of hours. We'll get an opportunity to hear from young student researchers as well as experienced scientists and scholars from around the globe who will present their work. For our online audience, we have a user-friendly guide in place. Before we move forward, let's have a quick roundup of today's house rules for the conference. We would request everyone to adhere to the schedule of the programme of the conference. You have an agenda, everybody has an agenda who's physically here as well. And please keep your cell phones silent, especially when a session is ongoing. And lastly, maintain decorum throughout the conference. Excuse me. We are hoping that connectivity will not be an issue, but please bear with us if it is. And we are going to be very strict on time for the speakers, etc. We have made efforts to keep the conference eco-friendly. Most of the creatives you see here have interactive barcodes, which includes a screening of the posters instead of the prints. Some elements still need our attention, which we will ensure to address better in the coming years. We request the online audience to send their questions to us in the chat box below the live streaming window on the website, and they will be relayed to the speakers. Our in-house and online audience may choose to retweet our tweets while we live stream, and you may use the hashtag MSF-SciAsia, which I think is in your brochure as well. We will take the questions with the speakers after the sessions, not during the sessions. We request everyone to go through the consent form, sign it, and submit it to the registration desk, please. And today's agenda, as I said, is in your notepad for easy reference. Now I would like to call on Dr. Farhat Mantou to give the opening address. So Dr. Mantou, or Dr. Farhat, is the Executive Director of MSF South Asia. And she joined MSF in 2003 and has been working in different capacities nationally and internationally. She has worked with various multinational companies and organizations. During the last 19 years, her work has been in Asia, India, Afghanistan, Sri Lanka, Nepal, Bangladesh, Europe and East Africa, South Sudan, Somalia, Kenya, with MSF and other organizations in management and leadership roles. She specializes in medical anthropology, communications, hospital management and human resources, and she is trained in humanitarian assistance linked to international humanitarian affairs. She serves on various international committees, both MSF and external, and has co-authored publications under her title. We are happy to have her here with us, and I welcome Dr. Farhat and request her to come forward and formally open the MSF Asia Scientific Days and International Conference of Medical Sciences 2022. Thank you, Farhat.
Good morning, everybody, and good morning to the online audience. It's very early morning, so we want to bring a bit of energy. So I want to see a bit of life in the room, so I would say good morning, and I would like to hear good morning from all of you. Good morning. Thank you. Thanks, Helen, for the introduction and giving us house rules for the day. I'm very excited to be here today, and I hope we are able to kind of infect you with this excitement of learning from each other, learning from the panelists that are especially curated for you today. The topics that have been selected are aimed at the region, the problems that are the problems of today and the problems of future. So we would also like to see that it's not a one-way traffic where the panelists are presenting, but we would also like to hear what are your questions, what are your experiences. So please feel very welcome to engage with our panelists all through the day. Last 2 years we have been online. So for this year, for the first time, we are attempting to do a hybrid conference. And we hope that the technology doesn't let us down. We are talking about innovation, so we'll also innovate and improvise if we experience any such kind of technical difficulty that may come today. You must be thinking, what is this Medicine Sans Frontiers? And yeah, it's an organization. It's a 50-year-old organization, an international medical humanitarian organization, working all around the world, somewhere between 65 to 70 countries. And where do we work? We work in places which are either impacted by a conflict or a post-natural disaster or a certain vertical disease area that is neglected or communities that are excluded, and this exclusion is in some cases deliberate, is intentional. So this exclusion could be political, economic, social. So these are the places where our frontline workers, our doctors, nurses, logisticians, financial coordinators, HR people work hand in hand together to deliver medical aid. So when we are a treatment-based organization, what are we doing here today? On a daily basis, our doctors and nurses in the field experience challenges in delivering medicine. So what we want to bring to you is not only experiences of our field from different parts of the world, but also learn from other organizations that may have similar experiences of how to improvise on the ground, what are the challenges we face, what are the solutions we find, and how do we make sure those solutions can be implemented and learned from and applied in different contexts around the world. The intent is one, to make sure the quality of medicine keeps improving, and it is based on evidence and it's based on scientific rigor. So that is critical, and that is how we conclude the day today. Our day is driven by abstracts that we receive from all over the world. We specially curate them. There is an editorial committee that works on them, and then there is a choice made of what we would do. So today, in addition to those abstracts that will be presented, we have 2 panel discussions. And those 2 panel discussions are as critical for the globe as they are critical for this country and the region. One of them is on climate change and the other one is on NCD. And climate change, it's a topic that concerns each one of us. We cannot say, oh, I'm sitting here, it doesn't touch me because I'll find some local solutions. But climate doesn't respect borders. So we are sans frontiers there. So from that point of view, I would say that hear what your colleagues are going to talk about, their experiences, and challenge them, listen to them, keep this dialogue going. I think that is critical. What we want from today is that at the end of the day, we leave all of you with some food for thought to be carried forward. As students to practice in the field, as mentors to mentor your students, and as academic and researchers to be sure that you further work on those topics to explore what is happening on those critical disease areas in the country. One more thing, because I do feel like this may be important, that COVID taught us that we cannot say our problems are ours and their problems are theirs. So it took us 2 years and still counting that we are working around the world to find solutions, and we are bracing on a daily basis on an epidemic that taught us that diseases can emerge from anywhere and engulf the whole world. So let's also, in addition to just listening about it, talk about it, but purely based in science. Thank you very much.
Thank you very much, Farhat. Okay, now we move on for your insight and encouragement and a very good explanation of what MSF is for those who didn't already know. Now we're going to move on to the first session of the day on the topic of community health volunteer engagement during COVID-19 to reduce non-communicable disease risk in low-resource urban settings in Malaysia by Dr. Ishu Kataria. Dr. Kataria is a senior public health researcher with the Centre of Non-Communicable Diseases at Research Triangle Institute International. She works on NCD prevention and control in India and globally. Dr. Kataria has experience in conceptualizing and developing training interventions, designing and implementing cancer prevention programs, maternal and child health, adolescent non-communicable diseases, and behavior change communication. She serves as the NCD focal point for the UN Major Group for Children and Youth, is the steering group member for the recently launched NCD Labs initiative for the WHO on NCDs, and the next generation, and is a commissioner for the Lancet Commission on Women and Cancer. Dr. Kataria will be joining us online today, and following Dr. Kataria's presentation, we will take audience questions if we have time. Thank you. I hand over to Dr. Kataria.
Thank you very much.
Any chance you can turn on your camera, Dr. Kataria?
I've switched it on.
Yes, we see you. Thank you.
Perfect. I'll just share my screen. Please let me know if you can see screen. Is my screen visible? And can I start, please?
It is. Thank you very much.
Perfect. Thank you. Hi, everyone. I am Dr. Ishu Kataria. I work as a senior public health researcher with the Center for Global Non-Communicable Diseases at RTI International. The Center for NCDs at RTI International leverages multidisciplinary technical expertise, research capacity, and programmatic experience to prevent and manage the negative health, economic, and social impact of NCDs. We work in more than 40 countries around the world, partnering with governments, non-governmental organizations, private foundations, and multilateral organizations to confront NCDs in all stages by designing, implementing, and evaluating policy, prevention, and treatment interventions. And today, I'll be speaking about our work on community health volunteer engagement during COVID-19 to reduce the NCD risk in a low-resource urban setting in Malaysia. But before I begin, I wish to thank the organizers for this wonderful opportunity to be able to share our work with you all. This is the outline of the presentation that I plan to follow today. I shall begin with the context, describe the methods that we used in our study, and then take you over the findings to finally come at a conclusion. Post that, I shall outline the recommendations from our work and end with some key messages. Before I begin describing you about the study, it is important that you get an understanding of what Better Health Program in Malaysia is doing. So Better Health Program, as we call it BHP, is basically co-developing a suite of locally tailored, evidence-based interventions for NCDs and obesity prevention in collaboration with urban poor communities as well as local businesses in Kuala Lumpur, Malaysia. The development of BHP Malaysia Pilot Intervention Plan involves a three-pronged approach and has been co-developed in close consultation with community beneficiaries. This has been through various community-based surveys, research evidence, and other sources of best practices. This includes increasing awareness, knowledge, capacity, and skills on NCDs and healthy eating, providing and promoting opportunities to help engage in physical activity, and engaging businesses to supply healthier food. What you see on screen is the methodological framework and approach for the BHP. Originally, we had thought of implementing all the activities for BHP Malaysia using a face-to-face approach. However, due to the pandemic, we had to go virtual. With this context, BHP in Malaysia developed a strategy to engage community health volunteers in low-income neighborhoods, which is the P40 population group, to address obesogenic environments through a proposed route of locally tailored, evidence-based, community-informed, and community-driven interventions for NCDs and obesity prevention. B40 is basically the population group in the country, which is the bottom 40% of the Malaysian household income. However, the COVID-19 pandemic hindered all our community engagement approaches, which were typically supposed to be conducted in person with support of community health volunteers. So for our study, we selected a target cohort of about 30 community health volunteers from 3 different KRTs, which are basically household divisional areas in Kuala Lumpur. These were PA3 Kota, PA3 Negeri Sembilan, and PPR Pekan Kepong. These were recruited to participate in BHP Malaysia, and we were supported this recruitment by the District Health Office. So CHVs were basically recruited from 2 main pools. This comprised of former and present COSPEN participants and new volunteers. To describe further, COSPEN program is basically an initiative by the Ministry of Health in Malaysia that addresses the increasing burden of NCDs in the country. This initiative is a transformation of public health services in an effort to improve the quality of health of Malaysians through empowerment and expansion of community involvement in public health programs by incorporating various existing mechanisms, especially at the grassroots level. The focus of our intervention through BHP was to build knowledge, capacity, and skills of CHVs on NCD prevention and healthier eating so that they can propagate the same to the community members that they were serving too. We also sought necessary ethical approvals to undertake this engagement with CHVs. I move on to sharing the findings of our work now. So at the onset of BHP Malaysia, the community health volunteers were basically expected to engage in typical approaches of community engagement, which included face-to-face interactions with community members to really support them towards better health outcomes, as well as periodically delivering community health promotion activities within their respective communities. This was basically in line with their role as community change agents. However, the government measures that were undertaken to stem COVID-19 nationwide necessitated a realignment of the roles as well as the expectations from CHVs. Given the virtual delivery that we had to do for most of the BHP Malaysia intervention activities, the community health volunteers' roles shifted to then actually influencing the community members by sharing their practices online with their social networks and seeking to inspire their peers to join the journey towards better health outcomes. So between January to December 2021, the CHV capacity building program was actually delivered in a multi-modality fashion. This included 4 in-person and virtual workshops, about 80 face-to-face and virtual informal check-ins, and asynchronous e-learning courses. What we observed that there was a 41.9% increase from CHV's collective baseline knowledge assessment score in the post-program knowledge assessment. This was about 85% of CHVs answering correctly all NCD risk factor questions. At the baseline, this score was about 43%. CHVs also highlighted that active virtual learning strategies that the BHP Malaysia employed during the period of COVID-19, which had games, simulation, role plays, as well as actionable practices such as diet and physical activity, being a key factor for making the training that they received useful, practical, digestible, and enjoyable. Therefore, what we were able to conclude through our work is that the large majority of CHVs demonstrated increased capacity in their knowledge through learning approaches that were of multimodality nature. This enabled them to perform their roles as community change agents even during the COVID-19 pandemic. We offer several recommendations from our study. First, it is important that CHVs, in order to perform their roles as community change agents, need sustainable support. For instance, this could be provision of practical job aids and ongoing technical material support, including refresher courses. It is also important that CHVs have strengthened links with primary care providers such as doctors, nurses, nutritionists, and other health experts in their communities so that they can provide ongoing support and evidence to others in their community. It is also critical that these CHVs are provided with a supportive environment of community leaders, family, and friends so that they can perform their roles effectively and efficiently. Finally, the most key recommendation is that appreciation and recognition are critical, as it goes a long way in boosting volunteer motivation to be able to perform their tasks that they are assigned to. There are three distinct key messages that emerge from our work and that I would like to share with you. First, it is important that community health workers are involved in design and implementation of programs, as it helps and results in stronger relationship building, increases empowerment, sustains engagement, and foster ownership of the activities that they are performing. The second message is that it is pertinent to use simple, clear language, easy to understand concepts through a range of delivery methods while training CHVs, as it helps them understand as well as retain what is being taught. And the final key message is that the importance of learning in a cohort, peer inspiration, mutual support, healthy competition, and presenting evidence through visual aids helps to initiate as well as sustain motivation for learning collectively. It also helps them sustain longer in the program. Before I close, I wish to acknowledge our on-ground team in Malaysia who has helped to make this work possible. And with this, I close my presentation. I'm happy to answer any questions that you might have. I'm also sharing my contact details in case any further information is needed. Please feel free to reach out to me. Thank you very much.
Oops. Thank you very much, Dr. Kataria. If there are any questions in the room, we have roving microphones, I believe. You can put your hand up and they will bring the mic to you so that Dr. Kataria can hear your question. Sorry, I don't see any hands up. There's one question online that I can ask. We still have Dr. Kataria, right? Yeah. Okay. Thank you. Thank you. What, if anything, is the role of financial incentives for developing a sustainable delivery system, in your experience?
Sure. So thank you for the question. I think I'll answer basically pertaining to the program. Since we were planning this program in close collaboration with the Ministry of Health, and they already have a cost spend program that I spoke about, the ministry was very particular that we do not move to something that is inclusive with regards to financial incentives, because this is a program that we have handed over back to the Ministry of Health, which focused a lot on behavior change. And for them to sustain the program, they did not want a financial incentive that would attach to it, so that they wanted this sustainability with regards to only what we were doing with techniques regarding to behavior change communication. So I think it was very clear from the beginning that we would not be moving towards financial incentives for the program, and we would want to eventually embed this program into COSPEN, where the government was facing certain difficulties that they wanted to actually help solve through our program so that they can sustain the program better, because that's an existing program that they wanted to embed our framework in. Thank you.
Thank you very much, Dr. Kataria. I have another question online for you. I have to read it properly. Sorry, bright lights.
Sure.
Is there any role for telemedicine in this, or have you noticed that? And if so, what were the challenges or the difficulties encountered?
So again, I think with this perspective to the program, we were mostly focusing on NCD risk prevention. And therefore, the role was basically to utilize community health volunteers as community change agents. We were not involving specialists with regards to doctors or practitioners who were treating NCDs. So it was focusing more on the prevention aspect, and therefore telemedicine was not an aspect that was included as part of the intervention strategy that we were passing through BHP Malaysia. Thank you.
Thank you very much, Dr. Kataria. Do we have questions? Any questions in the room? I don't think so. Okay, I think a round of applause. Thank you. Thank you very much, Dr. Kataria. Okay.
Thank you for having me.
Yeah, thank you very much for joining. We've been long in contact before now. We're now going to have a panel discussion. The first panel discussion of the day, there's two. And this one is on non-communicable diseases, burden and management for Asia. And the team will be, the panel, I should say, will be joining us online. If you bear with us. So the COVID-19 pandemic has brought to light significant shortfalls in primary healthcare infrastructure and organizational systems worldwide. Everybody had to have a good look at themselves, placing a massive burden on health systems. The pandemic has also greatly accelerated innovation in and adoption of digital and artificial intelligence-driven solutions, with the potential to improve the quality of care and its accessibility. During this session, we aim to highlight certain best practice models combating this emergency public health challenge and innovative approaches from countries that have implemented successful digital programs on their health systems of surveillance, prevention and control of NCDs. And if our panel are available yet? They are. I would like to hand over to Dr. Amulya Reddy to introduce the panelists and take this forward. Dr. Amulya Reddy is an NCD, senior NCD advisor for MSF in Holland, and she'll be moderating the session today. Hello, Dr. Amulya. Welcome.
Hello, good morning, everyone, or good afternoon. People are joining from other time zones, but I think mostly good morning, and thank you very much for the opportunity to be here. It's really a privilege to be part of this event, and to, in particular, to be part of this panel, to introduce this panel. So we have a very distinguished group. I will go ahead and introduce everyone, and then they will speak, each speak for 10 to 15 minutes. They'll share their screen and show their slides and give their presentation, and then afterwards we should have some time for a discussion and questions. So to introduce the panel, the first panelist is Dr. Khalida Islam. She is a director of primary healthcare in Bangladesh, now retired, but busier than ever. She's still involved with the Ministry of Health and Family Medicine for health sector program operational plan review, situation analysis, and policy recommendations, among other things. Her experience in primary healthcare system strengthening to achieve universal health coverage at the national and international level complements her interest in the same. She has also supported strengthening primary healthcare for Rohingya refugees. She has worked with the government of Bangladesh, besides conducting several international assignments in different countries, and worked with international NGOs to support endeavors of the government to strengthen primary health care. She worked as an implementation research facilitator for the WHO TDR program in Ghana, Indonesia, and Sri Lanka. She also continues to contribute to the medical education of the country through needs assessment and policy recommendations for medical graduates and the allied health workforce. So we'll be welcoming her. The second panelist will be Dr. KM Saif-ur-Rahman. He is working on health systems research and evidence synthesis. He's the senior research methodologist of Evidence Synthesis Ireland at the University of Ireland, Galway, and a systematic reviewer for Cochrane, Ireland. He's trained as a physician before starting training in epidemiology, and he has completed his PhD with a focus on NCDs and geriatric epidemiology at the Department of Public Health and Health Systems Graduate School of Medicine at Nagoya University. He has experience in both infectious diseases and chronic disease research in resource-poor settings using quantitative and qualitative methods, and he's a founding member of the Primary Healthcare Research Consortium, the PHCRC. Our third panelist will be Dr. Nalika, you have to forgive me for the pronunciation, Gwanwaradena. She obtained her MBBS from the University of Colombo in 1992. In 2002, she was conferred the MD in Community Medicine. She served the Department of Community Medicine at the University of Colombo for 18 years and worked her way to become the Merit Professor in Community Medicine in 2012. In 2017, she joined the World Health Organization and now serves as the Technical Officer of Non-Communicable Diseases in the WHO Southeast Asia region. Dr. Nalika also has diverse research interests and has over 100 scientific publications in peer-reviewed journals. And our final panelist will be Dr. Mohamed Robert Amin. He is presently the Professor of Medicine, Line Director of Non-Communicable Disease Program, Control Program, Directorate General of Health Services of Bangladesh. He earlier served as in the capacity of Professor of Medicine in Dhaka Medical College. His illustrious career includes having over 140 publications in peer-reviewed journals and being reviewer of many reputed national and international journals, and serving in different capacities at various councils and societies to aid medical research. Dr. Amin is currently serving as the General Secretary of Toxicology Society of Bangladesh and also is Member Secretary of Tropical Disease Research Cell in Dhaka Medical College. He also manages several editorial posts in various journals and is one of the national resource people for evidence-based medicine and practice in Bangladesh. He oversees training programs to tackle many topics: poisoning, malaria, kala-azar, snakebite, asthma, Nipah, rabies, and multiple tropical diseases. Also COVID-19 and NCDs. And so he's quite active in research in many topics. So as I said, we have a very distinguished panel, and we'll go ahead and get started. If Dr. Islam, if you'd like to start, share your screen and present.
Thank you, Dr. Amulaya. Let me share my screen.
Dr. Amulia, if you could slightly adjust your camera because we only see half of your face. If you could pull up the laptop lid, maybe. Thank you.
Is it okay now?
Sorry,
Thank you so much.
Dr. Khalida, please, you can begin. Excuse me. Thank you.
Thank you, Dr. Amalaya. Hello, everyone. Welcome to the presentation addressing non-communicable disease at primary healthcare level, an integrated people-centered approach to achieve universal health coverage. I'll be discussing mostly the philosophical and implementation issues of primary healthcare to address huge burden of non-communicable disease. As all of us, we are aware that about 70% of all deaths worldwide are now from non-communicable diseases, and 3/4 of all non-communicable diseases and about 82% of people who die prematurely are from low and middle income countries. Therefore, to address this huge burden of non-communicable disease, World Health Organization, they developed an action plan for prevention and control of NCD, that is 2013 to 2020, but now it has been extended up to 2030. This global action plan, it helps the member countries to progress the 9 global NCD targets and 25 indicators. And most importantly, it helps to reduce 25% relative reduction in premature mortality by 2025. The global action plan, it has got an appendix, which is a gold mine of knowledge and evidence base, and currently it has been updated in 2017. Currently it has again been updating because to accommodate the new evidences and also the new recommendations. World Health Organization is also developing one implementation roadmap, which is from 2023 to 2030, which advocates people-centered prevention of non-communicable disease and strengthening primary healthcare services. Now, why primary healthcare services and how it evolved? If we look back in 20th century, in the beginning of 20th century, in August 1937, in Bandung, there was a conference organized by the Health Organization of League of Nations on rural hygiene. And from that conference, the global population, they become aware of the health needs of poor rural people of Europe and other countries. And that conference was a milestone which advanced the Almaty conference. And in 1978, in September, the philosophy and practice of primary healthcare was enunciated in Almaty, and it was named as Almaty Declaration. The whole member states, they endorsed this declaration and they focused on providing healthcare, emphasizing primary healthcare modality. And in 2018, again in Astana, the primary healthcare concept was re-emphasized, and it took the countries, the member countries, one step ahead with the guideline of achieving universal health coverage and sustainable development goal. Now, if we would like to look how this NCD service delivery can be achieved through primary healthcare. The evidence, many evidence are there. Evidence shows that primary healthcare concept approach, it leads to improved population health outcome, health system efficiency, and ensures health equity. All the member states, they realized that if they have robust primary healthcare system, it will form the cornerstone of integrated people-centered NCD care. Therefore, the member states of Southeast Asia region, they developed Southeast Asia regional strategy for primary healthcare 2022 to 2030. And the member states, they wanted to address the challenge of achieving universal healthcare and SDG 3.4 through this primary healthcare approach. If we would like to look at what are the strategic actions the primary healthcare strategy advocates, first one is review and update policies, that is essential service package. In many countries, it was not including primary health care, not including non-communicable disease. It was focused mostly on communicable disease and maternal and child health. So we need to update the essential service package to deliver the basic primary health care of non-communicable diseases. Then the essential drug list. Many of the countries, they have their drug list, which was not updated to include non-communicable disease drugs. It needs to be updated. Strategic action 2, that emphasizes on financing. Without finance, without money, it is difficult to provide healthcare, specifically for non-communicable disease. So the action number 2 emphasizes mobilize internal and external resource to address non-communicable diseases. Third point, it is very important for addressing risk factors, especially shared risk factors. That is, the point emphasizes on multi-sectoral collaboration, especially for tobacco control, harmful use of alcohol, unhealthy diet, salt, sugar, sweetened beverages, trans fat, and physical inactivity. The Ministry of Health alone cannot address these risk factors. These are shared with other ministries, so extensive collaboration is required to address these risk factors. And also the social determinants of health, which are taken care of by many different ministries. So strong collaboration among those ministries is important. And another important issue came up, that all the ministry, while they develop their action plan, they should emphasize health in their policies, and they should emphasize whole society approach. The action 4, it emphasizes on continuum of care. We know many Asian countries, the urban primary health care for NCD is not well established yet. I can give the example of Bangladesh, where the urban health care for non-communicable disease is very poor, because it is the shared responsibility between Ministry of Health and Ministry of Local Government. So everybody's business is a business of none. So we need to emphasize on service continuum, and also there is a recommendation that integration of traditional medicine should be there in NCD services. Number 5 is culture of wellness to promote well-being. Being Ministry of Health or workers of Ministry of Health, health workforce, if we focus only on wellness, it will not work. We have to emphasize on well-being as well. And mental health care is very important. Countries like Bangladesh, which doesn't have or have minimum mental health care at primary health care level, we need to increase that service at primary healthcare level. Moreover, we need to have community-based NCD care to promote wellness. And wellness, promoting wellness will come, is strongly correlated with well-being and wellness. The sixth point is community engagement and empowerment. We just listened to Dr. Ishu Kataria, how community engagement, community health volunteers engagement empowers the community, engages the community. So to ensure preventive, promotive, and minimum curative care at community level, we need to have community-based activity, and maybe we can form patient support group, and we have to engage in the urban areas as well, the community. Moreover, communication between community people and NCD care provider is also very important. To support this healthcare service for non-communicable disease, we need multidisciplinary health workforce, and we know the scarcity of health workforce at rural and remote areas. Therefore, it is emphasized that we need to form multidisciplinary team. We need to have task sharing, task shifting approach so that we can cover full array of non-communicable disease services. We need to address their challenges as well. So, and we have to have the strengthened planning, management, quality, and performance of non-communicable service disease service providers. The next action point, it emphasizes on availability of quality essential medicine and other products, access to medicine, and affordability to medicine is essential. We have seen in Bangladesh, out-of-pocket expenditure specifically to buy medicine is around 73%, which cannot be. So we need to ensure continuous medicine supply based on protocol, minimum supply for non-communicable disease to keep the continuum of care continuous. So we have to take initiative in this issue. Supply chain management is very important. Promote local manufacturing company capacity is important, and we have to train the healthcare providers or team members how to handle the supply chain issues. The next point is strengthening quality. If we don't ensure quality of care, people will not be interested. They will not avail the services. So quality of care is important, and we have to establish monitoring system, supportive supervision system, and enable grievance redressal mechanisms so that we can improve our quality of care. The next point is digital technology. Once upon a time, we were using sphygmomanometer, manually operated. Now we shifted on digital blood pressure machine, and many other technologies are coming up. We have to accommodate and adapt to those technologies, and we have to make those available for better quality service. And we need to have data capturing mechanism. And the next point emphasizes on strengthening health information system. If we don't have open source data capturing mechanism to share patient-based data as well as population facility-based data, we won't be able to get the picture of how our program is working, how the prevalence of or hypertension and diabetes patients are under control. So we need to have a robust health information system. And last point, the strategy, Southeast Asia regional strategy, emphasizing is institutionalizing the learning system, that is documentation of best practices and sharing those best practices so that people can learn, as we are doing today. So if I now how we can implement these strategic actions in our real life activity to address NCD burden. If we start from community level, what can we do? We can emphasize prevention of non-communicable disease risk factors for lifestyle modification advocacy. We can improve the health literacy, behavior change, communication, and process of the community people. We can improve their care-seeking pattern. We can advocate the people who are 30 and above or at high risk group to go to the facility for screening, and also who are under treatment, we can encourage them for follow-up. The health workforce working at the community level. From our health system, we have some frontline health workers. In addition to that, we have community health volunteers. We have multi-purpose health volunteers. We have patient group. We may form patient group. We may form community support group who can involve in this NCD care activities. And at the community level, we need to ensure some care, as for example, regular follow-up of the patient at home, training the care provider and the patient himself how to take care within the home, and we can introduce limited home-based care. In addition to all these activities, we need to engage, empower, involve the community leaders. We can involve the local representative of local government bodies, the other leaders, teachers, the religious leaders. It will help them to own the program, and we have the experience, and we have seen if we can involve them properly, they mobilize resource within the community.
Dr. Islam, I think we have to watch the time.
Okay, I'll be finishing in 1 minute. So at community clinic level, which is closer to the community, we can emphasize this training, follow-up, health education, etc. And at the sub-district level, we can encourage protocol-based training, protocol-based treatment, and ensure supply of drug for them. And at national level, we have to address, as I said, we have to have political commitment, we have to have action plan, policy, financing, ministries coordinated. We have to take our indicators, and we have to ensure the health in all policy. We can also encourage school health, healthy city programs. We need to take evidence-based decision, data capturing and data update, and sharing our lessons learned. We have controlled communicable disease. Now we are struggling with non-communicable disease. We cannot prevent death from non-communicable disease. However, we can reduce the mortality of premature death from non-communicable disease. Thank you so much.
Thank you very much, Dr.
Thank you for allowing me to speak.
Yes, no, we really appreciate the framing of the approach and the outline of the strategy. It's quite comprehensive, as everyone will see the needs and the reasoning behind that actually all of those elements are required. Next, we have Dr. Saif, who will talk about the burden more specifically. So if you'd like to go ahead and share and start, Dr. Saif.
Thank you very much. Thanks to Khalidapa for the nice presentation. And now I'll share my screen and start my presentation. Just please let me know if you face any difficulty either in seeing the screen or either in listening to me.
Fine so far.
We all know about the non-communicable diseases, and this is now causing the highest burden of disease across the globe and in all regions. And mostly we focus on the major 4 non-communicable diseases that are cardiovascular disease, diabetes, chronic respiratory disease, and cancer. But there are other types of non-communicable diseases as well, and especially the most important one in current time is the mental health, that is also is part of non-communicable diseases. There are other neurodegenerative disorders, cognitive impairment, depression, sarcopenia, and frailty, and other things as part of non-communicable diseases. But mostly we focus on the major 4 non-communicable diseases, and their risk factors are quite common. There are some genetic risk factors, environmental risk factors, some socio-demographic risk factors, and factors of related to self-management. Those are tobacco use, alcohol use, inactive daily life or reduced physical activity, and obesity, food choice, etc. And there are some certain medical conditions. Those are also the risk factors for these non-communicable diseases. And importantly, among these 4 major non-communicable diseases, some risk factors, those are shared modifiable risk factors, and those 4 are the tobacco use, unhealthy diets, physical inactivity, and the harmful use of alcohol. And almost 2/3 of the non-communicable diseases deaths related to these 4 major modifiable risk factors. If we look at the different non-communicable disease prevalence in South Asian countries, we can see that the in terms of COPD, the prevalence is 26.7% in Maldives, and another 22.7% in Nepal, and other countries like Bangladesh and Sri Lanka and India are having a higher percentage of COPD. In case of cardiovascular diseases, in Bangladesh, India, Sri Lanka, Bhutan, there are higher percentages of cardiovascular disease incidence, with 26.9% in Nepal, 37.9% in Bhutan, and 28.6% in Bangladesh. And in terms of diabetes, we can see that most of the countries are having a prevalence of diabetes ranging from 7% to 13%, with Afghanistan having 13% and Nepal having 10%. And other countries like Bangladesh is having 11.3%. The prevalence of diabetes are also similar to the hypertension, where Bangladesh is having 39% prevalence among the total population, and in Afghanistan is 46%, and Nepal 23%. Also in India is 31%. So that means overall, all the South Asian countries are having a higher percentage of these major non-communicable diseases. And actually in Southeast Asia region, 8.5 million people are the cause of death for 8.5 million people are non-communicable diseases, and is the 8.5 million deaths in every year. And 48.8% of all deaths are for these NCDs are below the age of 70 years of age, and another 62% of all deaths in this region are due to NCDs. And it is causing the premature death in this region, and that is also responsible for the premature deaths globally. So there are strategies that Dr. Khalida has mentioned some, and also the other presenters, I think they will focus on these. So these strategies for managing NCDs in South Asia. So there are some interventions that are for the prevention at the population level. For example, the control of tobacco use, the reduced salt intake and unhealthy food, and promotion of physical activities. The NCD prevention policies, implementation and adaptation of the WHO Best Buy interventions are very much effective and are being implemented in South Asian countries. And the engagement of the community health workers that may play a vital role in NCD prevention and management. And also there should be an effective physical activities promotion policy And the multi-component intervention strategies for control of hypertension are available in some rural areas and infrastructures in South Asian countries. And there should be some active interprofessional collaboration to manage these diseases, and also there should be some integrated approach for managing non-communicable diseases in South Asia. And among these strategies, there should be some more initiatives. For example, the tobacco control. I can just give one example. We all know that in these South Asian countries, almost every year, we raise the taxation for tobacco. But I don't know how much effective is that, because in reality, when we can see that some countries are increasing the price for tobacco, maybe just by 1 or 2 unit of single, for example, taka or rupee per sticks. So actually that is also within the buying capacity of people. So they are habituated with this rise of price. Rather than the strategy should be like this, there should be no selling of the single sticks. Rather than they should be bound to buy the full packets, so that it will make the people hesitant whether they will go for that or not. So these are some sort of strategies that could be think of for the successful implementation of this reduced tobacco use or other harmful use of alcohol, etc. And among the other strategies, there should be strong national policies and plans for the prevention and control of non-communicable diseases. And the overall, in the Southeast Asia region, the salt intake is higher than the WHO recommended intake, daily intake amount. So there should be strategies on preventing or reducing the mean salt intake among this population of this region. And some interventions are really cost effective, as I mentioned, some on tobacco taxation or salt reduction, food labeling, and food advertising regulations. So these should be monitored strongly so that they are being implemented, and people are encouraged to reduce the harmful use of these substances, including the unhealthy food. And in some cases, for the primary and secondary prevention, sometimes some drug therapies are effective, but the lifestyle modification, healthy lifestyle, and non-pharmacological interventions are also very much important in managing or preventing the non-communicable diseases. And there are the current management plan across South Asian countries, which are almost common in many of the countries. The non-communicable disease NCD-related policies was introduced in Bangladesh, aligned with the World Health Organization's action plan that Dr. Khaleda mentioned, which the action plan was from 2013 to 2020. It's part of the global strategy for preventing of non-communicable disease, and also these were implemented in Bhutan and Sri Lanka, and in Afghanistan, Bangladesh, Nepal, and Pakistan in relation to the World Health Organization's best by guidelines for the prevention of non-communicable diseases, and these programs are being implemented and are followed in these countries. And overall, for the tackling of non-communicable disease in South Asia, there are central implementation from the global level by the WHO or other UN organizations, and they're working on designing the national policies and plan, and they're supporting and encouraging the research for non-communicable disease prevention and control, monitoring the non-communicable disease prevention program, and supporting national international partnership for NCD prevention and control. And here one thing is important, that the NCD related research should be encouraged, because yes, there are a lot many researchers in high income countries, but in low and middle income countries, there is scarcity of research, especially in the South Asian countries. And if you look at the research activities in this region, we'll see that yes, there are some research activities in India and some in Bangladesh, and also other countries are doing NCD related research nowadays, but still there's a huge research gap, and we should fill that gap by conducting more research in these areas. And the other activities at country level, there should be improved budgetary allocation to support the primary healthcare system, and engaging non-governmental organizations, NGOs, research institutions, and private sectors with collaborative partnership and interprofessional collaboration is important for implementation of research activities and NCD prevention activities and all other activities against the NCDs. And there should be the developed continuous quality improvement system focusing on the quality of care based on the primary healthcare prevention and management of NCDs. And also there are some activities related to the society level and also at individual level by following healthy lifestyle and healthy food habit and promotion of physical activities and other things and so on. If we talk about the quality of care of service deliveries in South Asia, actually, as I do the evidence synthesis and evidence mining, so we explored this in South Asian countries. But as I mentioned, there is huge research gap, and we didn't get that much studies on quality of care. However, we have found some studies conducted in the South Asian region, and that highlighted that the quality of care can be improved by providing community-based care and clinic-based screening and NCD care education and other NCD specialized hospital or NCD corners. So this may improve the quality of care, and also the use of technologies such as mobile-based screening that can be also be effective for improving the quality of care. And if we can provide some sort of strategies to reduce the waiting time or make the services more user-friendly, that also improve the quality of care in NCD service deliveries. And the very few evidence of the effective initiatives for improving quality of care that should be actually enhanced and scaled up across the South Asian countries, because the setting is almost similar. So in the evidence that we have, the important interventions that are already providing the proof of improving quality of care should be implemented or can be implemented in other countries or scaled up within those countries. And screening and early detection and regular checkup is always very much helpful. And also we conducted another evidence synthesis on the cost effectiveness of population-based screening of diabetes and hypertension in low and middle income countries, but some of the included studies were from South Asian countries. And actually we have identified that this population-based screening is really cost effective and is really helpful for NCD service delivery. And community health workers, they can be engaged actively in the patient follow-up and health education provision, and there should be some comprehensive education program and booklet, this distribution of booklet and other pamphlets. These are also effective for improving the quality of care. And as I mentioned earlier, that maintaining the patient privacy, confidentiality, and providing adequate time with reduced waiting time, etc. This also improves the quality of care, and it has been evident by the previous studies conducted within this region. And there are also the role of some non-pharmacological interventions. We also conducted some evidence synthesis and systematic reviews on non-pharmacological intervention for prevention of diabetes and for prevention of hypertension. We conducted overall for the low and middle income countries, but we contextualize it based on the evidence on South Asian countries. But very few research are on South Asian countries, and maybe a couple of studies are only within India. And actually, non-pharmacological interventions are really effective for the prevention of non-communicable disease, especially diabetes, and also maybe cardiovascular diseases, because lifestyle modification plays a very important role in preventing those diseases. But however, there should be more implementation of non-pharmacological intervention, and people should be encouraged. We always say about lifestyle modification and healthy lifestyle and improving physical activity, but actually in reality, it's really difficult to follow this instruction because our lifestyle is becoming sedentary day by day. We are being more engaged in desk work, and that is reducing our physical activities. Somehow our urban lifestyle is making it difficult to follow a healthy diet, but still there should be strategies that can be followed, and there should be more research activities within this region so that we can get the best evidence to be confident what should be implemented at the policy level. And among these non-pharmacological interventions, as we know that these interventions are really helpful in reducing hypertension or even the hypertension within the patient with chronic kidney diseases, and physical exercise, cognitive behavior therapy, some mindfulness based recreational programs such as yoga and other things. These also show benefit in terms of quality of care in cancer patients. And the non-pharmacological interventions that educated the people about some coughing technique and breathing exercise that also was found effective in COPD and some respiratory management of COPD. So my take-home message is we should invest in research. We should conduct evidence synthesis because it reduces the wastage of research, or it doesn't require that much investment on research, so we can know about the available researches, and if there are sufficient research, so we can be able to get a policy recommendation based on the available researches by assessing the certainty of the evidence base that we have. And if there is not enough research, that also can be identified through evidence synthesis, so we can get the idea of research gap, and so that we can plan for new research and new strategies. We should also focus on implementation research, and we should the evidence that we have with the successful implementation of some interventions that can be scaled up and that can be implemented in similar settings within the region in these South Asian countries, among these South Asian countries. And also we should explore the effect of interventions that are effective, that are being proven effective in other countries, and that also can be scaled up or implemented in these countries. So my highest priority will be to invest in research, and we should generate evidence to combat the non-communicable diseases and to improve the quality of care, and in preventing non-communicable diseases and in managing non-communicable diseases in South Asian countries. So thank you very much. That's from my part. So maybe if you have any question, I will try to answer those during the question and answer session. Thank you.
Thank you very much, Dr. Said, for outlining the burden and also the challenges. And I think one of the challenges being the lack of research in the countries. That's definitely something that we've come across as we've tried to work on this in MSF. We'll go ahead and Dr. Nalika, if you want to share your screen and present your. Are you able to unmute?
Okay, a very good morning to all of you, and a big thank you to the organizers for giving me this opportunity. And it feels good to be back at home, even though it's virtual. So my task today actually has been made easy by the previous two speakers, because I take on from where they started on how important the primary care setting and the primary care interventions delivered through primary care to combat NCD burden, and also the evidence synthesis that is shared by with us by Dr. Saif. So I'm specifically going to speak on a set of evidence-based cost-effective interventions that are advocated by the WHO for prevention and control of NCDs, and they're termed best buys. So best buys actually comes from, the term comes from the evidence of cost effectiveness that they have shown when implemented in low and middle income countries. As I show here, for those who understand this health economics better, the indicator that they go by is whether intervention shows an incremental cost effectiveness ratio of 100 international US dollars or less per daily averted when conducted in low and middle income countries. So that's the metrics that they go by. And over the years, WHO has collected evidences from systematic reviews and review these evidence to categorize interventions as best buys. So this happened in 2003, and as Dr. Khalida mentioned, there is another exercise that is going on right now to revise and update the best buys, and this is the publication that you all can access and learn on this better. So basically, in terms of economics, if you think, I started off by saying these are a set of best buys, which are actually population-based interventions mostly, which can be conducted in low and middle income countries with very less cost. In terms of cost, it is shown that you only need an additional 1.27 US dollars per person per year in low and middle income countries to implement all these 15 best buys that are prescribed. So another indicator of what you get out of this, what we call the return on investment, is that every $1 US invested in implementing the WHO best buys will lead a return of at least $7. And it will amount to a 15% reduction in the premature mortality that could be achieved by 2030. As you all know, the premature mortality by attributed to NCDs is one key indicator that we are tracking for SDG progress in countries. Right. So to get on to what these best buys are, actually there are a set of mostly policy options and population-based interventions addressing the risk factors that the previous speakers highlighted. And two of them are actually NCD care services as shown here. So altogether, they are addressing actually 6 areas of either NCD risk factors or NCD management, as shown on my right side. Right, so let's go through each aspect and see what they are trying to understand, how easy or how difficult or how applicable it is for the countries in the Southeast Asia. Firstly, if you look at tobacco use, I'd like to highlight that even for each aspect of each risk factor that these best buys are addressing, all the return on investment also has been calculated for that. So as you see, if you address the best buys related to tobacco use, it is evident that for each $1 US that you spend, you will get a return of $7.43. Right. So what are these interventions? Actually, they are of, we have 5 elements. Firstly, about tax. So it simply says it's about increasing excise taxes and prices and on tobacco products. I fully agree with Dr. Saif when he said, okay, just 1 rupee, 2 rupee, or 2 whatever unit of monetary that we use, increase of tax or increase of price is not going to actually make any difference, because now, though these Best Buys I am showing in very simple terms in a pictorial format, WHO actually specifies the level of tax or the level of price increase that has to be taken on for it to be called Best Buy. So simply, though I show it here in one sentence, how the population-based intervention has to be kind of done in terms to qualify as a Best Buy is very well specified in the document that I have shown you, and you all can access it and have a look. So otherwise, just increasing 1 or 2 rupees here and there is not going to give this return on investment that we are thinking of. So in all, it's about increasing taxes. It's about doing packaging modifications. As you all know, I will show you some examples later. There are different strategies that are prescribed, implementing plain or standardized packages or having graphic designs. So those are the packaging interventions. Then another type of interventions on tobacco tax is about advertising, promoting, and sponsorships, including indirect sponsorships. You all know how this industry is trying to kind of circumvent these interventions by doing indirect sponsorship. So all that is what these indirect sponsorships are and how they should be kind of tackled as a Best Buy. They are all specified well in the interventional documents. Another intervention related to tobacco use is having smoke-free public places. I need not emphasize to you about these effects of second-hand smoking, which is as same as first-hand smoking. So there are a set of interventions prescribed how you handle and make these public places smoke-free. The last type of intervention is public education. The mass media education on tobacco use is also shown to be a Best Buy, but when implemented in a specific pattern, it is prescribed that it has to be done at large scale at national level with very targeted interventions and running continuously for 3 months. That is the kind of public education campaign that we are talking about. When you say education, it's not just showing here and there one TV spot, one radio spot. So for a country to say, yes, we have implemented this Best Buy, there is a set of sub-criteria which is assessed by the WHO to say, okay, whether this country has implemented this intervention to qualify as a Best Buy. So that's about tobacco use. So just to show that how the countries in Southeast Asia are doing. One thing I am happy to say is actually there is a very clear tobacco use reduction in Southeast Asia. The evidence is out now. Among men, the tobacco use, when I say tobacco use, it's smoked and smokeless together, has declined by half from 2000 to 2020, which is a very good sign. And even among women, the decline is very steep from 8.9% to 1.6%. Actually, even the Southeast Asia region also showing a slight decline in the premature mortality due to NCDs, though it is not as steep as what we would have liked to achieve the SDG target, and that also is attributed to this decrease in the tobacco use. So that's good news. And in the 11 Southeast Asia countries, just to show you about the implementation of the Best Buy, 6 have implemented these interventions related to packaging, as I show you on there, right? And also 2 have enforced comprehensive bans on tobacco advertising, promotion, and sponsorship. Moving on to alcohol use, Firstly, just have a note on the return on investment. For tobacco, it was 7 point something. For alcohol, it's more. It's about 9.13. And what are the interventions? Again, in the same lines of tobacco. It's about increasing taxes. It's about banning and the advertising, direct and indirect, and mostly about modifying the availability. Right? So again, I am not going to actually specify, but increasing taxes means to a specified level, and advertising, is specified how much it is done. Availability restriction is something which works very well, which is depicted here. Things like imposing banning on advertising and restricting availability through an age limit, on a different through a time duration on weekends and things like that, and drink driving, all those. Moving on to unhealthy diet, and I want you to make a note that this is the group of Best Buys which is yielding actually the highest return on its investment. If you see, it will yield about $12 per $1 spent. And most of this yield comes from actually salt reduction interventions. We have different interventions here, and salt has the highest evidence and of effectiveness, and all of you know about limiting the dietary salt. Then there are other, connected to that, it is through either reformulation of food or offering the supportive environment where cooked food is served, whether children or the consumers have a choice. It may be through schools, workplaces. Again comes the education package, which has to qualify those criteria that are prescribed, and also about packaging, the front of pack labeling. And if you see some examples, many countries in the Southeast Asia actually have implemented different interventions related to unhealthy diet. Mostly it is about front of pack labeling, informing the consumers, trying to empower them to make good selection, healthy selections. Then again about, same principles of maybe restrictive marketing foods. There are countries which have bans on certain age groups being able to purchase some high calorie or high salty foods and things like that. And trans fatty acid elimination, the industrially produced trans fatty acid elimination is something that we are trying to promote to the Southeast Asian countries very much these days. And there is good evidence that many of the countries are ready to take it up as an intervention. Reducing physical inactivity, right? It is yielding a low return on investment, and actually not many interventions have shown to be cost-effective Best Buy type of intervention to reduce physical inactivity, other than implementing a national level public education campaigns, which is actually has been taken up by all countries, but to qualify as a national level, and as what we discussed as having fulfilling all these criteria, there are 6 countries, at national level, whether they take it on as a challenge and with policies and with national level implementation, whether they take on these physical activity promotion campaigns for public. Right, so those were the interventions that were addressing the NCD risk factors, but there are 2 which are also clinical type of interventions. And as Dr. Khalida mentions, both of these are things which we can do through primary care. So that is one thing that I need to emphasize. So the assessment is whether a country would do drug therapy and also counseling to CVD and diabetic patients through primary care. And these are the qualifiers that will qualify a country as implementing it as a Best Buy. And I'm happy to say, there are lots of guidance out there from WHO on how people should be taking it on, and several countries which have already taken it on. Cervical cancer is something which has a lot of evidence that as being able to prevent And if the public health interventions, there are vaccination with the HPV vaccine and also screening. And again, 5 countries in the Southeast Asia actually have taken on it at national level. So all in all, what we discussed was a brief introduction to the best buy interventions, the 15 as I show. But one point I want to make here is that these are not the only interventions that are prescribed for the countries. These are only the best buys. And how is one qualifying to be a best buy is through systematic reviews and availability of evidence. So unless you have published evidence on cost effectiveness, we have no way of qualifying it as a best buy. Having said that, WHO also recommends so many other sets of interventions which are not called best buys but are called effective interventions and others. So for all these areas, there are a list of other interventions also which can be implemented by countries based on their national context to combat the NCD burden that we all face. So thank you very much. I'll be available to take questions later.
Thank you very much, Dr. Nalika, for outlining the best buys and again reminding us how things can be implemented at primary healthcare level with evidence-based interventions. I think Professor Robert, are you able to join?
Yeah, thank you very much. I think I had to join through the mobile phone because there's some problem with the electricity right now. It's going.
Okay, thank you very much. Okay, I think we can share your slides if you're able to use the phone, and then I think we do have to keep this quick so that because we have about 15 minutes left. Thank you.
Thank you very much. First of all, thank you, organizer, the MSF Scientific Days and ICM 22 to invite me for such a wonderful seminar that we are actually attending. So I'm going to try to say something about the NCD management model in Bangladesh. I think there has been a wonderful lecture that we are receiving from the different panelists concentrating on the NCD and get to know about the hypothetical issues and other things. So from the point of the Director General Health Services as that become the line director of the NCDC, I will try to focusing on mainly what we are actually doing in Bangladesh relating to the management of the NCD, especially on the public health sectors. So that's we call it as the NCD management model in Bangladesh. So I'm requesting the organizer, can you show us the screen, please, so that we can also proceed. Whenever I will see the next, can you just switch us over one? Can we start with the first slide, please? I think this lecture is going to be showing you the NCD burden in Bangladesh. I will say something about that one. What government has taken the initiative to address the NCD at the primary health.
I think you've gone on mute.
Yeah.
The phone.
Okay, are you listening right now?
Yes, it's back.
Okay, so I'll be asking to just start the.
I think it's gone back on mute again. I don't know if that's. With the
is it okay right now?
Yes, it's back.
Okay. I'm really sorry for this one, but can you just show me the screen so that I can just tell when to switch us over? So this is going to be a lecture which is basically have some objectives.
It's switched back onto mute. Now it's back.
And also the government initiatives of the Bangladesh to address the NCD at the primary healthcare level, the innovative approaches and the success stories, and also the addressing the challenges of South Asian countries. I'm not actually seeing the slides in my screen.
Yeah.
Are you all seeing the screen on this slide? I'm not seeing that one in my mobile phone.
I can see the slides on a smaller view. Is it possible to make that larger so that you can see?
audience online can see the slides as well.
Okay, okay.
Or offline, I mean, in the room.
Now we can see, okay.
Okay, thank you. The next one, please. The next one, please. Next one. So you can see that in Bangladesh, the biggest problem is the mortality issue is the NCD. It's around 67% of the mortality of NCD due to the NCD happens. And among them, 30% is due to cardiovascular diseases. We have a death mortality of the cancer around 12%. For the COPD is around 10%. For directly linked to the part of diabetes is around 3% mortality. So if you can add the injury-related death of 7%, I think it will be around 74%. The big problem is that if you have got to know the number, it's around 240,000 people dies in every year due to the cardiovascular diseases. And interestingly, about the trans fat, we all know it is very harmful. And also it has been said that
I think we've lost your sound again, but it doesn't look like you're on mute. That might be the connection. I'm really sorry. It looks like we may have lost Professor.
While we're trying to get Professor Robert back, can we think if you have any questions for any of the panelists from the room? Don't be shy. These are experts and you get to ask them directly.
Hello.
Please. Welcome
Hello.
back.
I'm sorry. So what I was actually telling about the number of the mortality issues in our country is very high, and directly linked to the part of trans fat death is around 6,000. We have around 21% of the prevalence of hypertension. Interestingly, 50% of them does not have any awareness of their activity of the hypertension. Even they were aware, around 47% doesn't know how to control it. Even though somebody was treated, the control rate is very poor. The national control rate hypertension is only 30%. Relating to the risk factor issue, I would say that we had a very, unfortunately, fruits and vegetable consumption of 5 servings has not been practiced around 98% of the population. We have almost about a double of the salt consumption that usually is allocated for us, although the alcohol is not a big issue in Bangladesh. But the physical inactivity has been around 27% in 2010, and right now it is around 15%. Now, our patient have a self-reported diabetes around 6.4. In our step 3 service, we found it becomes raised up into 8.4% in 2018 step 3 service. We also have 31% populations to have a cholesterol in the range of days. Next one, please, the slide. So regarding the global burden disease in the 2016 study report, it says that age standardized mortality of NCD in Bangladesh is around 370 per 100,000 population. So death rate for the major NCD means that cancer, CVD, diabetes, and respiratory disease was around 448 per 100,000 population. We have around 171.68 per 100,000 population cardiovascular disease. COPD is in the range of 53.5 per 100,000 population. We have a cancer around 54.98 per 100,000 population and 19.43 per 100,000 population of diabetes. Our prevalence of ischemic heart disease is around 3.4%. Having the stroke is 9 per 100,000 population if it is more than 30 years. We also have shown in our report that the earliest death, I mean the death within the 30 to 70 years is around 22%, which is very high according to me. In a single year, we have cancers in the range of around 150,000 per year. And relating to the cancer issue, I think it's almost same in the surrounding region of the South Asia, as because the breast cancer, the cervical cancer in the female is highest, as well as the lung, as well as the GI tract cancer for the male. In the mental health issue, we have a 16.1% adult populations in Bangladesh is having some sort of the mental health issue, and it is raises up to 18.4% when we are considering about child and adolescent. The common illness is anxiety disorder, depression, and sometimes the schizophrenia. We have a 0.8% autism in our country and the mental retardation in the range of 3.4%. So next one, please. We all know about something about the NCD targets as because we have a poor baseline in 2014, and unfortunately, all the prevalence of hypertension and diabetes increases in our 2018 step 3 survey. So the target need to reshuffle or revise of 2025 according to me, because we have also increases our baseline in the meanwhile. I told you about everything about this numbers issue, but a few other things that we have big problem with obesity in our country. Currently, our overweight group is around 22.6%. And if we consider about the BMI more than 30, it is around 6.7% population in our country is having some obesity in our country. We need to cover around 50% Upajila by 2023 to cover for the 200 Upajila health complexes and 2,000 community clinic as per our concern. And also we need to have availability of drugs. So please, next one, please. So our NCD management model in Bangladesh actually basically have 6 principles with a standardized simplified protocol. You all know that, we need that. We need to have uninterrupted supply of the medicine. And we need to have task shifting and team-based care, patient-centered community-based care, and also information system so that it can be incorporated in a DHIS2. Very pleased to know that we have a national protocol for the management of diabetes and hypertension, which is based on the WHO PAN HEARTS package. For the uninterrupted supply of medicine, Bangladesh government has given the 3 anti-hypertensive drugs for free of cost, 2 anti-diabetic drugs free of cost. And among the anti-hypertensive drugs, there's amlodipine, losartan, potassium, and also the hydrochlorothiazide. In the anti-diabetic groups of the drugs, we have chosen as the first line is the metformin, and second one is the gliclazide. And also, the Bangladesh government is providing the aspirin as well as the rosuvastatin, free of cost of constant supply for every population of Bangladesh. So that's a wonderful thing that we have fulfilled the objectives to carry on the management model. Next one, please. So I'm going to show you how the things are actually going on right now. On the left side of the panel, I'm going to say that we have a wonderful infrastructure in Bangladesh. For every 6,000 population in rural Bangladesh, we have a community clinic. Now, another smaller component is the union. In the union, we have union sub-center. There are 2 kinds of union sub-center. One is the family welfare sub-center as well as the health services sub-center. So family welfare center is being seen by the family welfare assistants as well as family welfare inspector. For the health issues, there are health assistant health inspector, as well as the other members who can go to the household for the activities. For the community clinic, government has given a responsibility to the community healthcare provider, who is very popularly known as the CHCP. Besides this, Bangladesh government has also recruited in 100 Upajila health complexes for multiple health volunteers. So the multi-purpose health volunteers actually has to do a lot of activity on the incentive basis. The harder the work, the more they will pay. The less of the work, the less will they pay. This is the conception. The conception of the community clinic was to creating awareness to the whole society approach that's been said by the Khalada Islam. This is to encourage the lifestyle modification as we are seeing. We need to identify and motivate all adults more than 40 years for measurement of the blood pressure and blood sugar, which will be done in the community clinic and follow-up patient. On the left side of the screen, you can easily see that there's a, this is called courtyard meeting or the Bhutan Boitok, where the people of 40 years and above has been identified, and they are actually asked to go to the community clinic to measure their blood pressure and also the blood glucose. So in the middle, you can see this is the community clinic older versions, then the below is the new version. And this is 2-room-based older version and the 4-room-based community clinic. The community clinic is basically, I told you, the CHCP is the leader over there. Besides this, on the 2 days of a 6-day period of week, health assistant actually assists him. There, the screening happens for the measurement of blood pressure and blood sugar for adults more than 40 years. Health education is being done. After getting the screening for the more than 40 years, they will refer the patient to the Upajila Health Complex in the NCD corner. They will also do the follow-up and also the registration reporting. So on the right side of the picture, you can see the blood glucose is measured in the community clinic, and also the blood pressure measurement is done. And also you can see the flip chart where they actually showing the health education properly to this area. In this one, also the tab has been provided to the community healthcare provider and health assistant, so they can digitalize the process and making the system works very properly rather than the paper-based. Next one, please. So after this one, I would like to show you some of the activities that has been done by the NCDC in the community level. I told you about the Utan Boitok. This is courtyard meeting at different location. Some of them are actually in the house, some of them outside the house. And also there are two groups that is working in the community clinic. One group is known as the community group, another is called the community supporting group, as was told by the Dr. Khalida Islam in her presentation. And they used to do some community supporting group meeting where they actually plan how, when the health education and whole society approach can be applied. Next one, please. These are again a few of the community mobilization picture where you can see the health assistant or the community health worker is showing the pictorials, and also education part is going on. And this is a tea stall where the community mobilization activity is done by the community health workers. A village doctor, you can see the orientation on the right side. Postering is being done. And beside this, in the community clinic, there is a core team approach has been applied, where the core team is formed by means of the Upazila. Even the chairman is visiting the community clinics to see their activities as a part of their routine part. And also in their CG meeting or the community group meeting, many discussion on NCD visa is going on. Next one, please. So you can see after they come to the community clinic, a height and weight measurement is done by the CSCP over here. They can do the health education as properly. You can see a digital blood pressure message is provided by them, by the NCD and other operational plan for the measuring blood pressure, and also the blood glucose measurement is going on. After they make it diagnosis, screen out for the hypertension more than 140/90 or the blood glucose more than 11.1, they make a referral sheet, which is also provided by NCD, so that they can go to the Upazila Health Complex NCD corner. Next one, please. So these are the NCD service that is going on in the community. I told you, beside this, they are also refilling the drugs. Those patient hypertension diabetes already came to their clinic, will also receiving the refilling of the drugs for 1 month duration of time. So, and the monitoring activity is going on. Next one, please. Now, this is the area that I like to show the NCD corner. You can see there is a refurbishment across. We have made it very more cozier. People can have a seat rather than standing a long duration of time. It more refurbishments. The system that we have provided is the one-arm blood pressure machine for initial screening, because it does not need any assistant for any sister or any nurses or any SECMO. Just they have to put in their hand and the blood pressure will be measured. And after that, we actually have their waiting room where the coin is being provided to them, the serial like 02, 03, so that they can go to the problem. Next one, please. So you can see the coziness causes the environment is very entertaining, and also there are 3 groups of people for the team share. One senior nurse is over there, one SECMO is over there, and one doctor is residing in the NCD corner. So what happened that when the blood pressure measurement initially done by means of arm and the digital blood pressure machine, if they think that this patient need to be seen by doctor can immediately see in a one-stop center and also prescribe. So you can see the screening is going on through the one-arm center, then the digital blood pressure machine, the calculating BMI is going on, so also the blood sugar. And when the patient is shifted on the lower side, you can see the doctor is seeing a patient for making a diagnosis and treatment. And there are green books over there. You can see these green books are very valuable right now, because this is called the patient card, where the treatment and the free of drug is being provided. And from the same center of the NCDs, the drug is provided. Next one, please. So you can easily see that the people are actually going to like this beautiful environment that has been created by the Bangladesh government. This is one kind of innovation that we have successfully done it for 200 Upazila health complexes in Bangladesh. In the meanwhile, I like to know that we have 492 Upazila health complex. And so we had to reach the full corner of 492 even after a few years, as because we are targeting to cover the SDG by 2030. Next one, please. And you can also see that the drugs that has been provided here is a free of cost for the one-stop service. And also all the things are actually is recorded in a tab-based phenomena for digitalization. We like to put off our system of the hardware base, as because we found that it is very difficult for a huge number of patients to go for the hardware, hardbook-based entry. That the digitalized or the Android-based service has been very much popularized in our country perspective. And you can see the protocol has been put up in the wall so that the doctors can have an easiness. Next one, please. So what is the good news? The good news is that even before 2020, we do not know how to say that the real-time hypertension or diabetes in our country. But even though the COVID was taking a big hype in our country, we have right now a dashboard where the hypertension and diabetes can be reflected. Now, if within this short period of time, even with the COVID, we have around 1 lakh people have been totally registered in hypertension. And the surprising thing is that we have 55% control rate, which was around only 13% national value. But unfortunately, there are some things that we have a missed visit around 37% cases, and 8% people still doesn't have any blood pressure control. Regarding diabetes mellitus, we have around 48,476 new patients registered because we started late for this diabetes. The good news is that 32% of them actually has less than 200 blood glucose when they are actually in follow-up. In the meanwhile, you will be surprising to know that the blood sugar control in Bangladesh is very poor. I think it's around 8 to 9%. So it's remarkable has been done in the next NCD management model. But there's still again a big problem with the 32% visit, and within the range of 200 to 300 milligram blood glucose, we have around 15% of the population. The challenges, next one please. I think as you came to know that how can we actually came up with our process, we have a problem of the treatment outcome. You know, still 34% does not have returned to their follow-up. Drug availability is a big problem for all of us. You all know that. And the cost of the drug in Bangladesh is actually very high. And government has to pay a huge amount of money to buy these drugs in our country. Unfortunately, we do not have any high quality lab testing facility even in the Upazila health complex and primary health care. And by all of the things, we have a serious amount of scarcity and human resources. But still then there are some way forward. We need to increase the number of the registration, definitely. And we need to also coverage, as because we are covering the only public sector. A huge number of patients goes to the private sector, how to cover them. We need to cover the urban population, as because we do not have any good system. This system is working wonderfully in the rural population rather than urban. And also we need to reduce the missed visit that I'm showing you through an app system where the total automation can help us regarding this regard. So that's all from my point of view. I think this is the NCD management model we are processing in Bangladesh right now. We like to scale it up as quickly as possible to every Upazila health complexes. And we need to set up the tune for the upward referral in the district hospital and medical colleges. And the NCD corner needs to be established in everywhere so that the principle that has been told by all the previous speakers can be scaled up. With the hope that every country can follow these things. Thank you very much from the Bangladesh government, from the NCDC. Thank you all.
Thank you very much, Professor Rohit. I think we have gone a bit long, but we do have one question. Shall I go ahead? We had one question online for Dr. Nalik about what the role of the pharma companies might be, and whether they can develop market access or solutions for improving access. Is that something you could comment on quickly, and then I will try to wrap up.
Thank you. I think the big issue with the drug is that the drug has been well managed. I see in the country like India, where the price of the drug is very low. You see, for the 500 amlodipine, I think it costs us only $1 in India. But for us, it becomes a big problem, because the losartan potassium is very high price here, and also the costing of the drugs in the pharmaceuticals company. The surprising news is that there are a huge number of the pharmaceuticals companies in our country. They're doing a huge amount of business, but they need to sit with our drug administration so that the combination drug, or maybe the program perspective, the policy of the drug, the pricing can be reduced. And also the second issue is the quality of drug. Although there are so many companies out there, there must be some strict regulation where the quality of the drugs and the content of the elements must be highest. There's a lab there in the drug administration in Bangladesh where actually they can see the things. And from the program perspective, we are sending the samples randomly from different locations to identify whether how much percentage of the quality of drug is there. But definitely it's a very big issue. We are working on it. Hopefully the things will be bright in the future.
Thank you very much. Do we have time for other questions or?
Thanks, Amulia. I'm going to ask, are there questions from the audience, please? Please put your hand up so that somebody can bring you a microphone. You can be heard by the online audience. I see a hand up. Yay!
Okay, good. You're saying,
Early in the morning
I
for
really appreciate
everybody. We need to warm up.
it. Is, yeah. It's gotten light here in London and Ireland. But,
Very, very early for you.
yeah, while we're getting the microphone, I just wanted to thank all the presenters because they were really very rich presentations with so many important points that we need to emphasize. And again, I definitely have lots of questions, but let's see if this one is ready. Let's see.
Yeah, I guess this is morning and it's directed to Dr. Nalika. With regards to the best buys, Sri Lanka has achieved, or we have taken off for most of the best buys, other than the trans fatty acids. Has trans fatty acids been eliminated anywhere in Southeast Asia? And if so, how was that success achieved?
Okay, thank you, Shamini. Actually, WHO prescribes a framework called REPLACE, which has different types of interventions for a country to actually eliminate trans fats, specifically the industrially produced trans fat. In 2019, WHO Sri Lanka office supported the Sri Lankan government in doing what we called a landscape analysis. That was a situation analysis on all aspects of this framework and produced a report and with a recommendation to the food unit to bring in a regulation on trans fats.
That's right.
And I'm happy to say that the Ministry of Health has taken it up and the regulation actually is on the way. I think very soon it will be kind of gazetted and implemented. Just a word about how to bring in trans fat elimination actually is very easy. It's mostly because trans fat is something that is not required at all. It is totally harmful for human health. So there is no question can be asked about its elimination. And this replace package
Thank you very much, Dr. Nalika. I think we have to close there, but I'd like to thank Dr. Amulia and her esteemed panel for very, very interesting presentations and discussion. Thank you very much. So for all of us here in the room, we're going to have a tea break, coffee break now. And I'd like to ask you to spare some time during your coffee break, because it's going to be for half an hour, just under half an hour, in fact, 25 minutes. We have to all be back here in the room at 10:30, but the sparing of the time is to look at the posters and presentations on the screens outside the conference hall. The online audience can click the button above the live streaming window on the website to view the posters. And it's another quick reminder for, again, the offline audience to quickly go through the content form, sign and submit it to the registration desk if you have not done so already. So please be back inside this room at 10:30 and have an interesting break as well. Thank you.
At that point, we are 25 miles away.
This is not camp, this is prison. We not go back, because if we go back, it's a big problem.
Stop bombing hospital, stop bombing health workers, stop bombing patients.
We've all been through a very tough period of lockdown. It has a tremendous toll on the mental health. So mental health has been part of the strategy for the medical interventions in this COVID project. COVID is in general considered deadly. There are many people recovering from it, but the general impression in the community is that it is very deadly. So it's very important to support them and also state many examples of recoveries that is happening. The role of the counselors is to educate the patient about what is COVID, to share their experiences, their feelings and fears and anxieties, and also to educate the family members. And during this counseling process, we have educational interactive sessions with the patients through games and video watching.
जैसे 27 पे भी देख रहे हैं कि हाथ पानी से धोना है, ये बहुत ज़रूरी है.
The strongest challenge that we are facing is related to stigma. There is a lot of patients who have already experienced stigma and the family members who are currently experiencing stigma because the patient tested positive. And the counseling process especially involves a lot of eye contact, and with the PPE it's kind of a big shield. It's difficult to portray and connect with the patients. We use a lot of hand gestures. We do this when we kind of feel the pain. The other biggest challenge is the misinformation. It's been a kind of reinforcement for many months for them that this is how it spreads, this is how it happens, and this is how you can protect yourself. And we're trying our best to kind of change a lot of habits and thoughts.
This hospital is very important because we are one of very few facilities providing the secondary healthcare. And for many refugees in the camp, it's the only option to receive care in the intensive care unit or a high dependency unit. We also specialized in non-communicable diseases, which is very unique profile in these settings. Without the hospital in this setting, sooner or later they would die from, you may think, simple disease like diabetes. People shouldn't die because of diabetes. It's treatable. Hypertension, it's treatable. And it's not even that complicated if you manage this properly.
It's a big challenge. The growth is very, very high. There's going to be a need for more support for the NCD program here in terms of human resources and then in terms of drugs, so training to actually sustain that increasing number of patients coming to us. Most of our patients are also affected by hepatitis C. We believe that most likely because they have been neglected for so long back in where they are coming from, and they didn't have access to healthcare. Most likely that was where they contracted hepatitis C. The burden is high. Most of them present very late with a chronic liver disease, cirrhosis, which is very difficult to manage.
Barmada Gori no Hari no Hari, Barmada Basarani Kashila. Tarvo di Kedaya, Huji, Ana Pusha, the Losugi Yobadi. Losugi, Redhoti, Tona, and Moto Sitan, the Bagulio, Bishadar, Kuria, Terlagi. He lay a Kabaguana in night. Zina Chin for a divil Obadi. A Han of Haridan to the other one of them, Dabaja, Datana, in its over a thing where Yanama, the Iron.
We have a huge impact on the host community as well, because Cox's Bazar district is a very interesting area of Bangladesh. It's kind of a distant from the huge metropolis of Dhaka and Chittagong. They don't have easy access to healthcare either.
এখানে আসছি আমাদের এখানে যা আছে সেবা আছে কিন্তু ঠিক না সেখানেও আমরা ঠিকভাবে হয় না যাক এখানে শুনলাম যে এটা এরা বিদেশি সংস্থা, এরা আসছে, এদের ট্রিটমেন্ট খুবই ভালো, লোক উপকৃত হচ্ছে। মুখোমুখি শুনতেছি, লোক বলতেছে, যারা বললো আমার আত্মীয় স্বজন এখানে আসে তারাই বলছে আমাকে।
Hypertension and diabetes are included in the top 5 morbidities here in the area. There were depression, there was stress involved, the post-traumatic stress disorder during the siege. But of course, it can be also associated with diet, the lifestyle, and of course, it can also be genetic. What we tell them during counseling is the compliance of medication, because sometimes the government runs out of medication and it's really difficult to comply with that if you don't have the resources. So we really tell them how important it is and what could be the consequence after which. We also talk about diet, less salt and less fats. We also talk about exercise, healthy lifestyle. I think the patient responded really well because, for example, with some of our patients, they have uncontrolled BP, now they have controlled BP. And of course, they come back here really happy that they feel better. That's only not for hypertensive, but also for diabetic patients.
Nilipoonjua niko na huo ugonjwa, nilienda hospitali, nikapimwa, ikaonekana niko na sukari. Kutoka hapo nikaanza kunywa dawa. Changamoto ni wakati mwingine ninaenda hospitali napata hakuna dawa, alafu nakuja kununua. Hiyo ingine, saa zingine mtu akifanya kazi anasahau masaa ya kunywa dawa.
We were implementing a mentorship project for the healthcare workers. We are now in 11 facilities, and these 11 facilities are seeing up to around 7,000 NCD patients. The healthcare workers have been trained, mentored, and are capable of managing NCD patients on their own.
I am able now to do health education confidently because I'm confident in NCDs and even talking about lifestyle changes and adaptations to patients.
So the idea to establish a community revolving pharmacy arose from the need because the chronic patients require their drugs on a daily basis to keep their conditions under control.
بحس إني لازم أدير بالي على صحتي مشان أولادي، مشان جوزي، مشان أشوف أولادي البعيدين عني. يعني لما صار عمري بال31 سنة صارت لي صدمة قوية، زعلة، غميت وبطلت أشوف بعيوني. ثاني يوم رحت على الدكتور وإنه معي سكري.
يعني هي صار لي يمكن حركة 29 سنة مريضة، وأنا يعني شو بقدر ساعدها بساعدها، ما بقصر معي يعني.
وجينا على لبنان، والله أول فترة أجيب الدواء من جامع عباد الرحمن، بس ما يعطوني أنسولين كافي أشتري على حسابي. والله يدبر لي جوزي مصاري، لو يتدين يجيب لي إياه. بعدين على فترة هيك عرفت في أطباء بلا حدود، رحت سجلت هناك صاروا يعطوني دواء كفايتي.
بكون عندنا السكري على الريق مرتفع، بتكون المشكلة من العشاء، حالك مش مرتاحة، مثل ما قلتي كمان ضعف، تعب، ما انك حلقة قوة.
وأنا بشتغل أوقات بالأسبوع نهار واحد، أوقات نهارين، أوقات ولا شيء، حسب. واخذين اجار بيت احنا كمان يعني غالي شوي. هلا انا بتضايق، بس تشوفني تضايقت بتتضايق هي بتزعل كثير. بحاول اني اعمل حالي ماني متضايق يعني مشان حتى تكون هي مبسوطه. هي دائما فكره هم الأولاد دائما على طول، دائما أنه تعبانة مرضانة. هي كمان بحياتها تعبت معي وما قصرت معي.
أنا مهتمة بصحتي الحمد لله، وكل موعد الدواء بروح بجيبه، وإذا ما كنت قادر بروح جوزي بيجيب لي إياه. بحس إني لازم أدير بالي على صحتي مشان أولادي، مشان جوزي، مشان أشوف أولادي البعيدين عني، يعني مشتهي أشوفهم، حابة أشوفهم وأظل عايش لحتى أشوفهم. وهم أولادي كمان، يا يمه ديري بالك على حالك يا يمه، يعني هم كمان بيحبوني كثير أولادي، حنونين.
كان الواحد بسوريا يشتغل وأموره خير وعنده بيت ووضعه كويس. وين كنت أنت ووين صرت؟ شو صار فيك نتيجة الزعل؟ صرت بوعكة صحية، دخلت المشفى، طلعت معي ضعف بالقلب والتهاب بالكبد. الحمد لله شفيت من التهاب بالكبد ونزيف رئة، صفر ضعف القلب.
أنا أعوذ بالله من قولة أنا يما اللهم صل على سيدنا محمد. أرملي وساكن ببيت، في عندي جيران محترمين. صار عندي نزيف من خشومي زي حنفية فاض خشومي. اجت جارة إلنا ولا هي بتقول هذا ضغط، أخذوني على المستشفى، ضغطك مرتفع يا حجي كثير كثير. ما معيش أشتري الدواء الضغط، ما معيش أشتري دواء سكري. وبعدين ماتت عندي بنت ونفسيتي تعبت بالمرة. بنتي ماتت عمرها 22 سنة، كان معها سرطان، والسرطان كان بكل جسمها. يا رب لك الحمد. لما توفت، لأنها كانت دائما بحضني ودائما عندي، اللهم صل على سيدنا محمد، انجنيت بعدها يما. صرت اتخيلها بالدار تناديني تقول لي يما اعطيني الدواء، يما بدي انام بحضنك، يما بدي اجي عندك. اصير بالليل اقوم ادور عليها بالدار، ادور عليها، يما مرادي ادور عليها. صاروا يقولوا انجنتي اولادي.
هلا أنا جيت على الأردن بسبب إنه أولادي شباب، بدي أحمي أولادي، وخطر على الكل يعني بيتي أنا انهدم هو وعفشه، وجنبي بيت الوالدة وبيت أخي، 4-5 بيوت انهدموا، فما عاد في مجال إنه ما عندي حل إلا الأردن، إنه أجي على الأردن. كل الأحداث اللي صارت معي بسوريا وكذا، هذا التراكم هذا وتفكيري بالوالدة، وما في غيري أنا عم أقوم بالوالدة، أخواتي مو موجودين معي وما عندي بيت كان هون، أدى معي لضعف بصحتي، فاجتني أزمة قلبية. يعني أنا وصلت على المستشفى وقت اجتني أزمة قلبية، الناس أسعفوني بالطريق ووصلت على المستشفى متوفي أنا، فأعطوني إبرة الحياة وشغلوا لي قلبي على الكهرباء لحتى تميت 3 أيام فاقد الوعي.
فالحمد والشكر لله، ناس وصفوني هون قالوا لي في أطباء بيعالجوا وما شاء الله عليهم، قالوا لي يما إذا بدك سري إحنا بنعالجك سري بدون ما حدا يدري، ما شاء الله عليهم، بدك نعالجك زي ما بدك إحنا مستعدين. قلت يما الحمد والشكر لله إنه في ناس زيكو يما. الحمد والشكر لله، وإلهم إني أنا هسه نفسيتي مرتاحة وباخذ علاجي بالشكل الصحيح، والضغط والسكري صار منتظم عندي بالصلاة على النبي، وأحمد الله وأشكره على كل شيء يما.
على العلاج الدعم النفسي عم تلاقاه من الطبيبة، ارتحت شوي نفسيا، يعني ما عاد صار في ضغوطات على صحتي. يعني مع العلاج كمان شيء من الناحية الطبية، كمان مع العلاج عم باخذه بشكل دائم من الأدوية، وفي متابعة صحية يعني من قبل دكاترة ومن قبل الحمد لله. الست الوالدة ما في تروح على العيادة بسبب صحتها، انه مريضة ورجليها صعب انه بيجعوها، صعب تمشي عليهم. الدكاترة بيجوا كل شهر لعندها بشكل منتظم، يعني تاخذ ادوية من الاطباء بالحدود، وبيجي الدكتور بيفحصها الضغط وبيقيس وزنها.
نفسك كيف صار؟
هلا بتمنى بالمستقبل انه ارجع اشوف اخواتي وبقعد افكر فيها، وتجتمع العيلة وترجع هيك، انه هيك كنا بسوريا عايشين على طول نجتمع كل اسبوع، نجتمع انا واخواتي ورحل وما رحل وبسط وضحك والامور هي ترجع. هي انه هي انا فاقدها هلا بسبب انه عم نفكر بالازمه تبعنا، انه ترجع الفرحه هي لنا.
أنا الدكتور رماح عيسى حسن، طبيب في عيادة الأمراض المزمنة في ناحية العباسي. جاي نقدم خدمات الأمراض المزمنة، وبالتحديد مرض الضغط والسكر والربو والغدة الدرقية وأمراض القلب والصرع وحساسية القصبات. طبعا أكثر الأمراض اللي جاي نشوفها يوميا بعيادة الأمراض المزمنة بالعباسي هي أمراض الضغط والسكر. بالتحديد مرض السكر، احنا نعرف انه النظام الغذائي بالفترة الأخيرة بدأ يتغير. الأحداث اللي صارت أيضا أثرت على صحة المرضى وسببت بانتشار عدد أكبر من مرضى السكر بالمنطقة. كذلك الضغط طبعا هو مرض خفي، هواي ناس عندهم ضغط وما يدرون به، فلذلك احنا يعني نقوم بفحص المرضى وعلى بشكل دوري وجاي نشوف اكو مرضى يعني عندهم ضغط اصلا ما مشخص واصلا ما يدري به. بالنسبة للأمراض المزمنة وأكثرها تكون أمراض صامتة بدون أعراض، فضروري أنه يتم الكشف عنها مبكرا عن طريق الفحص الدوري، حتى إذا ما كانت عندك أعراض، حتى إذا ما كان عندك عامل وراثي، لازم تزور المؤسسات الصحية، تشيك الضغط، تشيك السكر بشكل دوري، على الأقل كل سنة أو كل سنتين، خاصة فوق عمر ال 35. طبعا إذا كان الشخص عنده عوامل خطورة مثل السمنة، مثل عنده عامل وراثي أو أمراض أخرى، يفضل يكون الكشف الدوري بوقت مبكر أقل من هذا الوقت.
सारे हॉस्पिटल्स मुझे ये बोल रहे थे कि आपका यहाँ से स्टार्ट नहीं होगा, आप दूसरी जगह जाओ, ऐसे करके वो मुझे खाली एक के बाद दूसरी जगह भेज रहे थे। मुझे ऐसा लगने लगा था कि अब कभी ठीक ही नहीं होना है।
Because of stigma and the discrimination, these patients are not able to get the basic tests also outside.
ये ऐसा टॉपिक है कि लोगों को शायद लगता है कि मैं अपनी बात शायद किसी से बोलूंगी तो शायद मेरी ही बदनामी होगी।
So most of our survivors, they live with their perpetrators on daily basis. People affected by war, conflict and natural calamities still die of preventable diseases.
In MSF Mumbai clinic, we are treating the patients, those who don't have any other treatment option left. They have taken the TB treatment in the public sector, in the private sector, and failed, and then at the end somehow they have reached to MSF.
MSF was founded 50 years back with the belief that everyone should receive the equal medical care irrespective of
Gender, race, religion, creed or political affiliation.
As a TB patient, बहुत सारी चीज़ें दिमाग में आती रहती हैं, कॉन्फिडेंट ख़त्म हो जाता है।
जिस टाइम मैडम मैं यहाँ पे आया था ना, उस टाइम मेरी हालत इतनी डाउन थी ना कि मुझे नो गारंटी करके बता दिया था। टीबी की दवाई जो बाहर इतनी जो महंगी है ना, वो मैं खरीद नहीं पा सकता था। और घर वालों को भी उन्होंने इतना वैसा बताया कि आप कोई डरने की ज़रूरत नहीं है, आप हमारे पास आओ तो आप ठीक हो जाओगे। तो MSF में आने के बाद जो मेरा लाइफ चेंज हो गया 6 महीने के अंदर, ऐसा लगता है कि मैंने सेकंड लाइफ मेरा चालू हो गया मेरा।
Knowing about a project which is sexual and gender-based violence, our biggest challenge is nobody would come up and talk about it. Nobody would come up and say, bar the fact that they need help, just come and talk about it.
उनको खुद को ये भी नहीं पता होता था कि जो मेरा शरीर है, अगर उस पर चोट आ रही है तो उसको इलाज की ज़रूरत है, कि अगर मेरे पति ने पीट दिया तो कोई बात नहीं, ये तो एक घर का मैटर है, घर का मामला है, तो हमें बाहर नहीं बताना है। मेन चीज़ ये है कि उनको कोई सपोर्ट करने वाला नहीं है, तो वो एक धारणा बनी हुई है दिमाग में, हमें भी झेलना है और ऐसे ही रहना है।
So from the time that we speak to them in the community to the time that they reach out to our ASHA worker, that we assure them about the medical confidentiality, they don't have to repeat their trauma. Our goal is to make them understand what is happening with them is not normal, they are not to be blamed, and it is okay to talk about it and seek help.
इसको बुखार आता रहता था, तो मानिए मैंने टेस्ट करवाया तो इन्फेक्शन आया कि इसके इन्फेक्शन की वजह से ऐसा हो रहा है यही सब होते होते काफ़ी कमज़ोर हो गया ये, फिर मुझे पता लगा यहाँ आके कि इसको HIV है।
So Bihar is one of the densely populated states in the eastern part of India, and the total number of PLHA living in this state is around 135,000, and the number of people who are dying because of AIDS and AIDS related complications is more than 2,500.
What we deal in our facility is basically stage 4 advanced HIV patients, and majority of our patients are from rural background.
So MSF felt that there is a need to target this neglected population, people who live with HIV. They are being denied care. People don't want to talk to them, people don't want to touch them, people don't want to listen to them.
So here what we try is not only to give patient the medical care which they need, but also to counsel them, also to counsel their family.
18 दिन में इतना अच्छा होना, एक बहुत सीरियस बच्चे का इतना ठीक हो जाना मेरे लिए बहुत मतलब बड़ी बात है, क्योंकि यहाँ केयर होती है, फैमिली की तरह सब करते हैं, हंसते हैं, खेलते हैं, साथ में बैठते भी हैं कि एहसास नहीं होने देते कि हाँ भाई क्या बीमारी से झूल रहे हैं या क्या बात है।
In 2020 across the world,
MSF treated 29,300 people for sexual violence.
MSF has treated 13,800 of drug-sensitive TB.
63,500 people started on first-line HIV treatment under direct MSF care, while 13,800 were started on second line of HIV treatment.
The satisfaction that you get in treating people who are neglected.
When they come sick and we treat them and they survive,
I think that is the most satisfactory thing.
Our daily work is a mission. It is intensely medical
and intensely personal.
Good morning, ladies and gentlemen. Welcome to the next session of the program. We have 3 speakers lined up for this session. And let me introduce the first speaker, Dr. Chandrika Ponnamperuma, who will be doing a presentation on ischemic heart disease, what is new. Dr. Chandrika Ponnamperuma graduated from Faculty of Medicine, University of Colombo, with second class honors in 1999, and subsequently he was board certified as a consultant cardiologist in 2009. Dr. Ponnamperuma is currently working as a consultant cardiologist attached to the Colombo South Teaching Hospital, and he has a special interest in coronary interventions. On behalf of the organizing committee, let me invite Dr. Ponnamperuma to commence his speech.
Thank you very much for the kind words of introduction, and I've been asked to talk about what are new things in ischemic heart disease. Well, coronary artery disease, we know, have broadly 2 syndromes, acute coronary syndrome and the syndrome which we called chronic stable angina previously. This terminology has changed now since 2019, and we are now calling it chronic coronary syndrome because chronic stable angina is not as stable as we thought it to be. This chronic coronary syndrome includes suspected coronary artery disease and stable angina symptoms, new onset heart failure, LV dysfunction with suspected coronary artery disease, stabilized symptoms less than 1 year after revascularization, asymptomatic revascularization or acute coronary syndromes, asymptomatic or symptomatic more than 1 year after initial diagnosis or revascularization, angina with suspected vasospastic or microvascular disease, and asymptomatic patients with the coronary artery detected at screening. This whole lump is put together and is called chronic coronary syndrome. This is why we changed the terminology, because as patients with previously called chronic stable angina is a wide included a wide spectrum of patients with different risk factor profiles as well as different disease burden where it comes to coronary artery disease. And these patients have intermittent cardiac events. In patients who have a high disease profile, high risk factor profile, the cardiac events are more common. Acute coronary syndromes are more common. And acute coronary syndromes become less after revascularization. Therefore, it is not as stable, and the terminology was changed to chronic coronary syndromes. In the diagnostic workup of acute coronary syndromes, CT coronary angiogram has gained prominence since late. Particularly in the groups which has a low clinical likelihood or low pre-test probability, CT coronary angiogram is the first line investigation. In patients with a high likelihood of having coronary artery disease and in patients whose revascularization is likely, if local expertise is available, non-invasive testing for ischemia such as dobutamine stress echo, stress MRI, then MIBI scans involving technetium-99 are recommended as the first line investigation. And in patients which have a very high clinical likelihood and severe symptoms refractory to medical therapy and having typical angina, invasive coronary angiogram is the first line of investigation. So this change has occurred because in patients with a low likelihood or low pre-test probability of having coronary artery disease, the intention is to find whether there is atherosclerosis or not. So stress tests will not identify atherosclerosis itself. Stress test will identify only hemodynamically significant atherosclerosis, which is causing angina. But it is important to identify atherosclerosis which is not causing ischemia also, because then we can institute lifestyle modifications and treatment of risk factors to prevent progression. Therefore, in patients who have a low likelihood or low pre-test probability, CT coronary angiogram has come as the first line investigation. So CT coronary angiography is preferred when clinical likelihood is low and revascularization is less likely. Non-invasive functional imaging is preferred when clinical likelihood is high and revascularization is likely. Invasive angiogram with invasive functional assessment with fractional flow reserve or this instantaneous wave-free ratio is recommended when clinical probability is very high and revascularization is very likely. So if it's very likely, straight away you can move on to invasive angiogram. This is what we meant by instantaneous wave-free ratio and FFR. That is, during coronary angiography, you put a special wire called the pressure wire into the coronary artery beyond the lesion, and that will measure the pressure beyond the lesion and compare it with the pressure in the catheter that is proximal to the lesion. And there are two ways of doing it. One is fractional flow reserve, where you take it as a ratio of the distal coronary pressure and proximal coronary pressure, and during the test you give adenosine into the coronary artery or as IV infusion to achieve maximum hyperemia, to simulate what is happening during exercise to see whether we can get a pressure ratio. That way you can identify whether the coronary lesion is significant. In instantaneous wave-free ratio, you get the ratio in the wave-free area as seen in the diagram on top to see whether there is a significant, whether the lesion is hemodynamically significant. These measures are recommended if the diameter stenosis on angiography is less than 90%. If it is more than 90%, you can straight away revascularize without assessing this. Exercise ECG is recommended for the assessment of exercise tolerance, symptoms, arrhythmias, blood pressure and heart response and event risk. Exercise ECG may be considered to rule in or rule out coronary artery disease only when non-invasive functional imaging is not available, such as in our setting in most instances. So in medical management, anti-ischemic drugs are the same as before. There's nothing new. Beta blockers, non-dihydropyridine calcium channel blockers, dihydropyridine calcium channel blockers, nitrates, nicorandil, ranelsin and trimetazidine. Those are the same. And then medical management involves anti-ischemic drugs for symptom relief and event prevention. When it comes to event prevention, you can't underemphasize the importance of lifestyle modifications, including diet, exercise and cessation of smoking. Then there's antithrombotic drugs, statins and other lipid-lowering drugs which have evolved, and other interventions which have evolved recently. So antithrombotics are mainly antiplatelets, aspirin and P2Y12 inhibitors, clopidogrel, prasugrel and ticagrelor. And recently oral anticoagulants also have come into the picture, as we will discuss later. So dual antiplatelet therapy is included for 12 months after acute coronary syndromes and 6 months after PCI. However, long-term aspirin beyond 12 months and ticagrelor 60 milligrams twice a day for post-time MI patients more than 1 year in high thrombotic risk patients is recommended, as proven in Pegasus TIMI 54 trial. After PCI, you have to continue dual antiplatelet therapy longer term if the thrombosis risk is high. If the bleeding risk is high and the thrombosis risk is low, dual antiplatelet therapy has to be stopped in 1 to 3 months' time. So far, warfarin and apixaban were checked for treatment in coronary artery disease for secondary prevention, but it showed an unfavorable increased bleeding risk. But since late, rivaroxaban in low dose, 2.5 milligrams twice a day, that is 1/4 of the usual dose, have shown benefit in patients who have high thrombotic risk. So adding low dose rivaroxaban to DAPT, dual antiplatelet therapy, particularly aspirin and clopidogrel, it is not recommended to combine prasugrel or ticagrelor with anticoagulants because the bleeding risk is high. In patients with stabilized acute coronary syndromes have shown to reduce composite of MI, stroke and CV death, increase bleeding but less CV death. Therefore, this is Atlas ACS2 TIMI 51 trial. And in COMPASS trial, it was shown that in stable atherosclerotic disease, adding rivaroxaban to aspirin compared with aspirin alone and rivaroxaban 5 milligrams BD alone is beneficial in reducing thrombotic events. This is the algorithm for ACS patients after PCI. If the bleeding risk is high, you give dual antiplatelet therapy for 1 month or 3 months depending on the severity of the bleeding risk, and continue single antiplatelet therapy long term. On the other hand, if the bleeding risk is low and thrombotic therapy is high, you can go up to 12 months or beyond dual antiplatelet therapy, or you can combine rivaroxaban with low dose rivaroxaban with aspirin. That is for patients who have had acute coronary syndromes without atrial fibrillation. In patients with atrial fibrillation, the default strategy is triple therapy, oral anticoagulant, dual antiplatelet for 1 week, followed by oral anticoagulant plus a single antiplatelet therapy, aspirin or clopidogrel, for 1 year, followed by long-term oral anticoagulants alone. Since recently, we have been combining the oral anticoagulant with an antiplatelet for long-term use. Here, the antiplatelet has been dropped and only oral anticoagulants are continued, and these direct thrombin inhibitors like apixaban, rivaroxaban are preferred over vitamin K antagonists. If the bleeding risk is high, again 1 week of triple therapy, followed by 6 months of dual therapy, oral anticoagulant and single antiplatelet, and beyond that, oral anticoagulant alone. And if the ischemic risk is high, you continue triple therapy up to 1 month, followed by dual therapy until 1 year. After that, continue the oral anticoagulant alone. Then coming to statins, statins should be used irrespective of baseline lipid levels. Statins is the other most important event reduction treatment. LDL cholesterol need to be reduced by 50% and up to 55 milligrams per deciliter. But if the patient has had two vascular events, need not be the same. It could be a stroke and a myocardial infarction. It could be a stroke or an exacerbation and of peripheral vascular disease. If two events have occurred during 2 years, your LDL target comes down to 40. You can add ezetimibe, which is a cholesterol absorption blocking agent, 10 milligrams if target cannot be achieved with statins alone. And recently, PCSK9 inhibitors, evolocumab and alirocumab, has come into the picture. Those are injected subcutaneously. They block the PCSK9 in protein. And it's very effective in reducing LDL cholesterol. It's shown to reduce ischemic events, but there has been no significant mortality benefit as yet. So this is what usually in hepatocytes, the LDL receptors are recirculated. What PCSK9 do is it's produced in the liver cell itself. It goes and binds to the LDL receptor, and the LDL receptor is destructed with the LDL molecule once it's bound to PCSK9. These antibodies, which are given as evolocumab and alirocumab, binds through the LDL receptor and binds to the PCSK9 and prevents the PCSK9 binding to LDL receptor. Therefore, the LDL receptor is recirculated to the surface of the cell where more LDL is taken in and broken down. Therefore, the LDL drops. So, guidelines say for patients at very high risk who do not achieve their goal on a maximum tolerated dose of statin and ezetimibe, a combination with PCSK9 inhibitor is recommended. It's a class 1 indication. So, since late, colchicine has come in a big way. One of our old friends, which has been in use for many years, not for coronary artery disease, as an anti-inflammatory agents for pericarditis, for arthritis and all. And low dose, there are 3 trials since 2013, the LODOCO trial, where low dose colchicine versus placebo in patients with angiographically confirmed coronary artery disease showed that reduced risk to develop acute coronary syndromes, cardiac arrest and ischemic stroke in patients. A small study in 532. The COLCOT trial in 2019 with again 4,745 patients, effectiveness of colchicine preventing MACE following recent MI. So after acute coronary syndromes, they showed that starting as early as after 3 days of the MI. Colchicine 0.5 milligrams daily significantly reduced the risk of cardiovascular death, MI stroke, resuscitated cardiac arrest or urgent hospitalization for unstable angina. Then LODOCO 2 trial, a slightly better trial, with 5,000 odd patients, 5,522, colchicine 0.5 milligrams versus placebo in chronic coronary syndrome patients, not acute coronary syndromes, chronic coronary syndrome patients showed a significant reduction in endpoints. It showed a 31% lower relative risk with hazard ratio of 0.69 in patients receiving colchicine. The results were impressive. Then the question is whom to revascularize. So patients, I'm not in interest of time, I'm not going to detail with this. So if they have symptoms and documented ischemia, they need revascularization. If the lesion is less than 90%, need invasive assessment with FFR or IFR. Stents, we have learned that it's lesser the better. FFR guidance only to hemodynamically significant lesions, drug-eluting balloons instead of stents, bioresorbable scaffolds instead of metal stents are useful. And virtual FFR and virtual PCI, this is computed on non-invasive CT coronary angiography using coronary anatomy and computational fluid dynamics. You can identify the hemodynamically significant lesions on CT and apply PCI on it, so that we can minimize the number of stents used. So what is new in ischemic heart disease? Stable angina replaced by chronic coronary syndromes, exercise ECG as a diagnostic tool limited to resource poor settings, CT coronary angiography and functional stress imaging preferred initial investigation to rule out ischemic heart disease. Fractional flow reserve and instantaneous wave-free ratio has become mandatory at coronary angiography to assess hemodynamic effects of stenosis less than 90% before revascularization. More effective antithrombotic agents and lipid-lowering agents have strengthened event reduction. And we have some good news from an old friend, colchicine. Measures to minimize metal stents in coronaries with use of drug-eluting balloons, bioresorbable scaffolds, and virtual PCI. And PCI in multivessel disease in diabetics and those with syntax score more than 22 has been downgraded, and CABG is preferred in such patients. Thank you very much.
Thank you very much, Dr. Ponnamperuma, with that update on ischemic heart disease. We are a little behind the schedule, so we will move on to the next presentation.
Next presentation is online. It is cellular therapy for hematological disorders by Professor Lalindra Gunaratne. Professor Lalindra Gunaratne is in the Department of Pathology and as a professor and honorary consultant hematologist in the Faculty of Medicine, University of Colombo. He is also the director of the Hematology and Bone Marrow Transplantation Program at Asiri Central Hospital, Colombo, which is pioneered allogenic bone marrow transplantation in Sri Lanka. Dr. Gunaratne has a special interest in hematological malignancies and hematopoietic stem cell transplantation and acquired coagulopathies. He was a former president of the Sri Lanka College of Hematologists and is currently chair of the Specialty Board in Hematology and Transfusion Medicine, Postgraduate Institute of Medicine, Colombo. He is a member of the Scientific Committee of the Asia Pacific Blood and Marrow Transplantation Group. Over to you, sir.
Hello, can you hear me?
Yes, sir, we can hear you.
Thank you so much for the also for the give this presentation. Right, so my topic is cellular therapy for hematological disorders. And when we talk about cellular therapy, what it basically means is that we can transfer cellular material into a patient for medical purposes. And this cellular material can either be autologous, that is from the patient himself or herself, or allogenic, that is from a different person. And these cells can either be stem cells or non-stem cells, and it can also be unicellular or multicellular therapy. So what you mean by unicellular is either stem cell based or non-stem cell based, single type of therapy. Multicellular means that it can be two types of stem cell therapies, or a type of stem cell plus non-stem cell, or two types of non-stem cell based therapies. And if you look at these cells, either they be stem cells or non-stem cells, autologous or allogenic, these cells can be introduced or transferred to the patient as they are, or else you can genetically engineer them or manipulate them in order to get the benefit that you require before transferring them into the patient. If you look at the global market size in cellular therapy today, last year it was about $9.5 billion US, and it is expected to expand to about $23 billion US in 2028. Now, how are these cell therapies administered? Well, it can be done topically, or it can be injectable. It's in the injectable form, in the form of infusions, bioscaffolds, or scaffold-free systems. And the indications, the therapeutic areas in which cellular therapy has been used or is being trialed is in regenerative medicine, in immunotherapy, and in cancer therapy. Most of them are in the early stages of development. However, there are exceptions, and when I mean exceptions, I mean those which are in clinical practice and accepted as standard of care. And in the best practice specific settings would be in things like bone marrow or stem cell transplantation or liver cell transplantation. And there are also some novel approved specific indications like chimeric antigen receptor T cell therapy for conditions like myeloma and for lymphoma, which I will allude to a little later. Now, so basically what I'm trying to provide today is a brief overview of the licensed therapies for hematological disorders. That is basically those which have been approved for regulatory by regulatory authorities for medicinal products. And I'll look at them under two categories. Those are the stem cell based therapies and the non-stem cell based therapies. Stem cell based therapies first, and a rather busy slide, I'm sorry about that, but we have different types of stem cells, and we know stem cells have the potential to regenerate, to self-renew, and to differentiate into different types of cell lines. And the totipotent stem cell is the most immature one and can differentiate into any type of cell, including a placenta. The pluripotent stem cell is the next in terms of potency, and it can also differentiate in any type of cell except for a placenta. Then we have the multipotent stem cells, which are sort of lower down in potency. The example for this would be a hematopoietic stem cell, and then we even have the unipotent stem cells like the dermatocytes. Now, along this continuum of potency towards mature, more specialized cells, these stem cells lose their self-renewable properties and the properties for differentiation. However, this hierarchy can be artificially reversed by doing nuclear programming, and includes the use of transcriptional factors, which can eventually induce pluripotency in any cell type. So if you look at hematopoietic stem cell transplant first, this can be autologous, where the patient's own hematopoietic stem cells are used as treatment, or it can be allogenic, where a donor, another donor, the stem cells can be used. So what is done is that by giving colony stimulating factors, these stem cells are mobilized into the peripheral blood, and it can be collected like this, that is by doing a bone marrow aspirate from the patient, from the posterior spine, or by using apheresis techniques. And you get a bag like this, which is rich in hematopoietic stem cells. Then you would give high doses of chemotherapy and or radiotherapy to the recipient, destroy his entire marrow, and then transfuse these stem cells into the patient, and hopefully they will go and engraft in the patient and give rise to a new bone marrow which is healthy and a new immune system which is healthy. So if you look at the bone marrow transplants, which was started off in 1956, and around about that time, there was a lot of failures at that time of the bone marrow transplants that were done. But then in 1960s, Jean Dosset described the MHC, and then people at that time realized that the HLA of a patient and a donor were very important in the success of bone marrow transplantation. And you can see even here, this is the transplant-related mortality. You can see that it is much higher if there is a mismatch in the HLA than if there is a match in the HLA. So based on that, there are indications for stem cell transplant. What do we use them for? The autologous stem cell transplants can be used in malignancies like myeloma and lymphoma, and in immunological conditions like multiple sclerosis. The allogenic ones, that is from a donor, can be used in malignancies like acute leukemias and aggressive lymphomas, and in non-malignant cases like thalassemia, bone marrow failure like aplastic anemia, and immune deficiency states like combined variable immune deficiency. Now, our experience, we started transplant, and the first one we did was in 2014, an allogenic transplant for bone marrow for a patient with thalassemia major. And most of the transplants we've been doing are in patients with thalassemia. And this is some of the data that we analyzed together with 4 other centers in the region. We looked at 82 patients who had transfusion-dependent thalassemia, and we compared these protocols, the conditioning protocols, which are used to prepare the patient's bone marrow for transplant. And here is the patients whom the protocol we used, and you can see that in patients who have a HLA-matched sibling donor, there's an overall survival of about 94% with a thalassemia-free survival of about 80% at the end of 2 years. Then more recently, we analyzed our own data, and then when we looked at the matched sibling transplants for thalassemia in patients ranging from 18 months to 17 years, we had 100% overall survival with about 85% thalassemia-free survival. If we looked at the matched unrelated donors, so that is donors who are HLA matched but are not from a family member, the overall survival is a little less, and the thalassemia-free survival is round about the same. Now, these allogenic transplants are not without risk. They're very risky, and the main problems are graft rejection, which is about 12% in this cohort of patients. We analyzed about 71 patients from our colleagues in India and our center as well. And then the other major problem is the acute or chronic severe graft versus host disease. We had a transplant-related mortality of about 7%. So because of all this, allogenic transplant is quite a serious, has some quite serious adverse effects. The other indication which we transplant for are bone marrow failure syndromes. And this was a publication in the British Journal of Hematology last year, where we published our first 4 patients, all children with severe bone marrow failure, either inherited or acquired. And, in bone marrow failure, they inevitably don't make it, they die if something is not done for them. And these were some of the outcomes that we were able to publish last year. Now, the other indication, as I mentioned earlier, is for aggressive malignancies. And this is the report of a 37-year-old man who had severe or very bad lymphoma, which was relapsed and refractory. And he was fortunate to have a brother who was an HLA match, and we were able to transplant him. And today, he's back in the Middle East, completely off medication and living a normal life for a transplant which he had over 3 years ago. Now, all these transplants have been with HLA-matched sibling donors, brothers or sisters. However, only about 30% of patients will have a matched sibling donor. What do we do for the rest? So there are donor registries around the world. We use the Indian donor registry most often. And these are called matched, HLA-matched unrelated donors. And this is again a publication of one of our, or some of our early data, where the overall survival and the thalassemia-free survival was 100% at that time. However, as I showed you more recently, both the overall survival and the thalassemia-free survival have dropped to about 85%. Now, for those who do not have even a matched unrelated donor and who have invariably fatal conditions like acute myeloid leukemia, which is relapsed or refractory, then there's inevitable death. What do we do? So, although we understood that HLA was very important, or matching HLA was very important between the donor and the recipient, people have been trying family members as donors with only a 50% or more match, HLA match, and those are called haploidentical hematopoietic stem cell transplants. Now, the problem is because the T cell repertoires of both the donor and the recipient are quite different, there is a very high risk of rejection and a high risk of graft versus host disease with high mortality. However, over the years, many trials have been conducted to come up with the optimal conditioning regimen. And one of the things that have been found is that if you deplete the T cells of the donor, then the risk of or the likelihood of success is much better. And there are various ways in which they have been done. The first one is by depletion of T cells via this instrument, and the second by giving high doses of cyclophosphamide to the donor after the transplant has been done. So after giving the stem cells of the donor to the recipient, you give the recipient high doses of cyclophosphamide, which have shown to inactivate the alloreactive T cells. And this has brought down the cost of haploidentical transplants significantly. And you can see if the European data that this line here, the orange line, the haploidentical transplants have been increasing over the recent years. And if you look at the Asia Pacific region, you can see what a steep climb there is, mainly because of countries like China, where they have had a one-child policy, and there are very few sibling donors available to them. So we performed our first haploidentical transplant a couple of years back. This was a child, again with severe bone marrow failure, and who had ICH due to platelet refractoriness. Platelet count was persistently less than 5. And the donor, the father was the donor. And today, about 2 years after the transplant, she's completely cured. Now, that was about stem cells which were unmanipulated. But more recently, stem cells have been manipulated and then transplanted into patients. For example, in transfusion-dependent thalassemias, gene therapy or gene editing has been performed. So what happens, just like for a stem cell transplant, you collect the stem cells from the patient, and then by either using viral vector-based addition of normal beta or gamma genes, or by editing these genes with the nucleases like CRISPR-Cas9 or zinc finger, which will increase the activity of hemoglobin F. These stem cells are modified genetically, and then they are multiplied, and then a transplant is done. But this is an autologous transplant. So the risk of graft versus host disease and even the risk of rejection is much less. There have been many clinical trials done, and this was a publication in the New England Journal of Medicine earlier this year, which showed very good responses for patients with thalassemia. And the FDA also has looked at it very favorably. So hopefully in the very near future, gene therapy for beta thalassemia will be a reality. Of course, the advantage of gene therapy over doing stem cell transplantation is that there is no risk of graft versus host disease, and there are a few others as well. What about non-stem cell based therapies? These are basically somatic cells isolated from the human body, and they can be either fibroblasts, immune cells like natural killer cells, T cells, and so on, and they are taken up and can be put into the person. So this is just an example of one of them. These are called chimeric antigen receptor T cells, where the patient's own T cells are genetically engineered to express certain molecules on their surface like this, which recognizes the tumor antigens. And then once the T cells are engineered, they are again grown in millions and then introduced back into the patient. And these CAR T cells will now go and destroy the cancer which is in the patient themselves. And this is the first CAR T cell therapy that was given to a patient, Dr. Vasanta Ratnayaka's patient, a child with acute lymphoblastic leukemia. These are the approved CAR T cell therapies, and the indications are like for leukemia, B-cell lymphomas, and for myeloma. And in the future, unlike the autologous CAR T cells, we're looking at being able to give patients CAR T cells off the counter. So in conclusion, stem cell-based and non-stem cell-based cell therapies are currently in clinical use for many hematological disorders. There are many new and exciting modalities of cell therapy in clinical trials. However, the cost and accessibility is a bar for our patients in Sri Lanka. Thank you very much.
Presenter.
Next presentation will be Meeting Endometriosis Head-On, the 1 in 10 Silent Terror by Professor Dhammika Silva. Professor Silva is currently working as a professor in obstetrics and gynecology at the Department of Obstetrics and Gynecology, University of Sri Jayawardhanapura. The professorial unit at Colombo South Teaching Hospital is the premier tertiary care referral center in Sri Lanka. for endometriosis and complex gynecological endoscopy. Professor Dhammika Silva's main interest is in minimal access gynecology. He is also interested in disseminating knowledge on minimal access gynecology among the postgraduate trainees by conducting various workshops, online teaching sessions, and outreach clinics. Over to you, Dhammika.
Thank you very much for that kind introduction. I've been threatened by her not to go even 1 minute over, so I'll try my best. All right. So, this is what we actually hope to see when we go in, right? This is a laparoscopy. This is a beautiful pelvis actually, which we very rarely meet. And there are no additions, everything is nice, very smooth and everything. This is what we really want. But in endometriosis, this is what we see. You can see the whole anatomy distorted. It's nothing normal there. Everything is added, and this causes an immense amount of pain for women. This is another one. If you see. So you see there's, when you go in, there's no anatomy. If you take it or you see the last slide, this is what we see. Now, this is a woman who has very severe endometriosis. What you're going to see on both sides are two rope-like structures. These are the two ureters, which are the ones that take urine from the kidney to the bladder. And she has bilateral obstruction and bilateral hydronephrosis. The kidneys are affected. She presented, and this is very severe endometriosis. She presented to us, and she required ureteric reimplantation. So this is what you see actually. You can see that the ureters are rope-like on both sides. I don't have a pointer here, unfortunately. So the whole endometriosis, what it does is it just crushes the ureters at the end and causes this. So she's going to lose her both kidneys. Luckily, she came to us. One kidney was 14%, other was about at 50%. And now she's fine because I had to do a ureteric reimplantation. This is also a pelvis which we see. You can see the whole pelvis is obliterated. You can see the womb or the uterus there. The bowel is stuck, the ovaries are stuck, everything is stuck, and this causes very, very, very severe pain for these women. This is another one. You can see all red is endometriosis. As you can see, endometriosis is tissue which should be living inside the uterus, is living outside the uterus, which should not be doing. So during the periods, she bleeds outside as well. So it causes an immense lot of problem, lot of agitations, lot of problems, and you can see the whole anatomy is distorted and they live in a world of pain. So my topic, meeting endometriosis head on, actually nothing, medical therapies have not evolved, nanotechnology is evolving, but still the only way we can go about it is just go after them and excise them. Medical therapies, much of them are not actually helpful because the reason is that there are physical changes actually in the pelvis itself, in the anatomy itself, and only for the moment only surgery can sort those out. We cannot cure endometriosis. It is excision and then suppression until she reaches menopause, hopefully. So I just wanted to understand, you all to understand there are so many symptoms, and for you all to recognize the whole problem is there's a huge delay, about 4 to 10 years in the diagnosis. People go to different doctors, different diagnoses are made, and unfortunately sometimes the diagnosis is not made until it's too late. 2 to 10%, that is 1 in 10. As I told you, women will have endometriosis. Infertile women, 50% will not have them. The economic burden all over is huge. Nobody understands that. In Europe, it is 13 billion euros annually, and that is only in Europe, and it's equivalent to diabetes. And all over the world, it is very. So, as I told you, endometriosis is endometriotic tissue living outside the womb, and the symptoms are debilitating, and there is no cure. What do we have? I just quickly go over. There's pelvic pain, 57% of the women. Periods are extremely painful. There's huge amount of pain during intercourse. The bowel openings can be so debilitating, sometimes women do not eat, right? And they're afraid of the bowel movements. And there is huge pain passing urine all the time. Just imagine passing urine and having pain all the time. Backache due to sometimes hydroureter and hydronephrosis. Nerve pain when the nerves are involved. She has pain during those where the nerves supply on, and of course infertility. So all this is a huge burden. This is a ovarian cyst, which you can see, which is the commonest type which we see. On the left side you can see that a large cyst. So what happens is there is bleeding during the periods into the cyst as well, and it causes a huge amount of pain for her during the period. Now this is endometriosis, which is what we call at the end of the vagina or at the near the top of the vagina. This is what is called the uterosacral ligaments. Of course, what happens is when there is sexual intercourse, when the penis hits against these, it becomes extremely careful. So these must be carefully exercised. Right. Now this is a case which I had with severe painful intercourse. What you are seeing is basically the top of the vagina where there's a huge endometriotic nodule which at the moment is being cut off. And so there you can see that there the nodule is being cut off from the vagina. And this is so painful that people do not have intercourse. So you can see that the whole tissue is being cut off, and you can see the clean vagina at the end, and then it is sutured. Now this is bowel endometriosis. Unfortunately, women find this so debilitating. Endometriosis starts to live on the bowel itself, and then it erodes into the muscle, and defecation becomes extremely painful because it becomes stiff. When the rectum expands, it becomes hugely painful, and when they defecate, the pain goes away and they are relieved. I had a patient about few months ago. She became cachexic. She did not eat because she was so afraid to eat because she need to open the bowels. Right. So these are the, you can see this is the rectum which you can see, and you can see the huge endometrial deposit on the rectum itself. So these are treatable. So there you can see the whole deposit, which I'm going to go quickly. This is another one. You can see that the whole rectum is involved with endometriosis, and this is really debilitating. Now, what do we do? Number one, we can shave it off. Right? This is one of the commonest things which we do. You can see over the bowel that this can be shaved off using cold scissors, and then if there are holes made in it, of course, we can put a few stitches on that. This is discoid resection with a linear stapler. So if there's endometriosis on it, as you can see, it has been picked up by a thread, and then a linear stapler is applied, and then the whole endometriosis can be allowed. You can see the linear stapler being applied and the stapler. It has to be understood anyway endometriosis is going to remain to some extent, but we can control it so that they can live their normal life. Now this is the patient which I showed you earlier with bilateral hydroureter hydronephrosis. On the left side you can see that the ureter has been transplanted or reimplanted in the vagina. You can see the ureter, and most of her problems have been sorted. The endometriosis has been maximally excised, after which she is going to go for suppressive therapy. This is a nodule on the bladder, which you can see that what happens is this is a bladder, the nodule is over the bladder, and this causes very severe painful urination when you go there. But this is outside the bladder, so when the bladder stretch, she comes bigger. So what is done is it's excised. You can see that the nodule is being checked, and then I will just force forward it. It can be slowly excised using the laparoscopy. That is how it is excised. Right. Now this woman has severe painful urination. She actually was infertile. What happened was there's a huge nodule living inside the bladder. You can see the nodule there when we do a cystoscopy. So this, of course, every time she urinates, she has severe pain. So if you relate that, this is how using what we call a Collins knife, this is resected away, and then laparoscopically the bladder is opened up, and this nodule is taken. You can see that the nodule is being removed, and then once the whole nodule is taken off, then you can see that the stents are in place inside the bladder, and that is the nodule which is being removed. This woman actually conceived 3 months after the resection of this, and the urination became completely pain-free. Now this is the endometriosis living on the ureter. Right, so these are the ones, luckily, that is not invading into the ureter. So in this case, of course, you can see the endometrial nodule right on the ureter, the ureter is on the right side, you can see it moving also, and then it has to be slowly shaved off so that it is later not going to obstruct the ureter in any way. So this is the, the nodule has been slowly shaved off without disturbing the ureter. Now this is hydroureter. Hydroureter is that the ureter is become, you can see it is like a huge rope. And of course, to save the kidney and the ureter, of course, we will need to reimplant this. And this is because the end where it falls into the bladder is crushed by endometriosis. So this is the process of ureteric reimplantation. Basically, you need to dissect it right up to the place where there is endometriosis, cut the ureter off, and then put it back onto the bladder. This is the ureteric dissection that you are seeing, and you can see how big the. And of course, the gynecologists, we have a pleasure in sometimes of cutting the ureter. You can see the ureter being completely cut, and then it will be stented, and then it will be reimplanted into the bladder. This will save the kidney, and this will, that is the bladder being mobilized. I'm just going to go very fast, and then you will see the end, and finally, you can see the ureter being stitched onto the bladder, and then that is the final sort of view which you can see after ureteric reimplantation. This is also a ureteric reimplantation. Because of this, she has bilateral hydroureteric hydronephrosis. So one of the things that if we diagnose endometriosis, it is essential, absolutely essential, that an ultrasound scan of the kidney is done, because we do not really want to miss hydroureteric hydronephrosis, because that will cause her to lose her kidneys. So I see so many patients where a simple ultrasound scan KUB has not been done and it has been missed, and when they come to us, already the ureters and the bladder kidneys are very much affected. So as you see, this is also a case of endometriosis. You can see at the end there are so many. This is the bladder dissection. The bladder needs to be mobilized down. For the students, you can see we are going into the retropubic space. Okay. And that is the retropubic space. The bladder is mobilized because the ureter becomes a bit short, and then of course it is reimplanted. So this is just the reimplantation which I showed you earlier. So that is a reimplanted ureter into the bladder. This woman suffered a lot. This is due to this is because of sciatic endometriosis. The endometriosis was living on the sciatic nerve, and therefore this needs a lot of dissection right up to the sciatic foramen. You can see the sciatic nerve here. That is the sciatic nerve. This is the initial stages of dissection. So we need to dissect them right up to that. What she was getting is sciatica like, she could not even walk. She needed to be carried to the bed and the toilet. But now she is perfectly fine after this dissection, and she is well controlled. Well, coming to us, this is our center. We were able to establish an international center which is called the South Asian Minimal Access Gynecology and Endometriosis Center. We of course are not dealing only with endometriosis. It is minimal access. We hardly ever do an open surgery now. So anything in gynecology, we are able to, most of them, to do laparoscopically. So this is the premier center in Sri Lanka, and international center. We get referrals from all over Sri Lanka for complex cases, and this is what we do. This also established about 3 years ago. So vision for every woman suffering from endometriosis to receive care at a tertiary care center of excellence, because we should not do less for these women who are suffering so much. We really should not be doing less. Right. So as a center, what we do is we go around the country doing workshops. You can see this is Ambilipitiya, Kahawata, Navalapitiya, and all these centers we have been going before COVID, pre-COVID, to increase or to try and increase the professional capacity of the colleagues and the consultants. And we go there with all the equipment, teach them what to do, and then revisit them for certain things. And this went on for some time. Then the COVID stopped this, and then the restarted again after COVID. Then after about 5 or 6, the last one also Homagama, the fuel crisis hit, and so the last one which we did was about 3 months ago. So, but this is our vision. It is not only to treat patients at our center, but to make sure that we spread this knowledge and spread awareness. So thank you very much for listening. So that would be I think I kept in time, so I'm not under threat now. Yeah, okay.
Thank you very much, Professor Silva, for sharing your expertise with us. Thank you.
We would like to entertain some questions, or we have one online question. Do we have time for this? I would like to invite members of the audience
to ask questions if you're... Yes, we have one question.
Actually, I want to pose this question to Prof. Lalindra Gunaratne. It's on CRISPR knockout stem cells. Just wanted to ask, what do you think is the scope in Sri Lanka? Because I know there's some expertise on that, mainly for thalassemia. Do you think that we might be able to proceed with that option in the future? What is your opinion?
Thanks, Lanka. Can you hear me? Hello, can you hear me?
Yes, we can hear you. Yes, and thank you for an excellent presentation also.
Yeah, so I mean, that's a very pertinent question because, as I said, that thalassemia or the stem cell therapy for thalassemia is, I wouldn't say in its infancy, but hasn't really been approved and is in use all over the world. The CRISPR technology lags a little behind the other, the viral vectors at present, but there was a recent trial which showed some really good outcomes. I'm not sure whether, we will be able to, it'll be cost effective actually to set it up in Sri Lanka. However, like I mentioned in one of the slides, there may be an opportunity for us to send the stem cells to a center, maybe like somewhere like India or China, where they could do the procedure and send the stem cells back to us so that we can do the autologous transplant in Sri Lanka. So I think it's a distinct possibility of offering this to our patients, hopefully in the near future, but I'm not sure whether it will be a financially viable venture to actually start producing these things, because whatever product we produce will have to go into clinical trials and so on, and it will be very costly. But the short answer to your question is yes, it will probably hopefully be available to our patients in the future.
Thank you.
Thank you.
I have one question for Dhammika. Dhammika, I know endometriosis is being frequently diagnosed. What are the well-known kind of more frequently encountered risk factors for endometriosis in a Sri Lankan setting, in our women?
Yeah, thank you for the question. Actually, there is no difference in the recurrence or the incidence of endometriosis compared to Asian or other countries.
Risk factors for Sri Lanka.
Basic risk factor, actually we do not know why it's caused. It is thought that because endometriotic tissue during the periods, during the menses, will fall through the tubes into the pelvic cavity. So about 10% of the women in the reproductive age, because these are the ones who are menstruating, will not have the ability to reject these cells from implanting into the peritoneum. For some reason we do not know. So specifically, there are no risk factors that we can identify specifically, okay, this woman may be at a more risk. So reproductive age is the biggest risk. Right? The whole problem is that it's not diagnosed early.
Thank you, Dhammika.
We have 1 minute left, and we would like to entertain a question from one of the members in the online audience, from Kavindu Tisera. This question is to Professor Lalindra Gunaratne. Are there any clinical trials currently being completed on chimeric antigen receptor T cell therapy, and what are the possible side effects?
Right. So actually, as I mentioned in the talk, chimeric antigen receptor T cell therapy has gone beyond clinical trials, and there are at least 6 products which have been approved by the FDA. So it's gone far beyond clinical trials now, and it's it's part of the armament of treatment in sort of relapsed refractory malignancies like myeloma, lymphoma, and even in acute leukemia. So this is, and I also mentioned that I think there was a patient in Sri Lanka, a child with acute lymphoblastic leukemia, who had CAR T cell therapy. Dr. Vasanta Ratnayaka was the consultant who was looking after this child. So they managed to send the patient's stem cells to a country overseas, I think it was China, where they did the manipulation and sent it back, and the child was given it here. So it's very encouraging to see that this has gone sort of way beyond the actual clinical trials and is in practice now. Thank you.
Thank you very much. Thank you very much, Dr. Kalani. Okay, so for our next session, we're going to move on to the second set of oral presentations. And our speakers will be joining us online. Each presenter will have approximately 20 minutes, and we urge all the presenters to be mindful of the scheduled time. We will take questions after all the presentations are done, and with that we call on our first speaker, who is Ms. Sachini Nemallaratna, and her topic is identical parasite sequences within human index cases of Brugian filariasis and animals, sorry, the light is so bright, in neighbouring areas in Sri Lanka suggest zoonosis. Thank you.
Hello everyone, I'm Sachini Nemallaratna from the University of Jayawardhanapura, Sri Lanka. Today I'll be presenting the findings of one of our studies, identical parasitic sequences within index human cases of Brugian filariasis and animals in neighboring areas in Sri Lanka suggest zoonosis. I worked at the Molecular Genetics Laboratory at the Center for Biotechnology under the supervision of Professor Nisanka De Silva and Dr. Hiruni Harishchandra. Our laboratory mainly focused on vector-borne neglected tropical diseases such as leishmaniasis, dengue, and lymphatic filariasis. There are 20 neglected tropical diseases, and they are prevalent in tropical countries, with some of the countries more than 5 neglected tropical diseases. These diseases are called neglected because they mostly afflict the world's poor and haven't received as much attention as other diseases. An analysis of the number of people afflicted with certain diseases and number of research papers published on those areas sums this up perfectly. As you can see, some of the diseases prevalent in first world countries like diabetes, HIV have received much attention and funding from relevant authorities and scientific communities as reflected by the number of research papers published on those areas. Whereas the understanding of neglected tropical diseases is nowhere close to that, even though the disease burden from these diseases is much higher. Lymphatic filariasis, more commonly known as elephantiasis, is the 5th most prevalent neglected tropical disease, and it affects 863 million people in 47 countries throughout the world. This disease is caused by parasitic nematodes of Branchoftian and Bridgian origin, namely Brucheraria branchofti, Bridgia malai, Bridgia pahangi, and Bridgia timori. These parasites are transmitted via mosquito vectors. Once an infected mosquito bites, the parasite falls onto the skin and enters the host via the puncture left by the mosquito. And this L3 larval stage can migrate into the lymphatic system where they mature into adults. And within the lymphatic system, these adults mate and produce millions of microfilaria which can migrate into the blood vessels during night. And when a mosquito takes the blood meal, these microfilaria migrate into the mosquito where they molt into L1, L2 and finally infective L3 larval stage. And likewise the cycle continues. At the initial phase of this disease, most of the infected people are asymptomatic. And in mild conditions, infected people might have episodes of acute inflammation together in the lymphatic vessels together with symptoms like high temperature, swollen lymph nodes, and shaking chills. And in severe conditions, this infected people can cause disfiguration, like thickening of skin, swelling in calves due to the adults that blocks the lymphatic vasculature. Treatments for lymphatic filariasis entails chemotherapy using diethyl carbamazine citrate, albendazole, and ivermectin. And there are no effective drugs against the adult stages of these parasites. Therefore, bandaging to reduce the edema is also an integrated part in disease management. Hindering the transmission by reducing the vector mosquito population, by destroying their breeding grounds, such as clearance of aquatic vegetation, which is required for Mansonia species mosquitoes to breed, is important in disease control. As well, mass drug administration to risk population is how the disease is controlled at the population level. Lymphatic filariasis has been endemic for many years in 8 districts in Sri Lanka, starting from northwestern to western and southern provinces bordering the western coast of Sri Lanka. The area is well known as filariasis belt. Of the 2 main types of lymphatic filariasis in Sri Lanka, Bridgian filariasis was eliminated from the country in 1969. However, sporadic cases have been reported over the past few years. In this graph, you can see the blue color line represents the number of Bridgian filariasis positive human cases we identified yearly. And the red color line represents the total number of human Bridgian filariasis cases reported so far since Sri Lanka completed the 5 rounds of mass drug administration. As you can see, there is a rising threat. And surveillance activities were not fully conducted during 2020 and 2021 due to COVID-19 pandemic situation in the country. Therefore, the situation might be even more dangerous than seen here. Sri Lanka received the certificate of elimination of Bridgian lymphatic filariasis as a public health problem in 2016 by World Health Organization. However, studies have reported a surge in Bridgian parasites among canine and feline populations in Sri Lanka. This raises the concern whether the increased microfilaremic rates among humans is suggestive of a parasite with zoonotic origin. Other findings such as unresponsiveness of Bridgian rapid test to Bridgian infections and nocturnal subperiodicity also suggest the same. Since there is a huge number of both domestic and stray cats and dogs in Sri Lanka, it is important to identify whether these animals could serve as reservoir host for the reemergence of Burgeian filariasis in order to prevent the reemergence in Sri Lanka, which is what led to this study. So during this study, we molecularly identified and compared the Burgeian filarial parasites we found within animal and human blood samples to see whether there is a similarity. So see whether there is a relationship between these Burgeian parasites in order to find the reason for the reemergence of Burgeian filariasis in Sri Lanka. The ethical approval for the current study was obtained for animal and human subjects respectively. The gold standard for the detection of filarial infections is observing Giemsa stain thick blood smears for parasites. So we obtained human Burgeian filariasis positive blood samples from anti-filariasis campaign headquarters Narahenpeta as confirmed by them from Puttalam, Colombo, Kalutara and Galle districts. And animal blood sampling was done around the most recent human Burgeian filariasis case, and animal blood sampling was done 500 meters radius zone around the most recent human Burgeian filariasis case. And in observing the Giemsa stain thick animal blood smears, we observed both dirophyllarial and Burgeian parasites. Dirophyllarial parasites can be identified with the hook-shaped tail, cephalic space with two distinct nuclei and body nuclei which do not extend to the tail of the tip. And Burgeian parasites can be identified with the anucleated cephalic space, pink color sheath and the terminal and subterminal nuclei. Here this graph shows the number of animals, dogs and cats we found with both dirophyllarial and Burgeian infections. The x-axis represents the type of the animal and y-axis represents the number of animals. Here, as you can see, peach color represents the number of animal blood smears we observed with dirophyllarial and Burgeian co-infections. According to this, 24% of the dogs and 43% of the cats were identified with both dirophyllarial and Burgeian co-infections, and 62% of the dogs and 14% of the cats were identified with dirophyllarial infections. And here, some of the examined animal blood smears didn't have any of the filarial infections. What you can see here is the molecular analysis of Burgeian parasites we found within animal and human blood samples using primers targeting the HHA1 region, which is specific for Burgeian parasites. Here I have done a multiple sequence alignment, and here if the bases are similar in all of the sequences, meaning cat, dog and human samples, the entire row is highlighted in red color, and when the similarity decreases, the color changes from red to white to purple color. As you can see here, most of the rows are colored in red color. So that means the Burgeian parasite we identified here is same in all of the samples, meaning cat, dog and human samples with a similarity of 97%. We know that Brugia malai and Brugia timori is the non-species to infect humans, while Brugia pahangi is the non-species to infect humans. The fact that the parasite we found here is same in all of the samples suggests the possibility of a parasite which has the ability to cross the human-animal barrier. This is worrisome by considering the total number of dogs and cats there are in Sri Lanka. Then we compare these sequences with those found from other lymphatic filariasis endemic districts like Kalutara, Puttalam, Galle and Colombo in Sri Lanka. Here also you can see most of the rows are highlighted in red color, meaning that the parasite we found from Puttalam is same as the one we can find from other lymphatic filariasis endemic districts in Sri Lanka. This shows that this is the reason for the re-emergence of Burgeian filariasis in Sri Lanka. Then we compare the sequences with lab-raised Brugia malai and Brugia pahangi. Here also it showed a close similarity, 97% of the similarity to Brugia malai and 82% of the similarity to Brugia pahangi. Then we compared these sequences with GenBand extracted canine Brugia malai sample from India and field code Brugia timori from Indonesia. Here I have highlighted only the dissimilar bases, and the bases which are not highlighted are same in all of the sequences. As you can see, most of the bases are not highlighted, meaning that they all are similar in all of the sequences. So here we observe 90% of the similarity of the parasite we found in Sri Lanka, Brugia malai, to canine Brugia malai from India, and 82% of the similarity to Brugia timori from Indonesia. This reveals that the zoonosis of these parasites in Sri Lanka. When we're talking about the limitations of the current study, although our studies suggest the zoonosis of Brugian parasites in Sri Lanka, it is difficult to know the direction of transmission. That is, we don't know whether this is transmitted from animals to humans or vice versa, or actively interchangeably transmitted. Then we can't survey all of the animals in this area. Therefore, only an estimation of the disease burden is made here. And during the current study, we have analyzed only a single region. So molecular analysis of many more regions will help to further understand the parasite, as well may provide a lead to the direction of transmission. In summary, our results suggest the zoonosis of filarial parasites in Sri Lanka. This adds a layer of complexity to the disease control, because it is evident that not only humans but also animals should be routinely surveyed in order to get a clear understanding of the disease prevalence within the country. The fact that the parasite we observed in Sri Lanka is similar to the parasite we can observe from other lymphatic filariasis endemic countries suggests the need to conduct similar studies in those countries as well, in order to find the real situation in those countries. Furthermore, like xenomonitoring, animals also should be routinely surveyed in order to get a clear understanding of the disease prevalence in the country. And in conclusion, our study suggests the zoonosis of filarial parasite in Sri Lanka. So always remember that zoonosis is provoked by the imbalances between human, animal, and environmental triad. It is a rising threat. And in some cases, we can't even predict the damage, as was evident during the COVID-19 pandemic situation we just faced. So it is important to be mindful of the risks inherent by this tightly woven web. With that, I come to the end of my presentation, and I would like to thank the people without whom this might not have been possible, all of my supervisors for their guidance throughout the study, especially Dr. Hiruni Harishchandra. She was the one who always behind me throughout the study. Then Professor Nisanka De Silva, Dr. Harendra Mallavarachi, Professor Nilmini Chandrasena, Professor Nilanthi De Silva, and Dr. Michael Kimber. The National Research Council for the financial support, Lahiru Herat, my fiancé, for his support during the fieldwork, staff of Regional Veterinary Office Madampe for their support during animal blood survey, staff of Anti-Filariasis Campaign, especially Director and Ms. Lakmini for providing all of the human Brugian filariasis positive samples and their information, and academic and non-academic staff of Department of Zoology, University of Sri Javardhanapura for their support. And I'm happy to answer any questions you might have. Thank you.
Thank you. I'm going to go from here because it's a bit simpler, I think. Thank you very much. That was really interesting, and a shame to hear that something that was eradicated in '69 is back now. I have two questions online for you.
Yes.
Can climate change be a factor contributing to the increase in waterborne and vector-borne diseases? Excuse me.
Yes. In the case of, thank you for the question. In the case of Brugian filariasis, actually climate matters. As I have shown you, can I share the screen, please? Thank you. Actually, in Sri Lanka, here I have shown, here I have shown filariasis belt. So this belt is mainly due to the climate changes. Yeah, actually Sri Lanka is situated in the monsoon belt. So basically climate is different within monsoon and intermonsoon period. So due to this climate changes and topography, Sri Lanka has several zones, meaning wet, dry and intermediate zones. So in the wet zone, the rainfall is so high, and wet zone is mainly near the southern western area. That means this coastal belt. So rainfall is mainly high, and also the number of human population here is also high. So together, and also the probability of maintaining stagnant water here is also high. So as a result of stagnant water, high population, human population density, together with climate changes, provide an ideal condition for the breeding of the vector mosquitoes, which are vector mosquitoes of this Bridgian filariasis. That is the main reason for the filariasis belt in the western coast of Sri Lanka.
Thank you very much. And another question from online for you is rapid urbanization another factor that has increased human-animal interaction?
Yes, rapid urbanization. Yeah. In the case of, it also can be explained by this graph actually. In compared to other districts, the human population density is higher in this western coastal belt, and also there are huge number of domestic stray and cats, domestic cats and dogs in Sri Lanka now. So as a result of this, as we suggest the zoonotic transmission of Bridgian filariasis in Sri Lanka, there is the probability of transmitting this disease through these undetectable host reservoirs is high. So that may be the reason for the reemergence as well. The interaction of the human animal is also involved in the reemergence of Bridgian filariasis in Sri Lanka.
Thank you very much. We have some questions from the floor as well. Everybody's excited about your topic, which is excellent.
Sachini, good work you have done.
Thank you.
Can I know whether there are any studies that are done with regard to transmission from animals to humans in Indonesia and India? You had compared those samples. Is there any literature for that?
Yes, of course. I'll share the slides here. Actually, not only from India and Indonesia, in Sri Lanka also several studies have been conducted. In India also, some research group has conducted a research on canine filarial infections in a human Bridgia malai endemic area in India. They have molecularly analyzed the canine filarial parasites they found and have compared that with the Bridgian parasites they have found in humans. Here they have used the same primer as we have used, and they have showed that the parasite they have found is genetically closer to Bridgia pahangi. And they have done phylogenetic analysis, and in our case we have compared base by base. Actually, I think it is more specific than the phylogenetic analysis, because we have gone through all the bases base by base, and we have in our case, we suggest that the re-emergent Bridgian parasite in Sri Lanka is more close to Bridgia malai than Bridgia pahangi. And also there are studies have been conducted regarding this in Sri Lanka as well. Dr. Malavarachi and the group has conducted a research, and they have suggested the high rates of zoonotic filarial parasites in dogs and cats, and they have suggested these animals as potential reservoirs for the human filariasis and Brugian filariasis. There they have only they have only analyzed the Brugian parasites within the cats and dogs, and haven't compared those sequences with the human blood samples. But in our case, we have analyzed compared base by base all the Brugian parasites within animals as well humans.
Okay, thank you.
Thank you. Yes, there is one.
Yeah, thank you. Just you concluded saying that the cycle is could be a possibility.
Yes.
Is there? Have you all tested the Culex or any other mosquitoes for the completion of the cycle?
Actually, here I haven't mentioned anything about the mosquitoes. However, we are conducting research on that as well as an extension of this study. I have analyzed many mosquito species in order to see whether they carry these infections and acting as vectors for the re-emergent Brugian filariasis. And there we have identified many mosquito species. And there we found Culex mosquitoes as well, many species of Culex mosquitoes as well. And there we actually analyzed the Brugian parasites we found within those mosquitoes and compared them with these Brugian parasites within humans and animals. There also we found that all of the Brugian parasites within animals, humans and mosquitoes are the same. So it basically give more evidences for the zoonosis of Brugian parasites. As well, we have done the blood meal analysis of those parasites, and there we found both cat, dog and human blood in those mosquitoes. There it give more evidences for the zoonosis of filarial parasite. In the question you asked, actually we detected Brugian parasites in those Culex mosquitoes, but we haven't done the incrimination activities. That means we haven't looked for all of the stages of the parasite. That means in order to be a vector, the parasite, the mosquito must be able to take the parasite and complete the relevant life stages and give it back to a host. That means it must complete all of the life stages that the parasite need to be completed within the mosquito. So in that case, we haven't done such studies yet. However, we have identified the same Brugian parasite in all of those Culex mosquitoes and many more other species as well.
Thank you very much.
Thank you.
Thank you.
Sorry. Thank you very much. I wanted to give you the certificate of appreciation for your very interesting talk. Thank you. I think we would have had more questions there if we had enough time, but anyway, we didn't, so we're sticking to the schedule. I'd like to call on the next speaker for this session, and it's, live again, Dr. Stalbek Alchev, and his presentation is on Cadmej area biomonitoring, a CAB study assessing human. Sorry, I'm struggling with the light. Human, and I've read this many times, exposure to environmental contamination in Cadmej in Kyrgyzstan, and it's a cross-sectional study. So he is the coordinator of the Cadmej area biomonitoring study. He's a Masters of Philosophy and Public Health degree holder from the University of Leeds in the UK, and he has worked with MSF since 2013 on various projects in multiple capacities, such as medical doctor for MSF project on drug-resistant TB in Krasu of Kyrgyzstan, as the project medical referent of the MSF project to combat non-communicable diseases and improve the health of women and children potentially exposed to environmental pollution in Cadmej district of Kyrgyzstan. Dr. Stalbek is with us now, I hope, and ready to present.
Okay. Greetings to all.
Thank you.
Just I request if you can hear me well, can you confirm, please? Hello?
Hello, we
We
can
hear
hear.
you,
We
the
can
ones
hear you.
connected online.
Okay, sorry. Thanks to all for this opportunity to give us a chance to share the results of our study. So today I represent MSF mission in Kyrgyzstan, it's in Central Asia, and I'm as a study coordinator of the Kadamjay area biomonitoring study. So in fact, MSF from 2017 to 2021 conducted series of studies as an environmental health program. So, this my presentation includes only results of the biomonitoring study. This study was conducted in 2021. So I will focus on key points of the study in my presentation, and I hope you will find it interesting. So this presentation includes some background information and methodology of the study, along with the characteristics of the study participants. Also, I will share with you the main findings of the study and comparative results of our study with other population-based studies from different countries. And finally, the study conclusion that we made will end my presentation. MSF, in close collaboration with Kyrgyz Minister of Health and Terragraphics Foundation from the USA, implemented environmental health program in Kadamjay district of Kyrgyzstan in 2017-2021. Within this program, an environmental pollution assessment was carried out, which revealed high levels of arsenic, antimony, and mercury in soil and locally grown vegetables in nearby mining areas of Aydarken, Esme, and Chawai villages of Kadamjay district. This finding in turn led to assessing the vulnerable groups of the local population's exposure to the above mentioned heavy metals. At the same time, there were developed appropriate health interventions with the objective of reducing the exposure of the population to heavy metals detected in the environment. As a result, a biomonitoring study was conducted in these locations to confirm the exposure of the population. Just as a quick information, biomonitoring is a measurement of chemicals or their analytes in the biological substance. So before the CAP study's implementation, an approval was received by the International Review Board of MSF, an ethical review board of the Research and Production Association called Preventive Medicine under the Minister of Health of the Kyrgyz Republic. Then the CAP study was conducted in high-risk areas, including Chawai, Eshme, and Aydarken. Residents from these high-risk areas were recruited for the study. The eligibility requirements considered 14 years old children and 49 years old females at reproductive age who were interested in the study. Initially, we created a list of the interested residents from these areas through organizing information sessions in the street. Then from that list, we randomly selected participants, followed by the informed consent signed. And of course, informed consent forms for children were signed by their parents. And these categories of population were selected due to their higher vulnerability to heavy metal exposure. From these selected participants, we collected blood and urine specimens respecting standard medical procedures. Then the specimens were analyzed in a recognized laboratory in Slovenia called Joseph Stefan Institute to measure levels of heavy metals such as arsenic, cadmium, antimony, mercury, lead, and uranium. And testing results were then evaluated by the relevant specialists to identify when an exposure was above a reference value or when the immediate referral for medical follow-up was required. when conducting this study, based on the WHO recommendation, we assumed a minimum of 240 participants, and given the possible loss of part of the participants, we added 10% to this, which amounted to 264 participants. Thus, this slide shows that 255 residents from 116 households located in the high-risk areas took part in the biomonitoring study. As you can see, we have recruited the required number of participants for the study. Almost half of them were children aged 5 to 14 years, with an equal ratio of boys and girls. Besides, 3/4 of the participants were ethnic Kyrgyz, and almost a quarter of the participants were ethnic Tajiks. As mentioned earlier, we collected blood and urine samples from these participants. In 2 cases, it was not possible to collect blood, and in 1, we were unable to collect urine. All of them were children 5 to 7 years old. However, these 3 cases of failed sample collection cannot affect the outcome of the study. Next slide shows the main findings of the biomonitoring study. 92% of the study participants had levels of at least 1 chemical in either blood or urine that exceeded the reference value. As you can see in the diagram, majority of the elevated levels of heavy metal exposure were associated with antimony, arsenic, uranium, and less cases with cadmium, lead, and mercury. At the same time, the levels of all metals appeared to be highest in the youngest children in the study. For example, the level of blood antimony in children under 10 was almost 3 times higher than levels in adults older than 45. Also, most cases with above reference levels of arsenic were associated with its inorganic forms, which are considered more toxic to the human body. This slide shows that 48 out of the 235 study participants with elevated heavy metals had values above the action level. Majority of these 48 participants with above action levels of heavy metals were associated with antimony, and a few cases with arsenic and mercury. So only these cases needed further clinical and laboratory assessment. At the same time, antimony appears to be the most significant hazard in the community, as levels appear to be 14-30 times higher than population-based reference levels determined from previous biomonitoring studies in North America or Europe. The next slide shows other interesting findings from the biomonitoring study in terms of differences in elevated levels of heavy metals between ethnic groups or between males and females. This study was not designed with a prior consideration of exploring differences in analyte levels among ethnic groups in the high-risk areas of Kadamjay district. However, it was a notable observation that levels of almost all heavy metals were highest in 22% of participants who were ethnic Tajiks. To understand this, we conducted informal post-study interviews with local nurses who knows better these local residents, and identified some of the dietary and traditional characteristics of this ethnic group that may be associated with higher exposure to heavy metals. For example, Tajiks consume more locally grown greens and eggs compared to Kyrgyz, who consume more meat. Also, Tajik women use coal as a cosmetic product, which contains antimony. Another interesting finding was the higher level of cadmium in the blood of girls compared to boys. This finding will inform targeted interventions given the fact that cadmium absorption and toxicity may increase when women of reproductive age lose iron during menstruation. In this slide, you can see a comparison of the 95th percentile of urine antimony exposure in Kadamjay area biomonitoring study compared to population-based studies designed to establish reference levels. So thus, the value of antimony in urine in our study turned out to be significantly higher than in other population-based biomonitoring studies conducted in Germany, Canada, and the USA. Next slide shows a comparison of the 95th percentile of inorganic arsenic exposure as measured by the metabolite dimethyl arsenic acid. As can be seen from this table, the level of dimethyl arsenic acid was also significantly higher than in other studies conducted in Canada and the USA. So to conclude, the results of our biomonitoring study in Kadamjay district suggest that there is significant opportunity to improve health outcomes by reducing exposure to heavy metal contamination in this region, as well as improving the capacity to manage potential heavy metal exposure. Also, these findings will be used to complement previous human health risk assessments and inform the development of community and individual level health promotion activities focused on reducing the burden of disease from long-term exposure to heavy metal contamination in the region. Finally, we are grateful to the local MOH team, the study participants, as well as international and national ethical review boards of MSF and MOH. Thanks to them, the study was conducted properly and achieved its objectives. So these were key points of the biomonitoring study in Kadamjay district that I wanted to share with you. I hope you found it interesting, and many thanks for your attention.
Thank you very much, Dr. Stahlbeck. I'm going to see if there are some questions from within the room for you on this very interesting topic. I don't see any hands up, but I do have one from online. So, are there any changes that need to be made at the policy level by government stakeholders to combat the exposure to these pollutants?
So, since it's quite a new study, this comprehensive exploration of the local context, at this stage, we just shared the results with the local and national level of Minister of Health, and it depends on them for how much this area will be priority for them to work further on this. So at this moment, there's no a policy change, but from our side, based on the results of this study, we already developed a health promotion message and conducted information sessions among the population to reduce the exposure to heavy metals.
Okay, thank you very much. I think there are no further questions for now. I don't see any more. And just for everyone's information, we have between 100 and 150 people online from about 12 different countries. I should have shared that with you earlier. And I will keep you updated as we go through the day. Thank you very much, Dr. Stahlbeck. So,
thanks to all.
Yeah, thank you. So, I'd like to call on our third set of speakers. Two people are going to present together, and that's Mr. Wamik A. Raza and Ms. Ifat Mahmoud. And both of them, their presentation is on climate afflictions. Mr. Wamik A. Raza is a health and nutrition specialist with the World Bank's Health, Nutrition and Population Global Practice in Bangladesh. Before this role, he served as a poverty economist. He's an applied microeconomist with national and international experience in analytical work, program design and implementation across 8 countries in Asia and Sub-Saharan Africa. His thematic experiences include health and nutrition, social protection, and ultra-poverty interventions. He has published peer-reviewed articles in leading journals for the economic and health fields. Mr. Raza holds a master's degree in development economics from the University of Sussex in the UK and a doctorate in health economics from Erasmus University Rotterdam, the Netherlands. And Ms. Ifat Mahmood is a public policy practitioner focusing on human development and a senior operations officer at the World Bank's Health, Nutrition and Population Global Practice. She has more than 16 years of experience in South Asia and Eastern Africa, particularly in Bangladesh, India, Nepal, Pakistan, Tanzania and Uganda, leading project management and policy dialogue with governments and partners. Ms. Mahmood's work includes cross-cutting areas such as climate change, water and sanitation and social protection. She holds a Bachelor of Science degree in Economics and a Master's of Science in Management from the London School of Economics and Political Science. I welcome you both to our conference. Please, I hope you can start.
So much, Rafi, and thank you everyone for connecting. So we'll present the key findings from the report, as Mercy mentioned. To begin, I'll provide an outline of the presentation so you have a sense of what's coming up. In the first segment, we'll provide some contextual background to the report, essentially to say we've done a systematic review of existing literature that is available for the world and research specifically done on Bangladesh, as well as data from a survey that we administered particularly for this work. We'll present some of the key findings from this survey to link the effects of climate change to infectious diseases and mental health issues. We will then summarize the weather data for Bangladesh to show that climate change is not only about storm surges and inundation, but weather patterns have significantly shifted between 1976 to 2019. And finally, we conclude with some policy options. In this report, we provide three main streams of information. First, the climate has considerably changed in Bangladesh, with a 0.5 degrees Celsius increase in temperature between 1976 and 2019. And along with variations in rainfall, we know that the 6 distinct seasons of Bangladesh, according to the Bangla calendar, are getting blurred. Second, there is a direct linkage between climate change and human health. Respiratory illnesses, for example, increase with temperature and humidity, but waterborne illnesses fall with rising temperature and humidity. Similarly, mental health is affected by the weather. In the dry season, for example, people are more depressed compared to monsoon, while at higher humidity levels, both depression and anxiety increases. Third, the 2019 dengue outbreak in Dhaka can be explained by the weather. Of course, lack of measures for mosquito control and cleanliness played a role, but even after considering these, unusually high rainfall in February 2019, followed by high temperature and humidity in the subsequent summer months, assisted in mosquito breeding and consequently disease spread. We will talk about each of these points in detail. I'll pass it on to Wamek to first present key findings of the survey that we got done for Bangladesh.
Thank you, Philippa. Okay, so moving forward. So the new evidence that we present today is derived from a two-round panel data set, which follows about 3,600 households, or about 15,000 individuals across 2 seasons. So the first round of the survey took place at the peak of the monsoon season between August and September, and the latter at the peak of the dry season between January and February. So the data that we present today is representative of Bangladesh, but the sample also allows us to estimate separate figures for urban areas and rural areas. For the urban, we're able to separately tease out, once again, separate estimates for Dhaka and Chattogram city corporations because of the fact that these are so inherently different from the rest of the country. So for this survey, we collected the usual battery of individual household level characteristics and community level characteristics. And we also collected a host of physical and mental illness related issues. So for respondents who fell ill within a stipulated time and they sought care from a medical practitioner, we collected the diagnoses. For those who did not seek care, So we collected a host of symptoms, which we later collaborated with medical professionals to kind of group into three broad categories: waterborne illnesses, vector-borne illnesses, and respiratory issues. So in terms of mental health, we collected data that would allow us to identify the prevalence of depression and anxiety. We use this, we use two well-accepted tools, the PHQ-9 and G87, that have been contextualized for Bangladesh. So first, I'm going to present some summary statistics from what we find in the survey. Overall, when and where matters. So infection rates are about 26% higher during the monsoon season in the country than during the dry seasons. And urban hubs such as Dhaka and Bangladesh, Dhaka and Chattogram, report much higher rates of infection than the national average. So it's about 9% during the monsoon and about 26% during the dry season. So what do we see when we look at the breakdown of the infectious diseases into the three broad categories that I mentioned earlier? Overall, we see that across the seasons, respiratory infections are most prevalent. And within the country, it's most prevalent in the cities, Dhaka and Chattogram. They also report, the two big cities, also report the highest incidences of vector-borne diseases, such as dengue, across the seasons. Now, demographics matter, but we find that there is a strong prevalence or a high prevalence of illnesses which are comparable between the elderly who are above 65 and children under 5, while adolescents report the lowest incidences of illnesses across the seasons. Now, how wealthy you are also makes a difference in the kind of illnesses that you get. For example, vector-borne diseases such as dengue are more prevalent among the poorer segments of the community, whereas the richest are more likely to suffer from respiratory ailments. Now, waterborne diseases, again, among the richest are significantly lower. For example, 9 versus 24% in the dry season. So what do we see for mental health? Now, overall, we see that mental health issues, particularly when it comes to depression, are about 16% higher in the megacities like Dhaka and Chattogram, and whereas anxiety is about 31% higher. The elderly are generally more prone to depression, whereas women, specifically aged between 26 to 40, are more susceptible to depression during the dry season. Next, we run some models to establish the relationship between climate change and infectious diseases and mental health. And as with such models, the results are derived assuming that all of other factors are held constant. And for our more analytically inclined participants, we control for relevant characteristics. You'll find a lot more detail in our reports. So what do we find when we model the relationship between the weather outcomes and infectious diseases? So for respiratory illnesses, we see that it has a positive relationship with rising temperature and humidity. So essentially to translate, if the mean temperature went up by 1 degree, the likelihood of contracting a respiratory infection increases by 5.7 percentage points. If the humidity increases by 1%, it increases the probability of contracting an infectious respiratory disease by 1.5 percentage points. Now, in terms of waterborne illnesses, the relationship is actually the opposite. 1% increase in mean temperature reduces the probability of waterborne illnesses by 4.2 percentage points, whereas for 1% increase in humidity, it goes down by 1.6 percentage points. And lastly, for vector-borne diseases, we see that this, similar to waterborne ones, 1% increase in mean temperature reduces the probability by 1.4 percentage points. We don't find any significant relationship between vector-borne diseases and humidity, at least through our survey. What about mental health issues? Now, when it comes to anxiety, we see that a 1% increase in mean humidity increases anxiety levels by 0.3 percentage points, and 1 degree increase Celsius in temperature increases anxiety rates by 0.8 percentage points. Now, the relationship again with depression and temperature is the opposite. So if temperature increases by 1 degree, it reduces probability of having depression by 1.6 percentage points. So now we segue a little bit into a slightly different topic, and it'll become clear why as we go along. So here we're going to be talking a little bit about what affects mosquito life cycles. And Ifat will elaborate more on this later. But the existing literature suggests that temperature, humidity, and rainfall, if you imagine a triangle, these three kind of play a combined role in the mosquito life cycle. So what are the ideal conditions where dengue-bearing mosquitoes, for example, thrive? So if we consider temperature, the minimum temperature has the most impact on mosquito spreading, and the suitable range is between 18 to 25 degrees. While for maximum temperature, it's between 25 to 35 degrees with the ideal conditions at 32 degrees. Beyond 35, mosquitoes usually start to die out. The ideal humidity is between 60 to 80%, whereas for rainfall, it ranges between 200 to 800 millimeters, but the peak is between 550 and 650. And the prevalence of dengue can begin at the onset and can continue for 3 months. So again, the takeaway is that all three of them have a combined role instead of one-off incidences. So I'm going to pass it back to my colleague to see where we are right now in Bangladesh. Over to you.
Thanks, Wabek. So shifting gears a bit, as I mentioned earlier, there has been a substantial change in the climate in Bangladesh. And it's not just about flooding and tidal surges. Temperatures increased by 0.5 degrees Celsius overall. There are, however, significant variations within the country, as you can see on the map on the right-hand side. If we take the eastern side, for example, which is essentially Chattogram and Sylhet divisions, we see that that area has witnessed the highest temperature increase between this period of time of 0.9 degrees Celsius. The western and southern sides, covering Rangpur, Rajshahi, Khulna, Borishal, for example, experienced between 0.6 and 0.9 degrees Celsius increase in temperature, while the central part, which is Dhaka and surrounding areas, experienced 0.5 degrees Celsius increase in temperature. When we analyzed monthly temperature data covering a longer time period of about 118 years, we see that temperatures increased for all months between 1901 and 2019, with the largest increments recorded for the months of February of 1.9 degrees Celsius, November 1.8 degrees Celsius, and December 1.6 degrees Celsius. So what does this tell us? It essentially tells us that summers are hotter while winters are becoming warmer too. Similarly, if we look at monthly rainfall data between 1901 and 2019, we find that the average rainfall for the peak monsoon months of June and August has actually declined considerably by more than 60 millimeters. But for September and October, average rainfall has increased by more than 40 millimeters. And as we witnessed yesterday in Dhaka, there was rainfall, which is quite unusual for October. So this says monsoon is being extended from March to October, and together with temperature rise that we presented in the last slide, this erratic rainfall pattern indicates that seasonality in Bangladesh is perhaps getting blurred. The rainfall changes are, however, not uniform across the country. We see that the southern part, as circled in the map, has become drier between 1980 and 2019, with average rainfall declining by 35 millimeters. And these are some of the low-lying parts of the country. We did a more granular analysis of Dhaka weather to explore its influence on the 2019 dengue outbreak. As I mentioned initially, climatic conditions played a role. To jog our memories a bit, the 2019 dengue outbreak in Dhaka was rather catastrophic, with 77% of the total dengue-related deaths in the country occurring in Dhaka. Now, to recap what Wamik mentioned about ideal conditions for mosquitoes, as shown on the right side of this slide, maximum temperature in the range of 25 and 35 degrees Celsius, along with rainfall between 200 and 800 millimeters, and humidity in the range of 60 and 80% are conducive to mosquitoes. Now, if we fit the Dhaka weather in 2019 across these criteria, we know that in February 2019, Dhaka recorded 115 millimeters of rain which was the highest ever recorded since 1976. Temperature and humidity in the months of March to July subsequently were within the range that are conducive for mosquitoes. So was this a one-off situation in 2019, or is it becoming a trend for Dhaka? To explore this, let us look through, but also keep in mind that the variables, temperature, humidity, and rainfall, all interplay. We shouldn't take one single variable out. We know maximum temperature in the range of 25 and 35 degrees Celsius are ideal. We plot these two horizontal lines on the screen, along with the line at 32 degrees Celsius when mosquito breeding peaks. Against this, we plot monthly temperature data for Dhaka from 1976 to 2019. And the red curves show the trend for each month across this 44-year period. I'll take a second to review this slide. This clearly indicates Dhaka temperature in the summer months of April to July are well within the suitable range and is increasing, which will aid mosquito breeding and potentially disease transmission. We do a similar exercise for minimum temperature. The horizontal dotted lines at 18 and 25 degrees Celsius indicate the ideal conditions for mosquitoes. And the dots with the red curves, which are the trends, show that temperatures in the months of December, January, and February are increasing and are close to the 18-degree mark. Similarly for rainfall. For the period June to August, rainfall in Dhaka is increasing and well within the range of 200 and 800 millimeters. Finally, humidity, which presents an interesting case. In the summer months of April to July, humidity is falling and is below 80%, but more than 60%, which is ideal for mosquitoes. So in sum, if we consider all of these variables together, temperature, rainfall, and humidity, the trends indicate perhaps Dhaka is more susceptible to future dengue outbreaks. Now, what do these all matter together, all the messages that we've presented today? And I know it's quite a lot. With climate change projected to worsen further, with temperature rise of approximately 1.4 degrees Celsius by 2050, and rainfall by 74 millimeters around 2059 in Bangladesh, the adverse effects on human health will increase. We need to act now to improve data collection systems so that potential disease outbreaks can be predicted using weather data. There is also a need to further strengthen the health systems to have sufficient capacity to deal with outbreaks of climate-sensitive diseases like dengue. And mental health issues on their own are under-addressed. Given the likelihood of depression and anxiety increasing with temperature and humidity, for example, we need to prioritize intervention in this space by raising awareness and facilitating self-help groups. With that food for thought, we end our presentation and invite you to read through the entire series to get more details. Thank you very much.
Thank you both very much. I would like to ask Ms. Mahmood and Mr. Raza, if you're online, if you're available for some questions. And then I would like to ask...
Yes, absolutely. Thank you.
Thank you very much. And then I would like to ask if anybody in the audience would like to ask questions of these presenters. But first of all, I do have an online one for Ms. Mahmood. Is there adequate researched evidence generated to show a link between climate change and health challenges, or is further research needed still? Ms. Mahmood?
Thanks. I was waiting for my colleague Wamik, Dr. Raza, to step in as he led the survey part, but I'll start. Yes, this is, we have sufficient evidence, as Wamik mentioned during his presentation. This survey was based on a representative sample. But of course, as you know, when you're trying to assess effects of climate change, we need data over a longer time horizon. 10 to 15 years. This one we did covering only 1 year, but provides enough evidence to make these preliminary conclusions. Thank you.
Thank you very much. I actually think there are no further questions from the floor, so I'd like to thank you both very much for your time and your presentation. Thank you. And next, our final speaker in this session is Mr. PJ Jude, and he's going to speak about the persistence of Pusilla reticulata, different chlorine levels in Mannar and Jaffna in Sri Lanka, a challenge in Anopheles stevensi control. Mr. P.J. Jude holds a Bachelor of Science and an MPhil degrees from the University of Jaffna, Sri Lanka, and is currently reading for a PhD from the University of Kelaniya. He worked as a research assistant at the University of Jaffna, Sri Lanka for over 12 years. He currently holds the position of Senior Lecturer at the Department of Zoology, the Open University of Sri Lanka. Mr. Jude has published over 50 articles, reports on vector-borne diseases, which include 23 in peer-reviewed international journals. Over the last decade, he has established highly productive research collaborations with other Sri Lankan universities. He's adept and experienced in securing and handling collaborative projects with local universities and conducting workshops, seminars, and lectures. I hand over now to you, Mr. Jude. The floor is yours.
Good morning, Chairperson, ladies and gentlemen. First, I wish to thank for giving opportunity to share my research finding here. My presentation title is Persistence of Pusilla reticulata at different chlorine levels in Mannar and Jaffna, Sri Lanka. A challenge in Anopheles stephensi control. First, introduction. Pusilla reticulata is a biological control agent for medically important mosquito larvae. This species has been used widely to control larval stages of malaria vectors since the inspection of malaria control activities in 1910. One of the main challenges to control malaria in the prevention of reintroduction phase in Sri Lanka is the emergence of new vector species. Reporting of the newly invented urban vector Anopheles stephensi in Sri Lanka, which breeds in wells and containers, has emphasized the need for continuous entomological monitoring. This mosquito species is resistant to available insecticide for adult mosquito control. Therefore, the anti-malaria campaign, which is the focal point for malaria control and management activities, has recommended larval source management. At present, larval source management is mainly done by introducing Pusilla reticulata, which is a larvivorous fish, to wells where the vector breeding is observed. It is observed that the people in the northern province apply chlorine to wells for the cleaning and sanitary purpose often. The effectiveness of larvivorous fish to control the Anopheles stephensi in drinking water sources has become a questionable and controversial aspects that hinder the success of the vector control efforts. Next, objective of my study: to study the survival of Pusilla reticulata to different chlorine concentration used in built wells in Mannar and Jaffna district for Anopheles stephensi control activities. Next, methodology: collection of larvivorous fish. The larvivorous fish species Pusilla reticulata was captured from natural habitats in Mannar and Jaffna districts. They were sorted based on the size. The fish of similar size were safely transferred to the field laboratory at Open University of Jaffna. The fish species that did not meet the above criteria were released back to their original habitats. These are the habitats where the larvivorous fish were collected: wells, ponds, and lakes. This is a sampling site in both district Mannar and Jaffna, especially in Jaffna, Navantura, Kurnagar, and Kolambatra. It is close to coastal area, and in Mannar, the similar Pesala, Erekalampiti, and Darabura, they are also very close to the coastal area. Rearing of larvivorous fish. The fish captured from both districts were introduced separately in 5-liter capacity glass tanks with normal well water. Fish density was maintained at 10 fish in each tank. They were maintained under laboratory care for 7 days for acclimatization before taking to experiment. The fish were fed twice per day with commercially available fish food. Evaluation of the survival at different chlorine concentrations. A concentration gradient of chlorine water from 0.5 to 5 milligram per liter was prepared by dissolving appropriate quantities of commercially available bleaching powder with a purity level of 34% in distilled water. 6 batches of acclimatized 10 Posilia reticulata fish were introduced into each tank, maintaining a 1:1 male-to-female ratio. The behavior and survival of the fish exposed to different chlorine concentration were recorded at 1, 24, and 48 hours interval. The experimental setup was replicated thrice. Controlled trials were conducted with distilled water. The data analysis. The percentage of survival rates of Posilia reticulata exposed to different chlorine levels was calculated for study exposure time intervals separately. The general linear model was used to statistical comparison of the survival rates of Posilia reticulata. Next, results. This graph shows the percentage of survival of Posilia reticulata under 1 hour exposure period. The survival of Posilia reticulata in both Mannar and Jaffna district significantly different chlorine levels at 1 hour, 24 hour, and 48 hours of exposure period. At 1 hour, the lowest survival rate was 53.4 in both Mannar and Jaffna district at 1 milligram per liter, while the survival rate was greater than 80 even at 0.75 milligram per liter. This graph shows the percentage of survival of Posilia reticulata under 24-hour exposure period. At the 24 hours, the mean survival rates of 70% in Jaffna and 81.7% in Mannar were observed at 0.75 milligram per liter. At 48 hours, the fish survived only at 0.75 milligram per liter, indicating a higher survival rate from Mannar, while the fish from Jaffna denoted 70% of survival. Fish captured from both districts had 100% mortality when exposed to water with chlorine concentration above 1 milligram per liter after 24 hours period. This graph shows the percentage of survival of Posilia reticulata under 48 hours exposure period. Next, conclusion. Posilia reticulata used in Mannar and Jaffna in Sri Lanka for mosquito control program can survive at chlorine levels between 0.5 to 0.75 milligram per liter. The fish captured from Mannar district indicated a higher tolerance to chlorine levels. Therefore, it is essential to revisit the effectiveness of using Posilia reticulata as a mosquito control agent, especially at drinking water source treated with chlorine. These are the reference cited to my research article. Finally, acknowledgement. This research was financially supported by National Research Council, NRC 1857, and entomological field staff attached to the anti-malaria campaign, Manar and Jaffna district office would be greatly appreciated. Thank you.
Thank you very much, Mr. Jude. It's quite a variety of topics we have this morning. I would like to ask if there's any questions here in the room for Mr. Jude on his study.
Sorry?
No, I'm just asking the audience if there are any questions. Meanwhile, if you're thinking of one, I can add an online question which we just received. What could be the challenges in the practical implementation of this strategy, scaling up possibilities? How could you answer that, please, for us?
Actually, controlling the Anopheles statistics is a newly invented mosquito. Nowadays, that most of the house owners, they are using the chlorine to applying to their wells to clean their wells and the water sources. That's the first challenge, the mosquito control program. And another challenge is that their mosquitoes are able to adapt that chlorine water and their other new breeding sites. These are the main challenges, and resistant to the chemicals. So these are the main challenges in Sri Lanka to control activities.
Thank you very much, Mr. Jude. I see a hand up down in the middle of the room. Somebody's coming to you with a microphone, I think. Please stay there for a moment, Mr. Jude. Go ahead.
Okay, yeah. Hi, Jude. How is the mosquito control right now in those areas? Mana, I know it started in Mana. How is it controlled right now?
Actually, there's an anti-malaria campaign that abandoned all activities, spraying chemicals in Sri Lanka, all over the island part, because they are forming the resistant activity. Actually, that in all part of Sri Lanka, they are monitoring the larval stage, and they normally use the Temifos in the breeding sites. Actually, that is our only chemical they are using, Temifos, to avoid the larval stage, that kill the larval stage only. Other adult stage, they are still nowadays they didn't do any activities control to the adult stage, only the control the larval stage. It's island wide, it's not in part of the all island part. Yes. No. That in island wide they are using the Temifos to control the larval stage, and the both biological control and Temifos. Actually, biological control, they have the challenge applying chemical like that. Water quality parameters, sometimes it's changes that is not favorable to the fish population. That time that larval mosquito larval population will increase. That's the time they use the Temifos. It's a biological process. Is a very long and effective one, but some climatic condition they have to use the Temifos chemicals.
Okay, thank you.
Thank you very much, and thank you very much again for your time, Mr. Jude. I'm going to hand over now
Thank you.
to Dr. Kalani Kulataleka to take over from me as MC. I'm going to have a little break.
Thanks very much, Helen. Well, it was a brilliant session indeed. Thank you once again to all our speakers for that very insightful session and for very well researched presentations. I think the audience here today felt the engagement. Well, while our minds are now saturated with information, we would like to take a quick break, not a quick break, rather an extended break for lunch. We wrapped up exactly 10 minutes ahead of time, so I think that will give you the best opportunity to take a look at all the e-posters that are displayed as you walk out of the main door. So we have displayed e-posters on 4 screens. There will be one by MSF and 3 screens dedicated for presentations by the University of Sri Jayewardenepura. So and also I would like to remind our virtual participants who are joining us that you can do the same by clicking on the button above the live streaming window on your website to take a look at the same posters. So while I invite you to take a look at that, we will now break for lunch and we shall return back at exactly 1:45 p.m. That gives you around 55 minutes. So yes, enjoy your lunch break.
There can be little doubt that our global environment is changing. The science is unequivocal. It's all too clear that we'll be seeing rising temperatures and sea levels, more frequent and intense extreme weather events such as heavy rains, heat waves, cyclones, and floods. This will impact fundamental issues like access to food and water. This in turn will impact people's health. We're also likely to see new and changing diseases and people falling sick because of pollution. And people will start leaving their homes as some places become uninhabitable over time. All existing projections point to large-scale changes ahead, and we can only anticipate the humanitarian needs this will bring, and we need to adapt the way we work to be able to respond. We know from experience that it's the most vulnerable who will be the most affected, making them even more vulnerable. We know because we're already seeing them in our waiting rooms. We're now looking at how we can best address this and get ready for the future. We have chosen to do this through the lens of planetary health.
Planetary health is a relatively new health discipline. It focuses on the changes that humans are making to our environment and the impacts that has on human health.
These changes to the environment destabilize the natural ecosystem, causing climate change and pollution of our air, soil, and rivers. This, in turn, affects the water we drink and the air we breathe. It means we will see disruptions to our food production systems and changing patterns of diseases, such as malaria. It means we may see new diseases we didn't know before, and also the re-emergence of other diseases as the ecological conditions for transmission of diseases change. The main idea behind planetary health is that it is looking at how all this is linked and how humans are responsible for these changes. Our health depends upon the well-being of the planet, and the well-being of the planet depends on how we act. It is all linked.
We are a medical humanitarian organization, so it touches us in 2 fronts. It touches us as medics, because as medics we are concerned about the health of our patients, their communities, and the populations we are trying to serve. But also as a humanitarian, we are concerned to preventing negative outcomes of humanitarian crisis. And we do know that the environment has an impact on health and has an impact to worsen already existing humanitarian crisis. So it's part of who we are in a way. We are seeing now malaria in places where they were not before, because the mosquito now can survive. We see introduction of mosquito-transmitted diseases such as Zika or dengue in urban settings in a larger scale. If the water changes temperature, the Vibrio cholera can survive easier. So there is a direct link between environment and environmental conditions, and mainly the vector-transmitted diseases.
Donc quand on parle de regarder toute nouvelle intervention en intégrant un prisme santé planétaire, c'est se dire, ok, donc au niveau climatique ici, il se passe quoi? Est-ce que les sécheresses sont plus sévères? Est-ce que les pluviométries sont plus sévères? Est-ce qu'il y en a moins? Mais quand il y en a, elles lavent tous les sols. Est-ce qu'on a une augmentation de la température en moyenne? Qu'est-ce que ça implique pour les populations? C'est toujours des éléments qu'on a regardés, mais sur lesquels on ne s'est pas nécessairement penché de façon systématique. On a besoin de savoir ça parce que ça va induire des besoins médico-opérationnels chez les populations qui peuvent probablement être différents de ce que c'était il y a 10 ans. Donc l'objectif de comprendre ce qui se passe d'un point de vue environnemental, d'un point de vue de température, d'un point de vue, on va dire, entre guillemets, santé planétaire, mais ça regroupe tous ces phénomènes-là, c'est de pouvoir anticiper quels vont être les besoins des populations et comment nous, on va garantir qu'on met à disposition des services de santé qui correspondent aux besoins et pas par rapport à ce qu'on faisait d'habitude pour ce genre de problème.
Our medical action is not fundamentally going to change, but we are going to add an eco-friendly lens to it. Our medical action should not be implemented in a way that jeopardizes the future of our patient tomorrow. And our medical action needs to be aware the way we implemented it without jeopardizing quality and reactiveness, doing it in a way that is the less harmful for people and environment. We can cure people, but we also have to avoid making people sick. So we have a double responsibility as a medical organization of restoring physical health, but maintaining environmental health to avoid people getting sick tomorrow. As running hospitals, as running large medical programs, we are reviewing our way of working in those programs to be able to provide the same level of care and with the same speed and impact, but trying to make it in a way that does not contribute to the climate emergency.
Donc on va faire bien pour les populations, on va s'adapter, mais nous, en tant qu'institution, est-ce qu'on est propre, en gros ? Est-ce que nos pratiques ne contribuent pas elles-mêmes à la détérioration de la planète? Si on prend en charge les populations affectées par des maladies émergentes qui ont un lien avec une dégradation du climat, une dégradation de l'environnement, notre rôle, évidemment, c'est d'éviter que cet environnement se détériore un peu plus. Donc pour moi, c'est normal que ça fasse partie intégrante du plan stratégique, et c'est plus est-ce qu'on doit le faire ou est-ce qu'on le fera dans 10 ans. Non, on aurait probablement dû le faire il y a déjà 10 ans, on est déjà largement en retard, mais maintenant il faut qu'on avance par rapport à ça, quoi. Et on n'a pas le choix,
We need to care for our patients in a way that does not harm them and their communities tomorrow. And for doing that, we need to take our own responsibility to be the most environmental friendly medical organization we can be.
When the weather becomes warmer and rainfall patterns change, insects like mosquitoes that transmit diseases such as malaria and chikungunya breed faster and survive in places they didn't before, exposing more people to these potential killers. It's been estimated that climate change will cause approximately 15 million additional cases of malaria each year. Dengue fever is also a potentially deadly viral disease transmitted by mosquitoes. It is spreading rapidly, with reported cases increasing almost tenfold in the last 2 decades. The virus is now present in over 100 countries. The changing climate also means we will see more ticks and the diseases they carry, like Lyme disease. The life cycle and number of ticks are strongly influenced by temperature. When there's little water, we can't grow and produce food. On the other hand, too much can bring more pests and diseases that damage crops. Heavy rains can also destroy entire harvests. Livestock and plants we depend upon for food can't be raised without water. Rising seawater levels bring salty water to coastal areas, making agriculture impossible. All this means our food production systems will be affected, and this can cause or increase malnutrition, even in places there was none before. Natural disasters are becoming more frequent and severe. When extreme weather events like cyclones and floods hit, they can cause injury, death, and deadly diseases like cholera. Cholera, hepatitis E, and other illnesses can spread through water, so when we drink it or come into contact with it, we get sick. As the air, freshwater sources, and oceans become warmer, this leads to an increase of pathogens that cause diarrheal diseases. They're one of the most important causes of death in children around the world. The rising temperatures will cause increased heat-related illnesses like heat stress and heat stroke. The most at risk are the very young, the very old, and people with chronic conditions such as heart, lung, and kidney disease. This is worrisome, as heart disease is the #1 cause for death worldwide. Heat waves are becoming more frequent and severe. The last decade has included the hottest years on record. Air pollution is a great concern to our health. It's the cause of 9% of all deaths worldwide. Children are particularly vulnerable. Air pollution is closely linked to climate change. The extraction and burning of fossil fuels is a major source of air pollutants, and many of them cause global warming. Wildfires also produce a range of harmful air pollutants, known to cause cancer and increase the risk of heart attack or stroke. Climate change will also affect our health in indirect ways. When resources are scarce, they become a reason for conflict, and conflict forces people from their homes. There are often many different reasons why conflict erupts and why people decide to leave their home. Climate change contributes to this and makes existing grievances worse. As you can see, climate change is a serious threat to human health. The World Health Organization estimates 250,000 more people will die every year because of climate change-related health impacts. Everybody will be affected by climate change, but some are more at risk than others. The most vulnerable will be the least able to cope. We know because we're already seeing them in our waiting rooms.
C'est très alarmant ce que racontent les communautés parce que généralement, nous ici, on vit à base de l'agriculture et de l'élevage. Et ces deux secteurs-là ne répondent pas aux besoins de la communauté. Moi, ma préoccupation, c'est que si rien n'est fait présentement, je ne souhaiterais pas que mes parents aussi puissent se développer à Maghreb. Je suis en train de viser d'autres alternatives pour pouvoir évoluer avec mes enfants ailleurs. Parce que ici, ce n'est pas la joie. Les pluies se font très rares et aussi les pluies demeurent inégalement réparties. Au lieu qu'elles soient bien réparties dans le temps, maintenant c'est concentré en un mois. Par exemple, le mois d'août, on récolte plus de pluie. Tu vois, la plupart sont pareils. Là, c'est bon. La terre ne donnait plus parce qu'on l'a surchargée. Et aussi, il n'y avait pas des apports nécessaires pour faire produire ces champs-là. Donc avant, quand on cultivait, c'est pour une année et même plus. Maintenant, c'est juste pour 6 mois. Et après les 3 mois là, de la période de soudure, Ça, c'est difficilement qu'on arrive à couvrir cette période. Le paludisme demeure jusqu'à présent la pathologie dominante et qui tue la plus grande partie de la population depuis des années. Quand il pleut, il y a beaucoup de moustiques qui se développent et qui attaquent la population. Pendant cette période de 3-4 mois de pluie, on est vraiment affecté par des cas de palu graves. Nous avons développé une approche qui permet de sensibiliser les parents sur la précocité de la prise en charge. C'est vraiment une approche qui a beaucoup soulagé les parents qui trouvent sur place la prise en charge au lieu de faire des kilomètres.
MSF is compelled to speak out about what we see after directly witnessing how climate change has likely exacerbated health and humanitarian crises where we work. In late 2020, hurricanes Eta and Iota hit Central America in quick succession. More than 120 health centers in Honduras were damaged or destroyed, or simply disappeared into the mud. 2 million people were left with limited or no access to care. But even before the storms, the health system in Honduras had been under considerable strain. Hospitals struggled to accommodate COVID-19 patients, while a dengue outbreak driven by insecticide-resistant mosquitoes loomed. We see mosquito-transmitted diseases such as dengue in urban settings now in a larger scale. MSF teams are supporting efforts to bolster health systems' resilience to climate threats in Honduras. These include vector control activities and a dengue fever surveillance system to preempt outbreaks. Without significant action to tackle climate change, these situations will become more common.
Manolonany fetrenany fahasimbany zao dia tena dia fiaignananay vahoaka tena hita hoe fa mafy. Ny vokatra sy ny araboly zany simba, ny ankizy sy mesy mianatra, ny sy fahasalamana misy, dia ny arabola hoentina sabonan'izay dia zavatra tena.
Donc les 3 axes sur lesquels nous travaillons à Noziwarika et dans le district, c'est d'abord l'axe médical, soutien aux structures avec une équipe médicale MSF, clinique mobile sur les zones n'ayant pas accès à l'hôpital de référence ici, et une surveillance sur la nutrition et le paludisme.
Tary fiaviany zany enimbolana iviana vokatra vary zany dia
tena ho sahirany vahoaka raha karahan'izao no mitohy. Amin'izany koa ilay toetrandro miovaova, ndraika maigna be, ndraika morana be dia lasa be rano, ilay vary amboarina koa ndraikindraiky hintahan'ny rano koa.
Alors on peut mettre quasiment tout ce qui est produit dans une structure de santé, ce qu'on appelle les DASRI, donc les déchets d'activité de soins à risque infectieux. Dans la taxonomie MSF, on a 3 grandes catégories. On a ce qu'on appelle les softs, donc c'est tout ce qui peut être potentiellement contaminé. Ça peut être des compresses avec de la bétadine, ça peut être des pansements, des ustensiles à usage unique, des choses comme ça. On a également tout ce qu'on appelle les piquants, coupants, tranchants, ou les sharps en anglais. Donc ça, c'est tout ce qui est aiguille, scalpel, etc. Et puis on a les organiques médicaux, donc du sang, tout ce qui est les déchets liés au bloc opératoire. Pour des raisons de confort, pour nos opérateurs, on a décidé de ne pas mettre les déchets organiques. C'est une solution intéressante, évidemment. Ce n'est pas quelque chose qu'on va pouvoir déployer sur tous les terrains MSF, parce que ça demande quand même une maintenance, des pièces détachées, une alimentation en électricité un peu continue, une certaine qualité d'eau, etc. Mais dans beaucoup de contextes, ça peut être une très bonne alternative. Il ne faut pas perdre de vue les objectifs principaux pour MSF en termes de gestion des déchets. C'est évidemment de réduire tous les déchets qui sont générés par nos activités et de pouvoir les traiter de façon la plus responsable possible en termes environnementaux et sanitaires.
Story has power. It's easier for the community to follow true story, especially if it's collected from the daily norms of the community. Majority like news of what is happening within their locality. Majority respond to lesson learned more than the flip chart.
For other method, we are using the leaflet, and with the leaflet, there is no really good discussion between the patients. But for the issue of change, it makes the interaction between the community with the health promotional team. And this interaction is very important because the community feels like they are the ownership of the activity, and also the leaders are also much involved.
The story of change training is available in all MSF projects. The training includes theory, practical, fieldwork skills. With members of the community, we can find out a lot about people and their living situation by the stories they tell.
Stories are powerful because they came out from the life experiences of the people. It also helps the project to better understand what the community is experiencing and how important is involving community.
Health promotion team identifies what questions or health issues we want to understand more. Who we want to talk to about these issues. Then we enter into the community and try to find out what stories exist about the issues. Once we gather enough stories together to analyze the key elements of the stories. What are the beliefs and perspectives? What challenges do they face? What are their priorities? Who are the influencers in the community? What language do they use to speak about these issues? Many elements that make up a story. Once we have analyzed the story, we should go back to the community to write the story together. We use the elements that we found in the analysis and include the relevant MSF messages in the narrative. In this way, the community has ownership of the final story. The story is familiar because it contains recognizable characters, language, and challenges in that story. After the training, you will have learned more about the community and you will have worked in collaboration with them to create a health promotion tool.
The final stories that we made was very useful. When you wanted to narrate to the community, they came in big numbers. They were asking questions. And they even asked, where did we get this story? Because it's similar with what they had already had within their community.
Story of change training is more than a training. It all involves the community.
People love stories. People pay attention and listen more actively when you are telling them the story than any other health promotion. People participate actively to give more involvement regarding the discussion.
The community participates in bringing change through story sharing. The story of change has transformed our understanding of the community. Through information collection, we have realized many factors influencing change in the community. This has enabled us to design effective health promotion interventions.
I feel amazed and blessed to conduct such a training program, and most important thing is that my team became more skillful for their work.
Without this training, we would have never been aware about the depth and importance of stories from our communities. Moreover, this new tool could be incorporated into our aim of reaching to every individual who stay bound to social and other associated stigmas and does not avail MSF mental health services to help themselves.
Gatekeepers and influencers are now actively involved in the health promotion activities.
Story of change training is different and unique because it helps to better understand the community you are supporting, and it helps teams to listen and collaborate from across the world.
The most interesting part is actually an opportunity for me to connect with all health promotion teams from around the world, from different projects. We might work together on tackling maybe similar health issues that we have, and also sometimes different health issues. They can guide you and answer any concerns or questions or uncertainties that you might have through the training.
Community can easily relate because they were actually part of this story. And after we shared the first co-created story of change, we have actually observed an increase in the number of adolescents who were accessing our services at Mbawa. So yes, I actually would want to encourage and would like to see all the members of the HP team doing the story of change training.
Innovation helps us save lives. Making sure that our help reaches those who need it most can be a daunting challenge due to countless obstacles. Many times, the obstacles we face are logistical, like how can we treat patients in places where there are no roads? We're constantly working to develop new and innovative ways to deliver care to people who would otherwise be cut off from essential health services. In Nigeria, we found ways to monitor for malnutrition cases using mobile phones. In Papua New Guinea, we've collected patient samples using drones. In Nepal, we used an inflatable hospital to treat earthquake survivors. We also launched an ambitious telemedicine program that allows isolated field doctors to connect with specialists from around the globe and treat more complex cases. For example, we helped develop an Ebola vaccine based on the knowledge we gained from working on the front lines of West Africa's Ebola epidemic in 2015. We've also developed a special fund dedicated to developing solutions to some of our most critical challenges. We're investing today in innovations that will help us save lives in the years to come. Thank you so much for watching MSF's Pulse. To learn more about how we're innovating the humanitarian world, click the link in the video description.
My name is Safa Herfat. I'm with MSF RSP project here with the Reconstructive Surgery Hospital here in Amman, Jordan. We're exploring how we can use 3D technologies such as 3D scanning, 3D design, and 3D printing to deliver prostheses. The goal would be to increase access to prosthetics. The focus is mainly on upper limb prosthetics. We are exploring different solutions that we can provide the patient, from cosmetic solutions such as this to different terminal devices that can be removed and designed specifically for the patient. For each patient, we sit down with my colleague Pierre Moreau and interviews them to determine their current condition and the specific activities that they would like to restore in their lives, such as driving a car or working in the field or working in the home. We are looking to design devices or terminal devices or tools that can be delivered to patients in austere environments or areas where there's limited or no access to prosthetic care. There are certain advantages to using 3D printing, so the logistics can be easier. Rather than stocking up on inventory of different devices, we're able to design on-site if needed or remotely, and then have a printer on-site with some of the filaments, the plastic filament material available, and from there we can pretty much prototype, or in this case manufacture a custom device for each patient on site.
So we are going to match the color and to try to see which color is matching the most.
Okay,
Yeah. Okay. Perfect.
One of our goals is to keep things simple. So rather than exploring electronic solutions or very complicated solutions, we want to keep things as simple as possible, but also durable. This is a cost-effective solution. This hand right here can cost you $20 rather than the hundreds of dollars a normal upper limb prosthesis would cost. But it also has the advantage of being lighter. That can be a huge factor in the adoption rate of an upper limb prosthesis. If it's really heavy and cumbersome to wear, then the patient will likely not adopt it in the long term and set it aside. So as an engineer, this is an incredible resource because I can prototype something and send it to the printer and potentially print it same day, rather than me designing, sending out to a fabrication facility, waiting for that lead time to come back. So we can work much more efficiently.
La résistance aux antibiotiques, c'est un problème de santé publique majeur, c'est un problème planétaire. On voit de plus en plus de bactéries qui deviennent résistantes aux antibiotiques, voire résistantes à tous les antibiotiques.
Years ago, we were able to treat most infections with simple antibiotics. This is not the case anymore.
La surconsommation d'antibiotiques et le mauvais usage des antibiotiques pour des pathologies notamment virales contribuent à l'émergence et à la dissémination de ces résistances.
As a physician, my primary concern is always the patient that I'm treating. And if I have the ability to diagnose them accurately, I'll use the right antibiotic, for example, for an infection. But if I don't, my inclination would be to use the strongest, the most complicated antibiotic to guarantee that my patient survives. And what we need to provide our physicians and nurses and medical staff in the field is with the precise tool that allow them to achieve both. A diagnostic capacity that allows them to treat the patient as efficiently as possible while using the least broad spectrum, the least sporadic way of prescribing antibiotics.
Au laboratoire de bactériologie, les flacons d'hémoculture sont directement placés dans un automate qui va suivre la croissance éventuelle d'une bactérie dans les flacons. Et les biologistes vont prélever les flacons positifs et vont réaliser un ensemencement. Ensuite, on va tester la sensibilité aux antibiotiques de la bactérie responsable de l'infection. Donc à partir de cet antibiogramme, on établit un rapport et ce rapport, on l'envoie au clinicien qui, lui, utilisera ces résultats pour pouvoir traiter de manière appropriée l'infection de son patient.
Nous avons décidé à MSF de développer un laboratoire d'analyse bactériologique transportable qui soit adapté aux contraintes de terrain.
In a traditional MSF context, you might be faced with anything, from being deployed very rapidly in an acute emergency to being in a very, very remote area.
Relative humidity can affect electronics, high temperature can affect stability of consumables, high dust can block several equipments. Short shelf life is difficult for procurement, cold chain is difficult for transport and for storage. Most clinicians have never used clinical microbiology in their practice, so they do not know about indications, sampling, and they cannot make a good interpretation of a microbiological result. Next, there's also a problem of affordable, available and adapted training materials.
Nous allons donc modifier les technologies existantes pour que celles-ci soient plus faciles d'emploi pour les utilisateurs, plus robustes et à coût raisonné. Concrètement, le but maintenant est de pouvoir adapter le matériel pour pouvoir faire en sorte qu'il puisse travailler dans des environnements avec des hautes températures, à 45 degrés, mais aussi à des basses températures, qui puisse du coup utiliser le moins possible d'électricité, voire qui puisse avoir la possibilité de travailler sans électricité pendant une certaine période de temps. Pour les tests de diagnostic, nous essayons aussi de faire en sorte que ces outils puissent avoir une durée de vie au-delà de 18 mois pour pouvoir permettre d'avoir une chaîne d'approvisionnement logistique qui soit plus facile à gérer. La première étape dans ce développement est déjà de rédiger des spécifications qui soient adaptées aux contraintes du terrain en travaillant avec des spécialistes internationaux, mais aussi des spécialistes à MSF qui ont une connaissance du terrain. Puis ensuite, nous regardons ce qui existe sur le marché et nous ciblons les industriels pour qu'ils adaptent leurs solutions selon notre cahier des charges. Nous allons les intégrer dans des solutions transportables, des solutions modulaires qui, elles-mêmes, seront ensuite testées sur le terrain. Nous espérons avoir les premiers prototypes d'ici fin 2018 pour pouvoir les tester sur les différents terrains d'MSF courant 2019.
So you're going to go to Makanga. It's one of these areas that were affected 2 years ago.
After occurring in below. This is the scene across almost half the zone.
It's an area that has been cut off partially during the floods. In anticipation of what may happen, the idea is to map actually the area properly and to be able to intervene fast, to plan the resources that are needed according to the situation.
So first we need to prepare really to identify all the airfields, and after we need also to prepare the drone and all the equipment that we will need. For small areas we can use the drone, it's easier, we can fly in a lower altitude than just with aerial images below the clouds, and we can have really precise pictures. At the end of this mission, we will have many pictures of the area. We will try just to get just one big picture of the Makanga Island. From this picture, we will try after with our GIS software just to digitalize all the access, all the roads, and try to find all the access for our missions.
Having the capacity to straight away map where the population is and to visualize that on a map allows actually to, on our side, design the intervention, and it helps tremendously to communicate at a distance with the decision makers, with the actors on the ground, and to actually understand the scope of the situation and fasten the decisional process.
Going out to the field, to different countries with diverse cultures, backgrounds and perspectives different than our own, it can get overwhelming. And finding the right candidate, the right person for field missions and projects is a different task altogether. MSF was founded 50 years ago, and our work today is just as important as it was then.
The roles are specific for each profile, and each requires a unique set of skills.
Our medical action is grounded on human-to-human connection. Every day, we reinforce our core principle of humanity as we deliver emergency aid across more than 70 countries.
Each year, thousands of internationally mobile staff carry out field assignments with MSF. They work alongside with 50,000 locally hired staff to give life-saving medical assistance to people in need.
We rely on a strong network of medical as well as non-medical professionals to deliver life-saving medical support.
Here at MSF South Asia, we contribute to this big network. People who we have selected for medical or non-medical profiles from this part of the world have worked with us in countries like Yemen, Iraq, Sierra Leone, Myanmar, DRC, to name a few.
My name is Anura Absimetova. I'm project coordinator for Advanced HIV project in Patna, India.
Hi, I am Vinita and I work as the Learning and Development Manager for the MSF mission in Sierra Leone.
My name is Usman Major. I am the HR coordinator for Nigeria mission based in Abuja.
My name is Dr. Shazid Majid and I work as the medical coordinator for MSF in Iraq.
In general, people feel that MSF is all about medical doctors.
Surgeons and nurses work here, but we are more than that.
It also has non-medical staff like logisticians, finance, human resources, learning and development, who also complement the medical activities that we provide across the missions.
And in the past several years, we have recruited over 200 medical and over 200 non-medical profiles from the South Asia region.
As long as there are people in need of emergency aid, our work at MSF will continue. And as long as our work continues, we will need people with skill, with talent and passion to deliver life-saving medical support.
There can be little doubt that our global environment is changing. The science is unequivocal. It's all too clear that we'll be seeing rising temperatures and sea levels, more frequent and intense extreme weather events such as heavy rains, heat waves, cyclones and floods. This will impact fundamental issues like access to food and water. This in turn will impact people's health. We're also likely to see new and changing diseases and people falling sick because of pollution. And people will start leaving their homes as some places become uninhabitable over time. All existing projections point to large-scale changes ahead, and we can only anticipate the humanitarian needs this will bring, and we need to adapt the way we work to be able to respond. We know from experience that it's the most vulnerable who will be the most affected, making them even more vulnerable. We know because we're already seeing them in our waiting rooms. We're now looking at how we can best address this and get ready for the future. We have chosen to do this through the lens of planetary health.
Planetary health is a relatively new health discipline. It focuses on the changes that humans are making to our environment and the impacts that has on human health.
These changes to the environment destabilize the natural ecosystem, causing climate change and pollution of our air, soil, and rivers. This, in turn, affects the water we drink and the air we breathe. It means we will see disruptions to our food production systems and changing patterns of diseases, such as malaria. It means we may see new diseases we didn't know before, and also the re-emergence of other diseases as the ecological conditions for transmission of diseases change. The main idea behind planetary health is that it is looking at how all this is linked and how humans are responsible for these changes. Our health depends upon the well-being of the planet, and the well-being of the planet depends on how we act. It is all linked.
We are a medical humanitarian organization, so it touches us in two fronts. It touches us as medics, because as medics we are concerned about the health of our patients, their communities and the populations we are trying to serve. But also as a humanitarian we are concerned to preventing negative outcomes of humanitarian crisis. And we do know that the environment has an impact on health and has an impact to worsen already existing humanitarian crisis. So it's part of who we are in a way. We are seeing now malaria in places where they were not before, because the mosquito now can survive. We see introduction of mosquito-transmitted diseases such as Zika or dengue in urban settings in a larger scale. If the water changes temperature, the Vibrio cholera can survive easier. So there is a direct link between environment and environmental conditions, and mainly the vector-transmitted diseases.
Donc quand on parle de regarder toute nouvelle intervention en intégrant un prisme santé planétaire, c'est se dire, ok, donc au niveau climatique ici, il se passe quoi? Est-ce que les sécheresses sont plus sévères? Est-ce que les pluviométries sont plus sévères? Est-ce qu'il y en a moins? Mais quand il y en a, elles lavent tous les sols. Est-ce qu'on a une augmentation de la température en moyenne? Qu'est-ce que ça implique pour les populations? C'est toujours des éléments qu'on a regardés, mais sur lesquels on ne s'est pas nécessairement penché de façon systématique. On a besoin de savoir ça parce que ça va induire des besoins médico-opérationnels chez les populations qui peuvent probablement être différents de ce que c'était il y a 10 ans. Donc l'objectif de comprendre ce qui se passe d'un point de vue environnemental, d'un point de vue de température, d'un point de vue, on va dire, entre guillemets, santé planétaire, mais ça regroupe tous ces phénomènes-là, c'est de pouvoir anticiper quels vont être les besoins des populations et comment nous, on va garantir qu'on met à disposition des services de santé qui correspondent aux besoins et pas par rapport à ce qu'on faisait d'habitude pour ce genre de problème.
Our medical action is not fundamentally going to change, but we are going to add an eco-friendly lens to it. Our medical action should not be implemented in a way that jeopardizes the future of our patient tomorrow. And our medical action needs to be aware the way we implemented it without jeopardizing quality and reactiveness, doing it in a way that is the less harmful for people and environment. we can cure people, but we also have to avoid making people sick. So we have a double responsibility as a medical organization of restoring physical health, but maintaining environmental health to avoid people getting sick tomorrow. As running hospitals, as running large medical programs, we are reviewing our way of working in those programs to be able to provide the same level of care and with the same speed and impact, but trying to make it in a way that does not contribute to the climate emergency.
Donc on va faire bien pour les populations, on va s'adapter, mais nous, en tant qu'institution, est-ce qu'on est propre, en gros? Est-ce que nos pratiques ne contribuent pas elles-mêmes à la détérioration de la planète? Si on prend en charge les populations affectées par des maladies émergentes qui ont un lien avec une dégradation du climat, une dégradation de l'environnement, notre rôle, évidemment, c'est d'éviter que cet environnement se détériore un peu plus. Donc pour moi, c'est normal que ça fasse partie intégrante du plan stratégique. Et c'est plus est-ce qu'on doit le faire ou est-ce qu'on le fera dans 10 ans. Non, on aurait probablement dû le faire il y a déjà 10 ans. On est déjà largement en retard, mais maintenant, il faut qu'on avance par rapport à ça, quoi. Et on n'a pas le choix. On n'a pas le choix.
We need to care for our patients in a way that does not harm them and their communities tomorrow. And for doing that, we need to take our own responsibility to be the most environmental friendly medical organization we can be.
When the weather becomes warmer and rainfall patterns change, insects like mosquitoes that transmit diseases such as malaria and chikungunya breed faster and survive in places they didn't before, exposing more people to these potential killers. It's been estimated that climate change will cause approximately 15 million additional cases of malaria each year. Dengue fever is also potentially deadly viral disease transmitted by mosquitoes. It is spreading rapidly, with reported cases increasing almost tenfold in the last 2 decades. The virus is now present in over 100 countries. The changing climate also means we will see more ticks and the diseases they carry, like Lyme disease. The life cycle and number of ticks are strongly influenced by temperature. When there's little water, we can't grow and produce food. On the other hand, too much can bring more pests and diseases that damage crops. Heavy rains can also destroy entire harvests. Livestock and plants we depend upon for food can't be raised without water. Rising seawater levels bring salty water to coastal areas, making agriculture impossible. All this means our food production systems will be affected, and this can cause or increase malnutrition, even in places there was none before. Natural disasters are becoming more frequent and severe. When extreme weather events like cyclones and floods hit, they can cause injury, death, and deadly diseases like cholera. Cholera, hepatitis E, and other illnesses can spread through water, so when we drink it or come into contact with it, we get sick. As the air, freshwater sources, and oceans become warmer, this leads to an increase of pathogens that cause venereal diseases.
Welcome back, ladies and gentlemen. We are back to the MSF Asia Scientific Days International Conference on Medical Sciences 2022. I'm sure everyone's feeling very refreshed after lunch. We are now about to commence the third session of oral communications. This session will be chaired today by Dr. Chamil Marasinghe, Senior Lecturer, the Department of Medicine, Faculty of Medical Sciences, University of Sri Jayawardhanapura, and Dr. Shehan Silva, Senior Lecturer, Department of Medicine, Faculty of Medical Sciences, University of Sri Jayawardhanapura. I would now like to hand over the session to our chairpersons to continue on from here.
Good afternoon, everyone. So we are going to start the third oral communication session. So it will last from 1:45 to 3 p.m. We got 7 interesting research presentations lined up. And for the presenters, few information. So your presentation should stick to 8 minutes, followed by there will be about 2 minutes question and answer session. The time will be displayed, time left will be displayed in the screen here. I hope the online people are joined. Kalani? Oh, joined? That's great. Yes, because some of the presentations will be done online. So the first oral presentation is online one. So the topic is health-related quality of life in patients on maintenance hemodialysis, a descriptive study in 2 in-center dialysis units at major tertiary care medical institutions in Sri Lanka. Authors are Athapattu AM MP, Disanayaka HDW TD, Dharmaratna SD, Nanayakara N. The paper will be presented by Athapattu AM MP. That will be online.
Hope you all hear me. Am I audible?
Yeah, we can hear you.
Okay, thank you, sir. Hello, good day to all. My name is Mudita Athapattu and I am from University of Peradeniya. My presentation topic is health-related quality of life in patients on maintenance hemodialysis, a descriptive study in 2 in-center dialysis units at a major tertiary care medical institution in Sri Lanka. This is the presentation outline, and let's move to the introduction. Over the years, chronic kidney disease has emerged as a major public health problem in Sri Lanka. The increasing prevalence of chronic kidney disease parallels the increasing prevalence of end-stage renal disease. The most preferred treatment modality for end-stage renal disease in Sri Lanka is hemodialysis. Evaluation of health-related quality of life among hemodialysis patients in the community can add new insight into the management of the disease. Further, systematic evaluation of the health-related quality of life of the hemodialysis patients in the selected study setting has not been carried out to date. Since that, the general objective of the study was to describe the health-related quality of life and the associated factors among hemodialysis patients in the National Hospital Kandy, Sri Lanka. These are few articles which have been used during the literature search. Next, I will proceed to the methodology. This study adopted descriptive cross-sectional study design and conducted at Nephrology Unit, National Hospital Kandy. All the patients undergoing hemodialysis in National Hospital Kandy during the data collection period were recruited, and purposive total population sampling technique was utilized. These were the inclusion and exclusion criteria. The sample size was calculation using Yamani formula, and by considering 10% non-responses rate, finally sample size equal to 248 participants. However, by considering inclusion and exclusion criteria, finally 317 patients were participated to the study. Health-related quality of life was assessed using the locally validated kidney disease quality of life short form version 1.3. Clinical, biochemical, and treatment-related information were extracted from the patient's personal medical records and the clinic books. Information related to health-related quality of life were assessed by the principal investigator through the face-to-face interview. Ethical approval was obtained from the Ethics Review Committee of the Faculty of Medicine, University of Peradeniya. Data were analyzed using the SPSS software version 25, frequencies and percentages used for the categorical variables, while mean and standard deviation used for the continuous variables. Further, man-with-new test, Spearman's correlation, and chi-square tests were used to find the association between the selected risk factors and the subdomains of the health-related quality of life. Let's move to the findings of the current study. The preponderance of participants were males, and majority of participants were belonged to the 51 to 60 age category. 84.9% participants were not employment, and 89.3% participants had comorbidities. Regarding the duration on hemodialysis, approximately 50% of the participants were on hemodialysis less than 12 months. About the access type, majority of participants were having AV fistulas. About the frequency of dialysis per week, majority of participants were attend 2 days or less to get the hemodialysis treatment. About the duration on hemodialysis per session, majority of participants were on hemodialysis 4-hour durations per session. About the presence of comorbidities, majority of participants having hypertension followed by having both diabetes and hypertension. This table shows the symptomatology among the study participants. Table 6 shows you the distributions of the quality of life major domain scores among study participants. As you can see here, mean and median scores of the kidney disease summary component is greater than the rest of 2 major domains. Table 7 describes the correlation between quality of life domain scores and some selected factors. None of the selected factors significantly associated with 3 major domains. Table 8 describes the association between kidney disease summary component and some selected factors. So it is worth to note that gender, presence of depression, presence of comorbidities, and employment status significantly associated with the kidney disease summary component. Table 9 shows you association between physical summary component and some selected factors. According to that, gender and the employment status significantly associated with physical summary component. Table 10 shows the association between mental summary component and some selected factors. According to that, gender and the presence of depression significantly associated with the mental summary component. Moving to discussion, health-related quality of life was significantly greater for females than for males in current study, whereas a similar type study conducted by Senanaik and colleagues in 2020 revealed gender of the patient was not significantly associated with health-related quality of life. Further, being positive for depression, presence of comorbidities, significantly associated with the lower health-related quality of life in current study. Whereas the Senanaik and colleagues revealed similar findings in 2020. One of the major strengths of the study was a timely attempt in covering a vast area in a single study, including different aspects. And one limitation of the study was no control group used to assess the health-related quality of life due to the resource limitations and the COVID-19 outbreak. Based on the findings, conclusions were the health-related quality of life of the hemodialysis patients in this population at National Hospital Kandy was found to be poor, and screening positive for depression, having comorbidities, and currently not being employed were significantly associated with low health-related quality of life. So the recommendations are periodical screening of the hemodialysis patients for depression and measures to alleviate symptom burden seems to be important, and practical aspects which can be implemented to improve the overall quality of life of these patients. These are the references. And I would like to finally thank my supervisors, all study participants, all staff members of the Nephrology and Transplant Unit National Hospital, Kandy, finally my family and the friends. With that, I will conclude my presentation, and if you have any questions, I will be more than happy to answer. Thank you.
Okay, thank you, Atapattu. Can you hear us?
Yes, sir, I can hear.
Okay, so now the paper is open for questions. Yes, there's a question.
I hope you can hear me. Just two questions. Was the quality of life associated with the adequacy of hemodialysis, and whether having KT plans or any definitive renal replacement therapy plans had any impact on the quality of life?
Madam, here I actually not assess the association between dialysis adequacy and the quality of life, because there were some obstacle I have met during the analysis of KT values, because collection of blood for the pre-dialysis blood urea nitrogen and post-dialysis urea nitrogen, actually I have collected blood sample, but that due to the number of the increased sample size, the final end results was not very good at to accurately measure the KTV values. Therefore, I mean that the blood samples were collected by the staff nurses as well as myself. The most of the post blood sample values were inaccurate due to mishandling and inaccurate collection of the samples. Therefore, I was not analyzed the dialysis adequacy and association between those two parameters, madam, actually.
Okay, but did the frequency, I mean, per week, did it have any impact?
No, madam.
Okay, fine. And the other one was about the definitive plans for renal replacement, KT or something like that.
You mean the association?
Yes. If they had KT plans, was the quality of life different?
The KT, no, there is no any association between KT plan with the quality of life. But the most of the patients were significantly impact their quality of life, and their depression level is significantly high in this current study.
Okay, fine. Thank you.
Can I allow one more question? Are there online questions? No? All right. In the absence of any other questions, so we'll move to the next paper.
Yes, the second oral presentation will be also online, and it is titled as Barriers and Facilitators for Weight Reduction in Obese Young Adults in an Urban Setting, a qualitative study. The authors are G.P. Gamage, P. Hettiarachchi, R. Jayawardena, S. Vasalatantri. The presenter will be G.P. Gamage from the Department of Nursing and Midwifery, Faculty of Allied Health Sciences, General Sir John Kotolawala Defence University. Dr. Gamage.
Good afternoon. Can you hear me?
Yeah, we can. Yeah, we can. Please start.
Okay, I'm JP Gamke from Faculty of Allied Health Sciences, and I'm here to present the findings of our study titled Barriers and Facilitators for Weight Reduction in Obese Young Adults in an Urban Setting. And this is the outline of my presentation. Obesity is a global health concern which has reached epidemic proportions, and despite the attempts to reverse this trend, the prevalence rates are continuously increasing in all countries. The target population was young adults, the age between 18 to 35 years, and this period is important since this is a period which is allied with number of significant life transitions such as leaving residency, starting full-time occupations, then higher education, marriage, pregnancy, and so on. According to the literature, the unhealthy dietary habits and physical inactivity are the contributing factors that leads to weight gain during this age group. However, interventions during this period are considered important since individuals begins to establish their adult health behaviors during this period. The urban setting was selected for this study since urban living has been identified as a risk factor for obesity in Sri Lankans. The interventions developed based on the barriers and facilitators are considered as important to plan effective population-specific interventions. Therefore, our study aimed to explore the barriers and facilitators for weight reduction among obese young adults in an urban setting. This was a descriptive qualitative study conducted among sample of obese young adults in the Colombo district, and the inclusion criteria were the body mass index greater than 25 and age between 18 to 35 years. We used purposive sampling technique and data saturation. Point was used to determine the sample size, which was achieved after 10 focus group discussions, and we used a semi-structured guide to keep the uniformity between the focus group discussions. Data analysis was done using framework method in thematic analysis, and ethical approval for the study was obtained from Ethics Review Committee, Faculty of Medicine, University of Colombo. When it comes to social demographic profiles, majority were females, and educated more than 70% of the participants have educated more than year 11, and nearly 70% of the participants were unemployed. When it comes to anthropometric parameters, the mean BMI was 29, and majority belongs to obesity class 1, and more than 90% of the participants had abdominal obesity. The participants' expressions and focus group discussions were able to identify 7 barriers at personal and environmental level, and let me explain each barrier with the excerpts. The first theme was incorrect knowledge, especially they emphasized the incorrect knowledge regarding causes for obesity and incorrect knowledge regarding weight reduction strategies. The participants preferred weight reduction strategies with quick results than diet and physical activity modifications, especially commercial preparations, self-prepared Ayurvedic preparations were preferred by the participants. The second theme was emotions and mood, especially they expressed that they feel lazy to adhere to dietary and physical activity modifications and feeling shy to engage in physical activities in open places. Poor self-control was another barrier. At social events, especially where there are a number of foods served and certain food cravings that are unable to resist were emphasized by the participants. Then inadequate support from the others, especially those who are closely around the participant, especially the loss of support from the family and friends for healthy lifestyle practices were emphasized, and also the influence to have more food or unhealthy foods by those who are around. And the negative feedback for weight reduction outcomes that has achieved by the obese participants were also highlighted. Other commitments, especially commitments related to household work, occupation, or education that took up their time, were emphasized as a barrier for weight reduction practices by the young adults. Lack of availability and accessibility to healthy food options, physical activity facilities, and weight management programs were also emphasized as a barrier for weight reduction by the participants, and also unsafe environment for physical activities was also emphasized by them, especially by female participants. They feel that they are not safe in outside. Not only the barriers, the participants were able to identify the facilitators that they are motivating for weight reduction activities, and accordingly we identified 6 facilitators at personal and environmental level. Especially the desire to improve the appearance and body image was the major concern or main facilitator emphasized by the majority of the participants, and they expressed the body image dissatisfaction and desire to increase the clothing options were the main things emphasized by the participants under this theme. Then health-related concerns, especially to prevent the obesity-associated diseases or further deterioration of existing medical conditions, was also emphasized by the participant as a facilitator for weight reduction. Difficulties in managing day-to-day activities due to obesity and allied symptoms such as breathlessness and some sleepiness and that sort of symptoms, they need to reduce that. Therefore, they stated that limitations in day-to-day activities as a facilitator for weight reduction. Then previous positive experience such as losing weight in previous attempts and also other positive outcomes than weight loss such as sense of general well-being and then feeling fit and so on are motivating themselves to practice weight reduction. Then support from others, especially from family, peers, and co-workers, also emphasized by the participants as a facilitator for weight reduction. And previous unpleasant experiences in public places due to their weight and appearance was the other facilitator that emphasized they need to get rid of that sort of discrimination from the society. Therefore, they are motivated to for weight reduction. So in conclusion, the knowledge, emotions, and mood, self-control are the factors that are associated with weight reduction attempts of obese young adults at individual level. The appearance and body image related concerns, health related concerns, limitation in daily activities, and positive experience are the facilitators at individual level. However, support from others is a key environmental level factor that acts as a barrier as well as a facilitator for weight reduction in young adults. Accordingly, considering the identified barriers and facilitators, when planning weight management programs for obese young adults is recommended, and also incorporating strategies to obtain social support to in weight management programs also recommended. These are my key references, and I would like to thank all the participants and Professor A.T.G. Amarsekar for assisting me in data analysis. Thank you.
Thank you. We have time for some questions. I have a question. Gamage, was there any theme that came up with regards to cultural barriers where when it comes to weight reduction, reducing diets, etc., where the culture came into play?
Actually, the participant aspects, we could not identify significant barriers at cultural level. However, we conducted another component of the same one with the healthcare professionals. There they emphasize that, but here not, sir.
What I in particular was wondering about dietary variations with regards to cultural differences. Was that a deterrent? Was that tone coming?
Yeah, there were concerns and they were stated some, but especially they talked about the barriers that they have to practice at family level than cultural issues actually as major themes we identified.
Okay, thank you. Are there any questions from the audience? If not, we will move on.
Yeah, let's move to the oral presentation 3. It's an in-person presentation. The topic is postpartum weight reduction and factors associated with postpartum weight retention in mothers attending child welfare clinics in selected MOH areas, Colombo district. The authors are Veerakon AW, Sirisena KKSN, Kalupahana MCE, Utpala PGP, Chamod DAS, Atithan LV, Hettiarachi UPK, Gunawardana CSE. It's coming from Faculty of Medical Sciences, University of Sri Jadapura. The presenter will be Sirisena KKSN. Over to you.
Thank you, sir. Honorable Chairperson, panel of judges, ladies and gentlemen, a very good afternoon to all of you. I am here today to present our undergraduate research, which is postpartum weight retention and factors associated with postpartum weight retention in mothers attending child welfare clinics in a selected medical officer of health area, Colombo district. I would like to take this opportunity to thank the organizing committee and MSF Asia for providing us this valuable opportunity. Obesity leads to non-communicable diseases, and the prevalence of women being overweight and obese in Sri Lanka is rising. One of the main overlooked factors leading to non-communicable diseases among women is postpartum weight retention, and a major factor associated with that is gestational weight gain. So in our research, we focused on gestational weight gain and its relation to postpartum weight retention. We realized during our literature search that there was a major lack in studies conducted in Sri Lanka with regards to postpartum weight retention. Postpartum weight retention is the difference between weight after delivery and weight prior to pregnancy. So using this definition that we obtained from the Chinese study, Ma et al. 2014, we took 5 kilograms as the designated cutoff value for postpartum weight retention at less than 1 year postpartum period. Gestational weight gain is the difference between pre-pregnancy weight and pre-delivery weight. We used the Institute of Medicine recommendations for gestational weight gain in our analysis, and it is shown in the table given below. So the IOM recommendations provide the expected weight gain that should be achieved by mothers of different pre-pregnancy BMI categories. It's used worldwide and it's also used in Sri Lanka. So previous studies have shown that gestational weight gain may vary with pre-pregnancy BMI and that a high gestational weight gain may contribute to postpartum weight retention. So the objective of our study was to determine the proportion of postpartum weight retention and associated factors among postpartum mothers at 7 to 12 months postpartum attending child welfare clinics in a selected medical officer of health area, Colombo district. So our study was conducted in the child welfare clinics in Boralasgamuwa MOH area, and it was a descriptive cross-sectional study comprising of mothers at 7 to 12 months postpartum. And although our calculated sample size was 292, we were only able to recruit 70 postpartum mothers due to the COVID-19 pandemic restrictions at the time. So a systemic sampling technique was used, and as study instruments, we used interviewer-administered questionnaires to collect data on the various relevant fields, a data extraction form to record the weight and height of mothers at the time of the clinic visit, and pregnancy records of mothers were used as data extraction tools to obtain the pre-pregnancy BMI and the maximum gestational weight. This was used to calculate the gestational weight gain and postpartum weight retention. After administrative clearance was obtained, informed written consent was taken, and the weight and height of mothers were measured using standard WHO guidelines. And data analysis was done using the SPSS software version 26.0. So the results of our study are as follows. The mean age of the sample was 30 years, with more than 2/3 of the mothers being unemployed, and 69% of mothers were educated above O levels, and most of the mothers had a pre-pregnancy BMI in the normal range. So this pie chart shows the distribution of mothers according to the gestational weight gain. Most of them achieved normal gestational weight gain, while 30% achieved excessive gestational weight gain. This chart shows the distribution of gestational weight gain according to the IOM guidelines in mothers of different pre-pregnancy BMI categories. So as seen by the gray color in the chart, mothers in the underweight pre-pregnancy BMI and the overweight pre-pregnancy BMI groups achieved more gestational weight gain. This pie chart shows the distribution of postpartum weight retention in our of more than 5 kilograms in our sample, and it was 47.1%. As you can see in this chart, which shows the proportion of postpartum weight retention according to the different categories of gestational weight gain as shown by IOM recommendations, mothers with excessive gestational weight gain had more postpartum weight retention, as you can see by the blue color in this chart. So in our research, we found that the association between postpartum weight retention and gestational weight gain was statistically significant. This shows the distribution of postpartum weight retention according to the pre-pregnancy BMI categories of the mothers. So mothers with underweight pre-pregnancy BMI had more postpartum weight retention than others. So the association between postpartum weight retention and pre-pregnancy BMI was statistically significant according to our study. So I would like to compare the distribution of gestational weight gain in our study and with similar studies done in China, Vietnam, and Gampaha of Sri Lanka. As you can see by this table, the results are not compatible with our study. In our study, we found that underweight and overweight pre-pregnancy BMI mothers showed more excessive gestational weight gain. And a similar study conducted in Vietnam showed results which were not very consistent with our results. And in our research, we found that postpartum weight retention and gestational weight gain were significantly associated. And the results was consistent with a similar study done in Vietnam. And we also found that postpartum weight retention and pre-pregnancy BMI were significantly associated. And it was similar to the studies obtained from a similar study in Vietnam. However, the findings were not similar in a study which was similar to ours that was done in China. So in conclusion, our sample of mothers, most of them had adequate gestational weight gain. And apart from educational level, other socio-demographic factors were not significantly associated with postpartum weight retention. Factors which were significantly associated with postpartum weight retention were gestational weight gain, pre-pregnancy BMI, higher educational level, mothers using a vehicle for transport, low physical activity, consumption of snacks. Parity, pregnancy outcome, exclusive breastfeeding, gestational diabetes mellitus, household activities and dietary habits did not show any significant association with postpartum weight retention. So I would like to recommend educational sessions for mothers during antenatal period to educate them about gestational weight gain and postpartum weight retention, and also during the postnatal period to encourage more physical activities to reduce postpartum weight retention. We would also recommend more island-wide researches be done in Sri Lanka regarding postpartum weight retention. Thank you all for listening to our presentation, and I would like to thank Dr. Inoka Liyanage and the staff at Borlaskamua MOH, and finally all the mothers who participated in our study and helped make it a success. These are our list of references. Thank you.
Okay, thank you. The paper is open for discussion. Any questions? Yes.
Yeah, it's because you are recommending the antenatal classes and the post-pregnancy exercises. Did you look at that among these women if they had attended the MOH exercise classes? Was that one of the factors that you are looked into?
No, madam, that was not included in our questionnaire. For physical activity, we used questions obtained from STEP survey, and we designed a few questions, mostly obtained from the STEP survey.
Thank you.
Any more questions from audience? Have you got any online questions now? A little clarification from me, because it's a long time period after postpartum that you took, like many months, after 12 months.
Yes.
Is there any sort of changing weight gain or weight retention during that 12 months? Is it more towards like immediately after the delivery, or it's towards the end of 12 months?
Yes, sir. So we selected this time period mainly after 6 months to avoid the clash that would occur, because at that time period the mothers are focusing on breastfeeding. So we cannot expect them to reduce their weight that they gained during pregnancy. And after 1 year period, we did not consider it based on previous researchers and everything. We considered it was could not be related to the pregnancy. It could be because of the postpartum food consumption, and therefore not exactly postpartum weight retention. Because of that, and based on previous studies, we selected the time period of 6 months to, 7 months to 12 months postpartum period, sir.
Thank you. Okay, in the absence of further questions, we'll move to the next presentation.
Thank you, sir.
The fourth oral presentation is titled Taxonomic Identification Key to Scrub Typhus Vector Sugar Mites in Sri Lanka, authored by MLS Ashani, N. Gunatilaka, R. Premaratna, N. Chandrasena, F.C. Jersina Vicious, R. Bassini Silva, and it will be presented in person by MLS Ashani of the Department of Medicine, Faculty of Medicine, University of Kelaniya.
Good afternoon to everyone. I'm MLS Ashani, representing the Faculty of Medicine, University of Kelaniya. I'm going to present a taxonomic identification key to scrub typhus vector chigger mites in Sri Lanka. So a little background. Scrub typhus is a zoonotic febrile illness. It is infectious disease, which is also known as Susugamushi disease or mite-borne typhus. It is very often neglected in the Asian Pacific region, which is also known as the Susugamushi triangle. The disease is characterized by prolonged fever and especially cigarette burns-like scars called eschars, which are the characteristic features of scrub typhus. In figure 1, you can see 2 eschars on a patient's body. The disease is caused by an obligate intracellular bacterium named Orientia Susugamushi, and humans acquire the disease by the bite of an infected chigger mite belonging to the family Trombidiformes. In figure 2, you can see a chigger mite was taken under a microscope. During the past years in Sri Lanka, we have seen several outbreaks of scrub typhus, but unfortunately there are only very limited studies conducted to identify and characterize the vectors responsible for the disease transmitting areas. First trombiculid mite was documented in Sri Lanka back in 1946 by Professor Jayavikrama. Besides that, a few studies on chigger mites parasitizing on bats were conducted by the University of Colombo. Barring those studies, there have been no studies conducted on chigger mites to identify their vectorial capacity and their locations in the Sri Lanka. So local public health workers and researchers interested in vector control face a major challenge in identifying these chigger mites due to lack of morphological identification keys and further data on them. So the objective of the study was to develop a morphological identification key to the recorded chigger mite species in Sri Lanka. Methodology, here we have adopted 2 ways. One is to do an extensive literature survey on the chigger mites identified in Sri Lanka from 1945 to 2021. Next up is to field sample chiggers, capture them and make permanent slides and do the morphological identification at the laboratory. So in field sampling, we've selected sites from Galle, Hambantota and Gampaha district based on the patient's records available in the Rickettsial Disease Diagnostic and Research Laboratory at the Faculty of Medicine, University of Kelaniya. And field sampling, for the field sampling, we have to capture their hosts first. For that, we placed live capture mesh traps designed for live capture of these small mammals, which act as a host of chigger mites. These traps were baited with fried coconut and were placed in peridomestic areas of the patient's residence, their working place, and surrounding lands. Traps were placed just before the sunset and retrieved in the morning. Once hosts or the small mammals, such as rodents, were captured, they were anesthetized and they were monitored for the presence of mites. Once mites are detected, they were collected to 70% ethanol and transported back to the laboratory. After the collection, hosts were carefully observed until they regained their consciousness fully and recovered fully, and they were released back to the captured location. We have obtained the ethical consent from the Institute of Biology Sri Lanka for the whole procedure. Figure 3 shows the inspection of chigger mites from a host. The host is anesthetized. Figure 4 shows a mesh trap we use to live trap these animals. It is baited with fried coconut. In slide preparation, once the individual mites were brought back to the laboratory, we washed them thoroughly with PBS and slide mounted using Hoyer's medium. Once the slides were prepared, they were observed under a light microscope and images was taken for further reference. Morphological key, as I explained earlier, developed constructed basing on original observations from the previous lecture and the morphological features observed from the collected samples from the study visits. For the construction of the mic key, we used morphological features such as the scutum, shape of the chigger mite, their formula, cheetotaxy, and morphometrics of the external features of the mite. The key was validated with the use of reference corrections, followed by a quality control procedure with the help of some international experts. Here you can see Figure 6, the most crucial part in identifying chigger mites and differentiating them into their genres, which is a scutum. We have used the shape and its measurements, external measurements, known as morphometrics, to divide these captured chigger mites into their genus levels. Also, we use the mouth parts, commonly known as the gnathosoma of these mites, to identify them up to the species level. And their leg arrangement was also used to identify up to the species level. Whole mount chigger mount and their length, number of setae or the hairs present on the body, dorsal side, ventral side, both were used to identify up to the species level as well. So the results from the extensive literature conducted and from the samples collected during the study, we have identified chigger mites up from 9 genus levels up to 15 species levels present in Sri Lanka. These are the chigger mites we have isolated from our study. Figure 9 shows Canogastiella punctata and figure 10 shows Leptotrombidium infalum. Both carry records to be possible vectors of scrub typhus. Canogastiella was captured mainly from the Gampaha district. Leptotrombidium was very prominent in southern areas of Sri Lanka. So this is the key we developed. In conclusions, this is the first attempt to develop such a key to morphologically identify chigger mites, and we are still in the first steps of developing the key. Our full paper is yet to publish, and we intend to publish a key with illustrated diagrams that will help everyone to understand the features that we are talking about in the key and have a better idea to identify the field caught chigger mice. We hope that this key will help and boost the interest among research scientists to carry further more research on this subject, which is very underrated so far. These are the references. And I would like to acknowledge National Research Council for funding the grant and relevant medical officers of health and their staff for the support provided to carry out field surveys, and also to technical officers and laboratory staff at the Department of Parasitology, Faculty of Medicine, University of Kelaniya, Sri Lanka. Thank you and have a nice day. And if you have any questions, I will be very glad to answer them.
Thank you. Are there any questions from the audience? Yeah, the microphone to Professor Renu.
All these species of the sugar mite you identified, do all of them transmit scrub typhus?
Some of them, yes. The Scenogastiella genus, yes. Leptotrombidium genus, yes. And there are some other Eutrombicula genus, yes, they do. We are yet to identify their vectorial capacity. Okay. But we tried that, and we are still developing that procedure also, because a genetic study is needed, molecular study is needed to validate the procedure. So we are still doing that research.
Planning to do that?
Yes, planning to do that in the future.
What is the prevalence of scrub typhus in Sri Lanka? Do we have a lot of it?
We do have. The issue is that it doesn't get reported. Like especially in the southern areas, hospital doctors and the MOH staff, they know the disease because they've seen it. And they identify the disease mostly by clinical feature, but apart from that, they differentiate scrub typhus from leptospirosis depending on the location of the patient's residence. Like if they are coming from, as an example, if they are coming from Batapolelia, Ambalangoda, and if they have this prolonged fever, then direct to it's scrub typhus. If not, it's leptospirosis. The diagnosis is like that in those areas. Because we don't have a clinical diagnosis procedure for scrub typhus only, and the disease is reported to MOHs as typhus disease only. There are many rickettsial diseases in that category alone, so it doesn't get reported. But scrub typhus is very prevalent, especially in southern areas, northern Jaffna Peninsula, and Anuradhapur area. It is very prevalent in those areas.
So more research is needed, really.
Yes, exactly. Yes.
Okay, thank you.
Thank you. In the interest of time, we move on to the next oral presentation.
Okay, oral presentation 5, it's an online presentation. The effects of Sri Lankan Apis cerana honey, it's a bee honey, on selected wound pathogens. So the research had been conducted by Jayamana HC, Leonarachi MB, Bhogavatta AE, Vijayasekara I, Jayasingha MA, Vijayasingha GK, Vidhanagamage RD, and Veerasekara MM. The research is coming from Department of Medical Laboratory Science, General Sir John Kotalawala, Defence University, Sri Lanka. The presenter would be Jayamana HC. It's an online presentation. We can start now.
Good afternoon to you all. I am Chari Jayamana. The title of our research is The Effect of Sri Lankan Apis cerana honey on Selected Wound Pathogens. Chronic wound infections have become a major global health problem. Chronic wounds provide an ideal environment for biofilm formation, and it has been reported that over 60% of chronic wounds and around 6% of acute wounds harbor biofilms. Bacterial and fungal biofilms are responsible for most chronic wound infections and are notoriously resistant to antibiotic treatments. So that their management is difficult and costly. Because of that, new approaches are required to combat biofilms in chronic wounds. Honey is lately been registered as an alternative treatment option for wound infections due to its broad spectrum antimicrobial activity. And several countries have conducted studies to evaluate the antimicrobial properties of the endemic honeys. But research performed based on natural Sri Lankan Apis cerana honey are very limited. So in our study, we investigated Sri Lankan Apis cerana honey for its antibacterial, antifungal, and antibiofilm effect against selected wound pathogens. Methodology. The antimicrobial effect of Apis cerana honey on planktonic growth of Staphylococcus aureus, methicillin-resistant Staphylococcus aureus, Pseudomonas aeruginosa, Escherichia coli, Klebsiella pneumoniae, Candida albicans, and Candida tropicalis was initially evaluated using well diffusion method and by the determination of minimum inhibitory concentration. Furthermore, the antibiofilm effect of Apis cerana honey was evaluated by assessing its ability to inhibit initial biofilm adhesion, biofilm development, and establish biofilms of selected wound pathogens using MTT microtiter plate assay. Then the mean percentage reduction of MTT activity in adhered cells were calculated by comparing the mean absorbance value of the negative control and the mean absorbance of the testing organisms using this equation. Finally, the post-exposure alpha structure of selected wound pathogens biofilms was studied using the scanning electron microscope. According to the results obtained by the initial screening with the agar-well diffusion method, it revealed that Sri Lankan Apis cerana honey had antibacterial and antifungal activity against all the tested strains. And the antibacterial activity of honey was a bit higher on the tested gram-positive bacteria as compared to gram-negative pathogens. And the larger zone diameter of inhibition were exhibited against Staphylococcus aureus and methicillin-resistant Staphylococcus aureus. And this slide shows the obtained results by the agar-well diffusion method, and all the tests were done in triplicates, and we used 0.2% chlorhexidine digluconate as the positive control and sterile distilled water as the negative control. And the MIC values of Apis cerana honey were in the range of 770 to 1540 milligrams per milliliter. And the other results of the MIC is shown in this table. And this shows the MIC results obtained through our study. According to the results, Apis cerana honey effectively reduced the initial biofilm adhesion of all test strains when compared to the negative control. And Pseudomonas aeruginosa achieved 50% reduction in the lowest concentration of honey, which was 12 milligrams per milliliter. And all the test strains except Candida albicans exhibited a percentage reduction close to 100% in 1540 milligrams per milliliter honey concentration. Furthermore, Apis cerana honey reduced the biofilm development of all test strains, and all the test strains exhibited a percentage reduction close to 100%. Honey also reduced the established biofilms of all test strains, and MRSA achieved 50% reduction in the lowest concentration of honey. And this slide represents the MBI 50 values of Apis cerana honey and chlorhexidine in forming and established biofilms. Scanning electron microscopy of established biofilms. When compared with negative controls, 24-hour mature biofilms treated with Apis cerana honey cause microbial cell shrinkage by damaging the walls of mature sessile and cause leakage of intracellular materials in all the test organisms. And as you can see, the untreated biofilms showed more number of microorganisms compared to the treated ones. And visualization of fewer microcolonies in the treated biofilms may be due to the inhibitory effect of bee honey. And this is the ultrastructure of Apis cerana honey treated biofilms formed by Pseudomonas aeruginosa and the untreated biofilms formed by Pseudomonas aeruginosa. And this is the picture of the ultrastructure of Apis cerana honey treated biofilms formed by Candida albicans and untreated biofilms of Candida albicans. Furthermore, structural deformities of pseudohyphae and hyphae were observed in Candida albicans with treated Apis cerana honey. Researchers have recorded the broad spectrum antibacterial activity of natural unheated honey against certain pathogenic bacteria. And up to date, there is no published document that has evaluated the antibiofilm effect of Sri Lankan native Serrano honey. So this study will be a novel experiment. According to the results of our study, AP Serrano honey exhibited a significant antibacterial effect towards both gram-positive and gram-negative bacteria. And the well-efficient results of our study indicates that the antibacterial activity of honey was higher gram-positive bacteria as compared to gram-negative ones. And AP Serrano honey had an antifungal activity against both tested Candida species. To the best of our knowledge, there was no research done on STM imaging to evaluate the answer structure of Sri Lankan AP Serrano honey treated by pigs. According to our study, the test strains exhibited reduced cell density, cell wall damages, cell wall deformities, and leakage of intra-cell materials in the presence of MBIC safety of AP Serrano. Conclusion: Sri Lankan AP Serrano honey has an antibacterial, antifungal, antibacterial effect against plankton growth of Staphylococcus aureus, methicillin-resistant Staphylococcus aureus, Pseudomonas aeruginosa, Klebsiella pneumoniae, and Escherichia coli related to the infection. Furthermore, AP Serrano honey exhibited an antifungal effect against Candida albicans and Candida trapezoides. AP Serrano honey showed an antibiofilm effect on the initial biofilm addition, biofilm development, and established biofilms of all the tested pathogens as well. And we would recommend AP Serrano honey can be a suitable candidate for further studies aimed at providing valuable insights into the treatments of wound infections caused by pathogens which do not respond to antimicrobial therapies. And it also can be used in introducing new wound presence. In addition, we would recommend that it is important to study other locally produced but yet untested Sri Lankan honeys as well for their antimicrobial activities. These are references. And I would like to acknowledge all the technical officers and non-staff of the Department of Microbiology, Faculty of Medical Sciences, University of Srinagar, and all my friends and family. Thank you.
Thank you. Any questions from audience? It's a small comment from me actually. I know it's a laboratory experiment. The question is whether it's going to be sort of effective when you treat patients, like putting honey into patients' wounds. Like that's the impression that the patient will get, whether they accept it or whether you think that it will be effective, in your opinion, when treating the patients. What do you think about it?
So far, it's been used in Ayurveda medicine as an external and internal application, and it's been used for treating wounds as well. So we hope it will be effective.
Okay. Ayurvedic physicians, they think that there's a benefit of this honey. Is it? Is that correct?
Sorry?
Ayurvedic physicians, they think that... Okay. All right.
They are used to see.
That's good. Thank you. Any online questions? No? Okay, we can move to the next presentation.
The sixth oral presentation will be presented in person. It's titled as Prevalence of Toxoplasmosis Among a Selected Group of Cancer Patients at Apeksha Hospital, Maharagam, Sri Lanka. The authors are Veerasurya PC, Manahekka H.A., Manamperi A.P., Dhanansurya M.N. And it will be presented by Veerasurya PC of the Department of Parasitology, Faculty of Medical Sciences, University of Sri Jayawardhanapura.
Thank you. Good evening. I am Pobudini Veerasurya. Our studies on finding prevalence of toxoplasmosis among a selected group of cancer patients in Sri Lanka. This is the outline. The toxoplasmosis is a widespread parasitic infection which is caused by intracellular protozoan Toxoplasma gondii And as you can see in this diagram, there are many ways that human could get infected from this disease. In immunocompetent patients, the disease is asymptomatic and it's a self-limiting infection among them. But in the immunocompromised patients and in pregnant women, it causes life-threatening adverse effects. As example, among the immunocompromised patients, it causes pneumonia and encephalitis. The objective of this study is to determine the seroprevalence of toxoplasmosis among a selected group of cancer patients using enzyme-linked immunosorbent assay technique. In methodology, blood samples were collected from 321 adult cancer patients who were admitted to the Apeksha hospital during November 2021 to March 2022. The patients who are at age 18 to 80 and who have histologically proven cancers and patients who are on any form of anti-cancer therapy were included in this study. First, we have collected an interviewer-administered questionnaire. Then, all the blood samples were tested using ELISA technique to detect IgG and IgM antibodies. Let's move on to the results. Among 321 cancer patients, 50% were males while 50% were females. Among them, 25% were at the age of 18 to 40 and 33% were at the 41 to 60 age group, and rest of the 42% were at the age of 61 to 80. And among these cancer patients, 60% majority of were having hematological cancers while others are having solid organ cancers. When moving on to the ELISA results, there are three categories as positive, negative and borderline. In IgG test results, as you can see, the positive and negative results are similar, while in the IgM test, the negative result shows much higher value. And considering this IgG and IgM test results for each of the patients, we have classified all the patients into different categories. Among them, majority were having no serological evidence of toxoplasmosis because they have both IgG and IgM negative result. Secondly, most of the patients have past infection, which means they have IgG positive result. Then 18 out of the 321 patients have definite acute infection or the possibly recent infection where they have both IgG and IgM positive result. Among the rest, most of the patients have possibly acute infection or the false positive IgM result, while others are having indeterminate result. Using these classifications, I have categorized all the patients into four categories as possibly acute infected patients, possibly past infected patients, negative patients and indeterminate patients. Using these four categories, we have analyzed all these categories to find the association of sex within these four categories. And the possibly past infection didn't show any sex difference, but in possibly acute infection, the males have the more possibility of getting possibly acute infection. And then we also analyzed the age group association within these four categories. There are 18% of the age 61 to 80 group have possibly acute infection, while 50% of the possibly past infected patients are also in the age of 61 to 80. And then we also analyzed the cancer type association with within these four categories. There we found that hematological cancers and organ cancers shows similar contribution for the possibly acute infection, but in possibly past infection, hematological cancers are higher. And then we also analyzed the association of risk factors within these four categories, but there we didn't find any of the associated factor among these cancer patients. In conclusion, 47.7% were having IgG positive result, 9.7% were having IgM positive result, while 5.6% were having definite acute infection, which means they have IgG and IgM both positive. And serological evidence shows that 11.2% having acute infection and 40.8 were having past infection. When considered the other factor association, overall acute infection was more among male, Past infection was more among above 61 years, and past infection was more among the hematological cancer patients. As for the discussion, we could say that our results are comparable with the most of the past findings which is done among the cancer patients. As a recommendation, we recommend to screen all the cancer patients for toxoplasmosis using ELISA, and we recommend to because even though they are IgG positive, they may reactivate the disease, and we also recommend to repeat indeterminate result after 2 to 4 weeks, and we recommend to develop an in-house ELISA as a cost-effective means, and using PCR to confirm ELISA result is recommended. And drawbacks of the studies, we didn't use a healthy control as this is a preliminary study. We are hoping to do it in our next stage. And we didn't use a convalescent sample to find the fourfold rise. And we didn't use any other test to confirm this ELISA result at this stage of the study. And this study was granted by University of Sri Jayawardenepura, and I thank all the patients and staff of Apeksha Hospital Maharagama as well as the staff of Department of Parasitology, Faculty of Medical Sciences, University of Sri Jayawardenepura, and I also thank my supervisors, Professor Hasini Banheke, Professor Arisha Manamperi, and Dr. Manjula Dhanansurya. These are my references. Thank you. If you have any questions, you can ask now.
Questions?
Just one question about your conclusion. You said you recommend all patients to be screened with the antibodies. What is the clinical implication of it? Say we screen and IgM or IgG is positive?
In IgG positive, as these patients are immunocompromised, they may reactivate the disease. So it is better to identify the IgG and IgM antibodies among cancer patients, because as these patients are under chemotherapy or radiotherapy, which is immunosuppressive therapies, if we don't know whether these patients have toxoplasmosis, we will give the chemotherapy and this reactivation can occur. So if we know the ELISA results of among these patients, we can either we can reduce the amount of chemotherapy we are giving for these patients.
That's a recommended practice, is it?
Yeah.
Okay.
If I may ask you, what is practice in Sri Lanka? Because it's very difficult to find pyrimethamine even as a treatment for non-malignant patients. What is the practice that is done at the moment in Sri Lanka?
The toxoplasmosis is only identifying in MRI. So after identifying the toxoplasmosis, they give medicine for especially for the pregnant women. And for immunocompromised patients like cancer patients, they don't give medicines still.
Even for pregnant patients, it's very difficult to find the drug. That has been a problem in the recent past. And another question, have you attempted to probe in and see what level of transmission that happens within the hospital, let's say after the patient gets admitted during the chemotherapy phase, and when the patient is, depending on what outcome it is, have you all attempted to do any further studies?
No, for that we have to do another test, like we have to do tests before they admitted to hospital and after admit to the hospital, because all the patients are under blood transfusion. So that is also a method that they will get the disease. So for that we have to screen before and after admitting to the hospitals.
So it's yet to be done?
Yes.
Thank you.
Thank you.
Move on to the next one.
Yeah, the last presentation is on experts' agreement on usability and features of web-based tool in promoting flipped classroom pedagogy. The authors are Johansson P., Henning M.A., Chen Y., and Lyndon M. The presenting author is Johansson P. is from Department of Medical Education and Research, Eastern University, Sri Lanka. It's an online presentation. Johansson, you can start now.
Hi. On behalf of all four authors, I'm Hashim presenting a study which titled on Experts' Agreement on Usability and Feature of a Web-Based Tool in Promoting Flipped Classroom Pedagogy. Introduction. Blended learning is considered as a new educational paradigm for implementing health profession education curricula. A typical form of blended learning include technology-mediated online and teacher-led face-to-face learning. One of the blended learning innovation is notion of flipped classroom. In flipped classroom, teachers use technology and share pre-class learning material to activate low-order learning, and students study the learning material before attending face-to-face classroom. Teacher designed the face-to-face classroom as an interactive education environment by using student-centered teaching strategies to allow the students to apply or evaluate the learned concept. Flipped classroom pedagogy involves using several educational technologies such as screen and video recorders, a learning management system, online quizzes, and social media platforms. Thus, teachers and students from health profession education would be likely interested in enrolling in an introductory training. It is vital to develop asynchronous training for clinical teachers and students who may be experiencing time challenges when balancing academic and clinical responsibilities. Thus, we aim to design, develop, and evaluate a web-based tool for fostering flipped classroom pedagogy in undergraduate health profession education. Methods. This is educational design-based research with a descriptive evaluation component. This study was conducted in 2 steps. Step 1, design and development. 2 actions occurred in step 1. Firstly, the FCN web designer developed innovative user interface and visual layout which allow the user to interact with the FCN website. Secondly, the authors develop learning materials for the FCN in accordance with intended learning outcome of the training. Step 2, evaluation. An expert panel was formed to evaluate the website by using website evaluation questionnaire. Experts in this study consist of people who are presently involved in health profession education, flipped classroom, and educational technology as a teacher or researcher or curriculum planner. 5 experts from 3 different countries agreed to participate. Descriptive statistics were employed to calculate the experts' agreement level. Results. The Flipped Classroom Navigator website design was adapted to provide access to the broadest range of digital devices. A simplified homepage was developed commonly for teachers and students. The homepage guides user to an attractive, colorful, and title-based course content page, which directs user to topic page which incorporated learning content. Learning content page was developed in 3 different forms: student-centric or interactive videos, word or picture-based illustration, and quizzes. Educational credibility of the Flipped Classroom Navigator. Adult learning theory principles were incorporated into the learning material development process for the FCN. For example, the FCN's learning materials encourage self-directed learning and inspired the learner to apply their prior experience. The expert panel thoroughly checked the instructional delivery of the online course, and quizzes were aligned with intended learning outcomes. FCN development was directed by Cook and Dupra's practical guide for developing educational websites. Experts evaluation. Experts rated the website evaluation questionnaire by 5-point Likert scale, responses 4 and 5 indicative of high level of satisfaction or agreement. We sum the number of agreeable responses divided by number of experts. An agreement level of 75% or above was considered as a good, and a value above 90% was indicated as excellent. Overall, the web-based tool obtained good level of agreement, that above 80% for its feature and usability from the expert panel. Conclusion: the web-based tool is an effective method for providing training to promote flipped classroom in health profession education. The web-based tool has achieved good rating from experts. However, it is essential to obtain acceptance from the end user, which will be a focus of future research. These are the references for today's presentation. Thank you.
Okay, ladies and gentlemen, this is a recorded presentation. So unless the authors are joining online, we can't ask questions. Okay, thank you. That concludes the presentation 3. Thank you very much for your participation.
Thank you very much. That was indeed a very thought-provoking session. I would like to extend a warm word of thanks to both our chairpersons, Dr. Chamil Marasinghe and Dr. Shehan Silva, and to all the adjudicators for your valuable contribution. We will award the Best Oral Presentation Award. The certificate will be awarded at the end of today's program, so do stay tuned for that as well. The next segment, ladies and gentlemen, is a symposium on keeping children safe together. The next segment is dedicated to identifying an often neglected aspect in pediatrics. While we do make accelerated progress in providing access to the finest of medical care in pediatrics, on one hand, there is still we still find significant shortcomings and lapses in providing justice and addressing the countless issues faced by survivors of child abuse, especially given our socio-cultural and political backgrounds. This next segment is dedicated to explore these questions and find answers through discussion and dialogue by the experts in the field. I would like to introduce our chairpersons of this session to the audience. Professor Guani Liyanage, Professor in Pediatrics, Faculty of Medical Sciences, University of Sri Jayawardhanapura, and Professor Sanjay Huladduwa, Professor in Forensic Medicine, Faculty of Medical Sciences, University of Sri Jayawardhanapura. Over to our chairpersons to continue the session from here onwards.
Thank you, Kalani. Thank you, Kalani. This symposium is on keeping children safe together. So there will be 3 presentations and from 3 speakers, and appreciate if you could stick to 15 minutes for each presentation. Let me first introduce the first speaker. She's Dr. Aswini Fernando, consultant pediatrician. She was the former professor in pediatrics in University of Kelaniya, and she'll be talking on provision of services for children who have faced violence. She has clinical and research interest in violence against children and child protection, and she was instrumental for the development of national guidelines for the management of child abuse and neglect, and for the establishment of a child protection unit, which is called Lama Piasa at the Colombo North Teaching Hospital. And also she served as a member of the board of National Child Protection Authority and as a member of Sectoral Oversight Committee of Parliament on Women and Gender. She is also the chairperson of Child Protection Committee of the Sri Lanka College of Pediatricians and advocates for rights of children. Over to you, madam, for your presentation.
Thank you, Guani, for those kind words of introduction. I would like to start by thanking the organizers for inviting me here today for this symposium, Keeping Children Safe Together. And my task is to talk about provision of services for children who have faced violence. let's very quickly understand what we mean by violence against children. It includes all forms of violence against children under 18 years. But it could be perpetrated by parents, caregivers, peers, older children, romantic partners, or strangers. And the WHO divides this into 6 main categories: age dependently, and child maltreatment and child abuse is one. It means the same thing. Bullying, youth violence, intimate partner violence, sexual violence, and emotional and psychological violence, and witnessing violence. This is something we don't pay much attention to. This is WHO 2016. Now, in the past few years, some of us pediatricians had concerns about what we were seeing. We were seeing all forms of violence against children: physical, sexual, exploitation, corporal punishment in schools and in homes, skull fractures due to abuse, and we were also concerned that there was inadequate recognition of the problem by medical professionals. I'll just very quickly go through a story. 6 weeks old with a spiral fracture of the humerus. That has to be non-accidental injury. Sent home with a plaster cast. Don't worry, the bone will heal well, come back in 2 weeks. This is from a leading hospital. So that's the fracture. Spiral fracture is always, and in a 6-week-old, any fracture should be suspicious. There was inadequate follow-up. We had this 9-year-old girl. She was a street child. She was admitted with pseudo seizures. She had been sexually and physically abused and neglected. There was no one in the whole wide world for her, so we had to send her to a child development center. And actually, I met her 6 months before this incident happened. She was very happy. There were counselors in that institution where she was, but sadly, she committed suicide 4 years later. So inadequate follow-up was a big gap. There were inadequate links with other sectors. This again led to a death. This was an illegally adopted child with a spiral fracture of the femur, an infant. Prior to the case conference being held, the police decided to discharge the child from the hospital. Despite all our attempts, we could not get the child back. 3 months later, the child was admitted to another hospital, unconscious, and died of shaken baby syndrome. So these were alarming us, and we also noticed at the same time that the reporting rates were steadily increasing. The iceberg was becoming more visible. So we needed a well-planned professional response by all stakeholders to sort out this problem. So in 2012, we formed a Child Protection Committee at the Sri Lanka College of Pediatricians. We embarked on a project called Creating Safe Communities for Children. It had 2 main objectives: better management of children who had faced violence and its prevention. Plan Sri Lanka partnered us on this venture. We were able to come up with a guideline. By 2013, a national guideline for the management of child abuse and neglect, and that's a multi-sectoral approach. We had all professional bodies, ministries, and departments working with us round the clock, round a table, arguing, debating, but the best interests of the child won the day, and that's how the guideline was formulated. We introduced what we call a clinical case conference, because we saw the re-traumatization of these children. Every place they went to, the child had to relate the story over and over again. So we decided that we should have integration, multidisciplinary integration within the health sector, and within 24 hours of the child coming into hospital, the JMO would have examined the child and taken a detailed history, and he shares that history with the pediatrician and psychiatrist within 24 hours of admission. I do not ask these children the story again, because I have been given the story. If the children do talk about it, of course I listen, but I don't ask what happened to you. So we have reduced the re-traumatization there. We have gone beyond the guidelines. Now the venereologist also sits with us if it is a child who has faced sexual abuse. Then the other case conference we have is the institutional case conference, which is the link to the multi-sectoral management. Legal and social sectors participate. And objectives here are many, but what we stress is ensuring psychosocial rehabilitation and reintegration of these children into society. The last bullet point, ensure legal justice with minimal delays, is a huge issue. These children have to go on for 10 years sometimes. They are married, they have to go to courts with the husband about an incident that happened several years before. This is very sad, but it is left to the legal fraternity to sort it out. In the meantime, by 2012, the Ministry of Health had accepted the concept of safe houses in health institutions, and we were able to establish a place, we call it Lama Piasa, and we call it the place where violence ends and healing begins. So we opened this in 2015. This was with help of Plan Sri Lanka. The funding came from them. From April 2015 to September 2021, when I retired as head of the unit, we had 659 children. Now the count is 720. We provide holistic care for the child and family, but it's a well-trained group of nurses and doctors now. And we have close links with all other sectors. During the designing of this unit, we decided to incorporate a video evidence recording unit. Why did we do this? Because we had seen too many children suffering, going to courts and relating their story there. I'll give you an example. An 8-year-old girl who was brutally sexually abused by her father. She needed surgery. The abuse was so horrific. Mother was overseas, and as I usually do, I rang the mother and requested her to come, and she did come. But she decided then she had to go back to find money for the rest of her house that she was building. And she said, put her somewhere safe, madam, I'm going back. That bond can never be mended when they leave their children, is what I have seen over the years. So we had to place her in a child development center. She needed a lot of psychological help. 8 years later, she faced the father in open courts. She realized that her statement would send the father to jail, and she went into deep, deep, deep depression again. She wrote a book on this. I still have it somewhere, and this was very sad. So we were determined. The only facility we had was in the National Child Protection Authority, and that couldn't cope with the whole country. So we incorporated this. We got approval by the Attorney General. Mr. Palitha Fernando was the Attorney General at the time. There's been long delay in starting this process, but this year, from May, we have started recordings. And Professor Mudita Vidaram Patrina, who's in the audience, has helped us to get this up and running during his tenure as chairperson of the NCPA. I just show you what have we learned from this cohort. I'm looking at the cohort that we have managed at Lama Piasa. The usual story, sexual abuse stands a mile long. Then we see physical abuse with corporal punishment included in that, emotional abuse, neglect, we've seen everything. 77% females and 23% males. What about sexual abuse and exploitation? What have we seen? We've had 33 pregnancies, 23 live births and 10 miscarriages. Some of the miscarriages were of course induced. What about sexual exploitation? These are things that we are seeing more and more now in this era. We are seeing sextortion. I will just give you a little story so that you understand what I'm talking about. A 14-year-old girl a 14-year-old boy forced to have oral sex with an 18-year-old boy. The act was videoed. The child did not know about it. He was blackmailed by the perpetrator to obtain money and jewelry from the members of the family. This was an upper middle class family. Their jewelry, the mother's jewelry went missing and money was going missing. No one else was coming into the house. And in the end, the child revealed the story. The children who were lured via internet for sexual activities, 37 in these last few years, this has escalated with online classes. This is very sad. Unsafe use of information communication technology. We are also seeing dating violence amongst adolescents, physical, sexual, and emotional abuse. What are the other lessons we have learned? We have known the risk factors for a long time, but we were able to confirm these. We did non-verbal IQ level testing with the 23 instrument in 119 children. And we found that 53% had an IQ level below average or lower. Now this was startling because some of these children actually were trying to sit for their O-level examination and they couldn't do basic sums. They couldn't write properly. They had not had any medical attention or referral. I mean, these are things that the Education Ministry should be looking at. We had 18% of children with specific learning disorder, which is higher than the given prevalence in the given population. We also had a few children with attention deficit hyperactivity disorder. Family dysfunction, this is another huge problem for children. Only 46.7% of the children were living with both parents at the time of the incident. Others, either mother alone, father alone, grandmother, grandparents. Why? Well, there was divorce or separation, 23%. Employment overseas, 12%. Deaths, young deaths, because these children are still young. How did they die? Road traffic accidents, drugs, and issues like that. So, family dysfunction leads to violence, well, can contribute to violence against children or expose children to violence against children, and this is what we saw. The other bugbear for children right now is illicit drugs being used, and this is impacting heavily on children. We studied the data in 2019 and 2020, and we saw a significant increase by 2019. The total admissions to the unit in that 2-year period was 220, and overall drug usage as a co-factor was 26.8%. Substance use by the perpetrator, 13.7, and here we are, parent or caregiver, substance user, 15.9, substance dealing, 1.4. Perpetrator, substance user, 15.3%. Very worrying, we need to do something. Placement of children, I'm just giving you some examples of what we do. We do not send these children to institutions. We don't believe that they are little heavens for children. They need family. We had these 3 boys, aged 3, 7, and 9, who were intentionally poisoned by the mother. The maternal grandmother was willing to care for them, but she had no means to do so. The children had to very sadly be sent to a child development center. We managed by convincing the probation officers that they had to go to the same center because the younger one was under 5, he would otherwise gone to another child development center. We fought for that and he did go. But we managed then to do a family strengthening program together with SOS Villages, and the 3 children are now reunited with the grandmother and doing very well. They do family strengthening, they get a house for the family for 6 months, they pay the rent, and then the mother or grandmother, whoever the caregiver, is trained in vocational training so that she can earn for herself and then ultimately pay the rent and look after the children. We always, as I said, try to place children, if it is most possible to send the child back home, then to extended family or family-like care at SOS Villages. Education and life skills we stress a lot. That's the way to get these children back into society. We had a 15-year-old boy, I'm just giving examples, groomed by a man in the village with alcohol and drugs, sexually abused, became an alcoholic and a drug addict and dropped out of school, developed genital herpes. When he was seen by a community worker, they said, don't bother about this child, he cannot be rehabilitated. But we said, bring him here and we will do something. He said he had dropped out of school, and for several months he said, I'm not going back to school. But we managed to convince him. He sat his O-level examination. He studied at Lama Pierce. Tuition classes were given by medical students and doctors. And he obtained 5 simple passes at the at the O-levels, and he's now following vocational training in the A-level class of his school. Out of the pregnancies, 11 adolescents are back in school and 4 are following vocational training. 3 adolescents, as I said, we allowed this boy to study and sit for his O-levels. He went to the center from our facility, and 1 child, we conducted the O-level examinations through the examinations department. Supervision was done in our unit. So we give them their childhood back. We try to get them back into the education stream. And that works for these children. We have recommended, the Child Protection Committee of the Sri Lanka College of Pediatricians have recommended to the Ministry of Health that 8 other such facilities should be opened in the 8 other provinces, headed by a child protection lead pediatrician and a community pediatrician. And I think the benefits will be large if we can do this. And I'm leaving you with a few images of our facility. The one at the bottom is the new education space we were able to do recently. They do home gardening, they do yoga, they do a school timetable on a daily basis, and that's how we do rehabilitation. So this is our logo at Lama Piazza. Every child is told that though they have been in some muddy circumstances, that they should bloom like this beautiful lotus flower without any mud sticking on them, that they should bloom into a beautiful flower and spread the message, and be useful to the rest of the world. So they get a picture of this with them. If you can see, the education space has that logo painted on the wall. They get a picture of themselves with this, so that it's a reminder of the fact that they have been with us and that they have been helped and that we are always there to help them. They do keep coming back even after 18 years. They want us to see them. I will end by saying thank you and Ayubowan.
Thank you very much, Madam. Thank you very much for your very informative speech. And our second speaker is Professor Muditha Vidana Patirana, and that is, the topic is on medico-legal aspects of the management of child abuse and neglect. Professor Muditha is the Chair Professor of Forensic Medicine at the University of Sri Jawadanapura. He has authored 6 books and editors. He's the editor-in-chief of the Medico-Legal Journal of Sri Lanka. He has more than 200 scientific publications and has won several awards, including presidential awards. He has supervised more than 25 successful postgraduate trainees at the PGIM and several research students and elective students. He was a UN consultant in 2014 and 15 and conducted training of the trainers on the gender-based violence in Maldives. He was the 11th president of the College of Forensic Pathologists, and he is a council member of the Indo-Pacific Association of Law, Medicine and Science and the University of Sri Jawadanapura as well. Currently, he holds the vice president of the INPALMS and the Medical Legal Society of Sri Lanka. He was the former chairman of the National Child Protection Authority from 2020 to 2021 October. Sir, the podium is for you. Thank you, sir.
I would like to invite our speakers to join the panel on stage.
Madam, please.
Madam, would you please join us on stage? And Ms. Lasanthi Daskon, would you also take your seat on stage? Thank you. Over to you, Professor Muditha.
Thank you very much for that kind introduction. So, a young family following a very long love affair, they got married. Because of poverty, at last, wife decided to leave to Saudi Arabia. She served there for 7 years and unfortunately came back to Sri Lanka with a 5-year-old child. I was a diploma holder and I was working in Colombo, JMO's office. This was the child. Because of this illegitimate child, I'm sorry to say, there was a huge issue in the house. Husband started taking alcohol, started assaulting wife. Wife started assaulting the child. See the crooked nose here. See the backside of the body. Heated electric coil burns with keloid formation. Not only that, we hardly see pathognomonic injuries of child abuse. This is one of those. See, the anterior superior edges of almost all vertebral bodies are chipped off due to hyperflexion, touching the head on knees. These were the findings. So we had a case conference. Child was sent to Child Development Center, Lama Nivasya, and we saved that child. So my topic is medico-legal aspects of management of child abuse and neglect. Very good evening. Introduction to child abuse, international and national level. See the UN Child Rights Convention in 1989. So based on that, in 1998, the National Child Protection Authority Act was introduced and Child Protection Authority was developed in Sri Lanka. Now, for example, definitions, if we consider, so basic ones. Child, the definition of child means a person under the age of 18 years. You take the definition of child abuse, hardly the accepted uniform one single definition for child abuse. All experts cannot agree upon one definition, multiple definitions. According to National Child Protection Authority Act, child abuse is being defined as contravention or breaking of 17 offenses, 14 in Penal Code Act, 1 from Employment of Women, Young Persons and Children Act, then Care and Protection of Children and Young Persons Ordinance, then Compulsory Education and Education Ordinance. So incidents, victims, we get only 1/7 of the issue. It's iceberg phenomenon, unreported cases 6/7. But the huge number are vulnerable children. They have at risk of child abuse. Now, recent increase is due to increased awareness, increased reporting, as well as increased identification. For example, cyber crimes identification has been increased. In addition to that, police identifications have been increased. First report should be sent within 24 hours of getting a complaint to any police station in Sri Lanka to the National Child Protection Authority. In addition to that, since 2021, we introduced an additional report, the second report, within 7 days of reporting to any police stations. Then medico-legal aspects. It's not just confined to injuries. We have a lot of responsibilities. Law reforms, awareness, prevention, protection, monitoring, and management of child protection. We'll concentrate a little on about law reforms. For example, with National Child Protection Authority, we started law reforms in 5 areas in 2020, completed by July 2021. Uniform ages, 5 areas, 23 reforms were suggested. Combined cabinet papers with 6 ministries were done, and 5 laws were amended. Unfortunately, others have not been implemented yet. Then child-friendly police procedures. Prepared a circular for online for police ordinance, has not been implemented. Sentencing guidelines for judiciary, cabinet paper and Juvenile Sentencing Act was introduced, sent to 4 ministries, has not been implemented yet. Video evidence recording procedure, we developed an internal circular, and at last we got established for cabinet approval for establishment of 9 such video evidence recording centers in all 9 provinces. Then child-friendly court procedures, we concluded it. In fact, this was a huge victory of children of this country. A circular was issued in 2021 by Judicial Service Commission. If you read this, ශීර්ෂකර කරුණු සම්බන්ධයෙන් ජාතික ළමාරක්ෂකගේ ඉල්ලීමක් සලකා බැලූ අධිකරණ සේවා කමිෂන් සභාව at last they agreed for all 3 of our requests. A separate day was identified in high courts for children cases. On such days, priority should be given to children. And a yellow sticker, we suggested that they agreed it is applied for child abuse cases. So, national policy on daycare facilities, for example, could not do it for many years. Final draft was finalized in August 2021. This is the draft, has not been implemented yet. So, development of Foster Care Act. Most do not adopt children. Stakeholder meeting held in August 2021 has not been finished yet. Management guidelines for maternal substance abuse. We got a lot of cases. Addicted mothers came for delivery at Disoisa Hospital during case conferences. So subcommittee was appointed. We had many discussions. Has not been implemented yet. Then awareness on child abuse and neglect. Take for an example, website should be updated. This was the National Child Protection Authority website. Not child friendly or not mobile friendly. We developed it. Now it's child friendly and mobile friendly. So launched in October 2021. So introduce social media campaigns such as sharing micrographs. I hardly see this in media. We need to start again. Developing awareness materials. In 2021, developed 3 films. Chamudage Katav, Oya Then Lukudamek, then Pinimal Teledrama. Then for the first time, NCP Media Unit prepared films by themselves. Their own cameras, all that. Then developing theme songs. I have shared all these among our members, my friends. So this is National Child Protection Authority song, theme song. Then to promote 1929, we developed another theme song. So improving knowledge on laws, we all know in 20 years there will be, if we start today, there will be a generation who has knowledge on the laws and rights of their children. Started developing 3 extra reading books on child and law for grade 6, 7, 8, 9, 10, 11. Life and law, society and law, child and law, environment and law, social protection and law, justice and law. We concluded by 2021 October, grade 6, 7 book. Others have not been concluded. Awareness, identification of children with invisible disabilities. As you all know, during COVID at Aludgama, without knowing regarding these invisible disabilities, police arrested an autism child. Based on that incident, we got together a lot of stakeholders, established a methodology to identify children with invisible disabilities. We didn't stop there. We made a small tutorial I shared with my friends in the uni. Education tutorial identification. You can win internet generated certificate as well. So prevention. If you take national database of child abuse, could not prepare for last 23 years. We initiated, launched it in October 21. Had been entering data with 10 hands, 5 people here, more than 2,000 uploaders. See, it has 4 components. NCPA complaint database, police complaint database, video evidence database, vulnerable. We launched in October, has not been implemented yet. Prevention of cyber crimes, developing cyber surveillance unit. We had a cyber investigation converted to cyber surveillance unit. We got bad sites cancelled and 10 cadres got approved, had not been recruited yet. Prevention of mobile games addiction. As you all know, mobile games are like digital heroin. So, and cyber crimes. So for that, we initiated a mobile game app, Sara Kids app. You can download free of charge. We launched it in October 2021. from Play Store. So to counter child sexual abuse with the sexual HIV and STD program, Play Store. So to counter child sex, create awareness among children and adults and children on HIV and AIDS with Health Ministry. I have shared all these soft copies with my colleagues. Then Prevention of Child Trafficking, another beautiful book with Faculty of Law, University of Colombo, in all 3 languages. And awareness programs are being conducted now. So corporal punishment, instead of punishments, we encourage discipline. We published this one in 2021, especially for teachers and parents. You take prevention of abuse children with disabilities. University degree program was initiated. We were requested by UGC, but subcommittee, all that couldn't finish. Then protection of abused children. So child helpline was there for more than 20 years. In 2020 to 2021, we introduced new 7 modes of child protection app. The address was shortened. Any person can write in 2 seconds, 1929 Sri Javadanapura. Telephone numbers were given to their job, not to persons. They are forever. The posters have been distributed in all hospitals. So email addresses, even we don't have telephones for our positions. So these young gentlemen, they have. Twitter, Facebook, WhatsApp, all are there. So strengthening child fund, we can earn a lot of dollars for children. Introduce a payment gateway from BOC, launched in 2021 October, has not been implemented yet. This is a disaster. Psychologically abused children. So psychosocial support, counseling and follow-up available in 25 districts. See, counselors are there in NCPA, social services, Women's Bureau, Mithru PSA, hospitals, all data are there, contactable. What would include all teachers, 3,000 teachers. So adoption of recovery curriculum, we say we became doctors because we were punished in our childhood by our parents and teachers. That means we have not been recovered from those punishments still. Therefore, complete recovery, there is a curriculum. We wrote to Cheryl, Cries of USA, agreed in writing. So we started in 2021, has not been finished. Sarapasa, beautiful case studies. So you can use this tutorial as well and win a certificate also. So media. So cyber abuse, I wanted to establish a separate portal, Internet Watch Foundation, but couldn't do. Monitoring, just monitoring was done. I increased from 369 to 50,000 by introducing an ODK digital platform. So these are the results. We could identify all the, so monitoring. Finally, management of child abuse and neglect. Give me 2 minutes. Hospital management, medical officer's duty, when to admit if we cannot provide OPD treatments, or when the abuser is in his house or place of living. So multidisciplinary approach was introduced. Case conferences, clinical as well as institutional. Psychosocial management, multidisciplinary approach. Then prevent re-victimization within the hospital. Re-victimization, as Madam described, various stakeholders within the hospital obtain the history of the incident repeatedly. Prevent re-victimization, we adopt 3 things. One is clinical case conference. Second one, as Madam explained, Lamar Pearson and video evidence recording. So regarding clinical case conference, prevent re-victimization within 24 hours, JMO, pediatrician, psychiatrist, all combine together and come to a collective decision. Then, to prevent secondary victimization, abuse, once again by same or another abuser, prevent by conducting institutional case conferences. Objectives: to prevent secondary victimization, confirm the diagnosis or care and protection, for example, send back to family or hand over to a trusted relative or send to a government home. Institutional case conference organized by the clinician. Participants are clinicians, parents, police officers, probation officers, child protection officers, child right promotion officers. And case conference and management guidelines are laid down in this book we wrote in all 3 languages in 2020. So I have shared all the soft copies. Sent to government home, then we have to monitor for re-victimization, secondary victimization. Abusers management should be rehabilitated. Final slide, challenges we face. Child abuse and neglect victims. You will be surprised. There are no homes for the abused victims in Sri Lanka. Only for Anatha Lamainta Pamanaitian. So we have suggested to introduce safe houses in each province and introduce an on-call system for probation officers. In this criminal justice system, we are on call, judges are on call, police on call, all are on call except probation officers. We should introduce. Child-friendly media should be introduced, healthy TV watching. We were planning to introduce this, we didn't have time. We must introduce a coding system. General, adults only, children, or adult with child, parent under parent guidance. And less than 3 years, no screen time should be advised. Then modern slavery or invisible children, that is child labor, child marriages, child prostitution, child trafficking. We need a huge research to explore these huge menaces in our society. Thank you.
Thank you, sir, for that informative presentation describing what has already been done and what more to be done in terms of child protection. Let's move on to the next presentation, which is child abuse in Sri Lanka, gaps in the legal framework and social implications, will be presented by Ms. Lasanthi Daskon, attorney at law. And she is also the Deputy Country Director of International Foundation for Electoral Systems in Sri Lanka, with 20 years of experience working to promote inclusion of groups and communities who face marginalizing barriers. She focuses mainly on the rights of persons with disabilities. Ms. Daskon supports diverse stakeholders in their efforts to further promote inclusion. She is also visiting lecturer at the Department of Disability Studies at the University of Kelaniya and the Center for Disability Research, Education and Practice of Faculty of Arts, University of Colombo. Over to you, Ms. Daskon.
Thank you so much for the very kind introduction, and thank you for this opportunity given to me. And as you heard, I'm not necessarily per se a child rights expert. I must state that in the outset, my expertise on disability, and I have done some work on children with disabilities and the abuse and neglect and the violation of their rights. And I must acknowledge the presentations made by Professor Aswini and Professor Vidhana Patiranan for their informative presentations. I also wish to acknowledge my colleagues and friends who work in the field of rights of children, people like Mr. Harshana Nanakara, a very prominent child rights activist, and some of my friends in the judiciary who are very passionate about the about this issue who have also helped me in making this presentation. So the legal framework and the issues I think Professor Vidhana Pathirana also touched upon, but I will start my presentation with this newspaper article which I found from February this year, where it says that University of Sri Travadanapura study has found that 28% of victims of child abuse are under 12 years of age, and 94% of those are abused by known persons. So this is a social dilemma. This is an issue. This, as my other panelists also acknowledged, it's an issue for the country, for everyone to be concerned with and not to be neglected any further. So again, I know Professor Vidhana Pathirana also attributed to the CRC. So the CRC recognizes the Convention on the United Nations Convention on the Rights of the Child, recognizes that a child is any person who's below the age of 18, unless the local law recognizes the child to have attained majority earlier. And there is a national child protection policy of 2020 which I found, which recognizes all persons under 18 as children, again unless majority is attained earlier. So very briefly to speak about the international legal framework, the UN Convention on the Rights of the Child, which Sri Lanka ratified, it is not directly incorporated into a Sri Lankan law, which doesn't necessarily happen in Sri Lanka, but Sri Lanka being a dualist country, enabling legislation needs to be enacted. So the National Child Protection Authority Act and some of the legal reforms we have seen in the penal code and in the criminal justice system, which Professor Vidhana Pathirana and Dr. Ashwini also mentioned, are influenced by the CRC provisions. And then we have also signed the optional protocol to the CRC on the involvement of children in armed conflict, and also the Convention on the Rights of the Child on sale of children, child prostitution, and child pornography. We are also a state party, having ratified in 1981 to the Convention on the Elimination of All Forms of Discrimination Against Women, which we call as CEDAW, and which also has specific mention on the girl child. And more recently, the Convention on the Rights of People with Disabilities, which has specific provisions on the rights of children with disabilities with regard to the discrimination they face on being children and also being children with disabilities. Again, CRPD has been ratified, but we are awaiting enabling legislation to be introduced in Sri Lanka, which has been a very frustrating, prolonged, unnecessarily prolonged process due to reasons which I am unable to explain, unfortunately. So when we talk about the CRC, the protection, the 4 Ps, participation by children in decisions affecting them, protection of children against discrimination and all forms of neglect and exploitation, prevention of harm to them, provision of assistance to children for their basic needs. So these are the main things that we need to look at, and protection irrespective of the child's or his or her parents or legal guardians' race, color. So irrespective of any difference that we may like to attribute to disability, birth status, social, cultural origin, language, sex, gender orientation, anything. protection of children is mandatory. And CRPD, Convention on the Rights of People with Disabilities, in its preamble itself recognizes the rights of children with disabilities, that they should have full enjoyment of all human rights and fundamental freedoms on an equal basis with other children, and respect for evolving capacities of children with disabilities is recognized, and under the general obligations, it recognizes the development and implementation of legislation and policies to implement the convention, and in other decision-making processes concerning issues relating to persons with disabilities, including children with disabilities, and state parties need to do this in consultation with people with disabilities. So UNICEF Sri Lanka recognizes, and this is recognized the world over, children with disabilities are at greater risk. And essential services, the justice system, and law enforcement system, none of these, as we know, are accessible to children with disabilities. And because children with disabilities in countries like ours are left out of education with no access, less access, and without having access to information, they are at a greater risk of abuse, neglect, and exploitation. And most of the time, because people with disabilities, children with disabilities also represent families who come from poverty, access to services and knowledge and awareness of parents and protective measures are very minimal. So local legal framework, I will not go much into it, but then Professor Vidhana Pathirana extensively explained the great work done by the NCPA. In terms of disability, we have a national policy on disability, way too old, national policy on child protection, rights of persons with disabilities, children's charter. I think Professor Vidhana Pathirana's presentation had much more information on the laws than in mine. And then in the definition of a child, the problem comes in the legal, in the criminal justice system, is the gap between these ages, right? In the Children and Young Persons Ordinance, a child is a person under the age of 14, which was now, which has been, I think, now raised with the amendment to 16. But generally, under the general definition, this is a child is someone between 18. But because of this 2-year discrepancy, children who are sent to probation care between the ages of 16 and 18 face a problem, because under the Children and Young Persons Ordinance, they're not children. So they cannot be sent to the children's facilities where there are children. So then there are these children left out within this gap of 2 years, and correct me if I'm wrong, but this is what I spoke to some of my friends working in the judiciary, so they pointed out this is one of the biggest problems, because again, there is no codification of all laws that relate to children and then their abuse. So again, I wanted to speak about the opportunities. So we have a fundamental rights framework which the Supreme Court broadly interprets to include rights of children, and then this bizarre case, Ishara Anjali versus Bogawat and others, where a police officer, a woman police officer, subjected a child to see a series of abuse. Justice Aluvihari says children are to benefit from all the human rights guarantees available to adults. In addition, children shall be treated in a manner which promotes their sense of dignity and worth, which facilitates their reintegration into society, which reflects the best interests of the child, and which takes into account the needs of a person of that age. I will not speak of the NCPA because Professor Vidhana Pathirana spoke about this. So again, to reinstate what already the former speakers mentioned, the sexual abuse is mainly by persons closer to the child, so there is a power dynamic, and also with the patriarchal attitudes in our society, it becomes very difficult for a child to recognize that what they're going through is abuse, and also to report the abuse. This is very challenging, and then we haven't empowered our children enough. We haven't empowered our children enough to even understand what they are going through. This is the gap in our education system, where education on sexual and reproductive rights is not recognized, and most of these issues are shoved under the carpet in the name of culture and not in national interest, sorry, but I mean mainly on the grounds of culture and religion. These things are not brought forward, but it is an issue. We really need to understand, recognize, acknowledge that this is a issue, and this is why cases go unreported. This is why it becomes an issue to bring people before the law, bring the perpetrators before the law. So poverty is an issue, and in society, again, due to stigma and discrimination, victim blaming is an issue. And Professor Ashwini also mentioned trauma, re-traumatizing of children through the process, through the justice system, through the law enforcement process, by society. This is an issue. Lack of resources to support victims, and then any crisis exacerbates these challenges. COVID, we know, increased these numbers, economic crisis now, and then the conflicts and natural disasters. So I will also not speak too much about the challenges because I already mentioned these. There are shortfalls in our criminal justice system, laws delays, as Professor Ashwini also spoke about, and people with intellectual disabilities who face sexual assault and abuse are much more higher, and they are unable to report, they are unable to even describe what they experience because of their disability. And also we've had this ongoing conversation about, say for example, children who are deaf, who have no mode of communication with law enforcement authorities or a trusted person or in the justice system, also they're left out. So social implications, we all know this is a long-term issue. It brings the abused child, brings into society a traumatized mind, which affects society, and it affects extended networks. And I mean, as a society, I would say we would need to be ashamed of this, because if we cannot protect our children, then we have failed as a society. So I think, again, just to reaffirm, we need to review the existing legal frameworks and to see how these could be reframed in the best interest of the child, codify laws that ensure all laws, including personal laws, protects the right of child, and then recognizes children as children, and education reforms, invest in awareness strategies, awareness raising among law enforcement, the judiciary, school teachers, everyone, the stakeholders, and then also children with disabilities, the unique challenges faced by them. So medical professionals, again, Professor Ashwini spoke about this. So duty of care towards child victims, the need for the medical profession to work very closely with law enforcement, judiciary, and also the policy makers, because they are the first respondents, or first people that encounter these children and who interact with these children and who can identify the issues and look for solutions, and ensure that the child victims are not re-traumatized, confidentiality, ensuring confidentiality, and also take a leadership role as the medical profession on awareness strategies, help break stereotypes and work closely with stakeholders, contribute to educational reforms, and establish collaborations with children, women, and disability rights organizations. So this is what I have to say, summing up just in time. Thank you very much for your time.
Thank you very much, Ms. Daskon. And as we are running out of time, we can entertain a few questions, just 2 or 3 questions only. If anybody has any questions, please, it's time for you to. Yeah. This one. Yes.
Thank you very much. Maybe the question is directed to Professor Ashwini or Professor Mudita. I see a lot of things that are going on in Sri Lanka in terms of the National Child Protection Authority and all that. But in terms of health, what is the Ministry of Health or the focal point at the Ministry of Health? What is their contribution towards child protection?
Thank you for that question. The focal point is the Family Health Bureau. And they are the ones who are looking after this area. We've had discussions with them. When we did the guideline, there was a representative from the director was with us throughout, but directors have changed. I wish, in answer to your question, I wish they would take child protection higher up in their agenda for the sake of the children. That is, what I'm trying to say is the Ministry of Health has to prioritize this. And I have to say that it is insufficient.
Are there any online questions?
Thank you very much for that extremely insightful and thought-provoking session. I think it highlighted some of the grave realities that the children in our very own society are facing. I would like to thank our chairpersons once again, Professor Gonili Yanage and Professor Sanjay Huladua, for chairing that session, and I would like to invite you to present a certificate of appreciation to our speakers.
Main session, the last hour.
Recording in progress.
Interesting. Okay, so now I would like to, we're coming to the keynote address for the day, and we're going to call upon Dr. Maria Guevara to give the keynote address. Maria is the current International Medical Secretary for MSF, Doctors Without Borders, based in Geneva. She's also a Safe Steps First Aid Ambassador for a collaborative Pan-Asia program to promote awareness and increase knowledge of first aid skills across the region. Her recent nominative appointments include being a member of the WHO-led Independent Allocation of Vaccines Group and the advisory group of Sunway Centre for Planetary Health. Her work in the humanitarian sector began in 2004, and she's been working in Asia, Africa, and South America. Big long list. In her role as International Medical Secretary, she serves as a key member of the MSF International Office in a trio with the Secretary General and the International President, working to promote medical leadership, advise and ensure accountability for defined medical priorities, innovation and operational strategies across the movement, as much as provide key direction and input on positioning and representation. Dr. Guevara was trained in pulmonary and critical care medicine at the University of Florida in USA and holds a diploma in tropical medicine and hygiene from the Liverpool School of Tropical Medicine and a Master's of Science in Global Health Policy from the London School of Hygiene and Tropical Medicine. And her special interests are global health, response to emergencies, and planetary health. Maria, are you there online?
I am.
Great. Welcome. Welcome to Sri Lanka.
Thank you so much for that warm introduction, Helen. And it's great to be here with you all. Good morning, good afternoon, good evening. I'm not sure where people are tuning in, but I realize it's evening for you all already. It is quite an honor and a pleasure to give the keynote address at this year's MSF Asia Scientific Day held in collaboration with Sri Lanka University. I apologize that I cannot be there with you all in person, but I guess in the age of climate change, of which we're speaking of today, speaking to you all virtually may be the more sustainable way. But just to say, I was there 5 years ago as participant in the MSF Asia Scientific Day when climate change and environmental degradation started to gain momentum as topics for discussion at MSF. Already then, our keynote speaker at the time called in virtually from the East Coast of the US. It was Professor Adil Najam, who we have the great fortune to have once more amongst us as panelists today. Then he warned us of the coming crises, which is in plural, and that already in 2017, if not even decades before, we are already living in the age of adaptation. It is here and it is now. And it is precisely this point that I wanted to build on the discussions today, that the crises have come and it is time to not only mitigate, but adapt. As a medical humanitarian organization, crises and emergencies are MSF's bread and butter, and climate change is our issue. Highlighting the importance of recognizing and acting on responsibility and vulnerability, I wanted to speak along 3 points. The first, science is science, which is perfect for this scientific day, because climate change is real, and it is a health crisis. 2, at MSF, we often speak of the field. What does it mean in the age of climate change and adaptation when climate change levels the playing field, affecting all lands one way or another? And 3, climate change is a humanitarian crisis where the impacts are still mainly borne by the global south. So firstly, why does it matter? As the largest scientific collaboration peer review process in the world, to which some amongst us of you today have contributed, the Intergovernmental Panel on Climate Change, in their 6th report, basically drives the point that the science is clear. And the verdict is grim. That is, the planet is no doubt heating at a rate never seen before, and it is our fault. There is little hope remaining of avoiding a worst-case scenario, and the effects of climate change will be overwhelmingly negative, with the most vulnerable being the most impacted. The report unequivocally links climate change to negative health impacts. Climate change is a health crisis. From extreme heat causing increased disease and death and more frequent and more severe extreme weather events, to increasing incidence of foodborne, waterborne, or vector-borne diseases, more malnutrition due to rising food insecurity, emergence of new infectious diseases, especially of animal origin, as with COVID and now monkeypox, or a rise in chronic diseases, a topic that you've discussed today. To climate change and environmental degradations contributing to violent conflict and population displacement. And for the first time, mental health has been is noted in the report as being negatively impacted by climate change. From the MSF perspective, we've witnessed every single health impact highlighted, and as a medical humanitarian organization focused on humanity, this human element is critical. We humans are the main cause of today's threats, the ones burning fossil fuels and clearing trees, releasing heat-trapping gases in the atmosphere. While at MSF we are addressing this through different frames, specifically looking through a planetary health lens, makes sense as it reinforces and reminds us that our well-being is interdependent with that of planet Earth, that we are ultimately responsible for much of the decline in the ecosystem, that the time to act is now, and that we cannot address this in isolation. That is, we must radically collaborate, cross boundaries, build alliances, and develop partnerships across all sectors. By owning this responsibility, we are taking the first step to any sustainable and real action. Which brings me to my second point. What do we understand as field today? From the Lancet Countdown 2020 report, they say no continent, country, or community is immune from the health impacts of climate change. It doesn't matter where you live. Climate change threatens health, and basic necessities will be disrupted. For MSF, a large proportion of the health problems managed in our projects are considered climate-sensitive diseases, as diarrheal illnesses like cholera, vector-borne diseases like malaria, dengue or yellow fever, and infections associated with undernutrition. A few more newly emerging infectious diseases such as Ebola and COVID. Of the 30-plus new human pathogens detected in the last 3 decades, 75% of them are zoonoses originating in animals. Due to the increased interface between humans and animals in the same environments, whether due to climate change, environmental degradation, or biodiversity loss. And these past 2 years have shown all of us that no one is immune. The pandemic has proven that viruses have no borders, as is the case with climate change. COVID has also shown us a collective unpreparedness, sounding out an alarm to a new frontier of fragility and vulnerability. That is, the crises of tomorrow are not only where today are considered humanitarian hotspots, but will also be in the, quote, developed world, the so-called global north. For MSF, we had to be agile and adapt. It was new for us to deploy and open missions in 2020 in Belgium, in Spain, Switzerland, Italy, or US, where I myself was part of the team that set up in Michigan. Our experience in managing outbreaks with limited resources was precisely the skill set needed at the time. We had to be flexible, finding alternative ways to provide workforce surge supports, while many of us were grounded, mainly reinforcing and empowering local staff and community. We had to be innovative in how we reach patients who could not come to the health facilities due to lockdown, stigma, or fear of the disease. We therefore increased the availability of telemedicine, provided online infection prevention and control trainings, ran health promotion campaigns on social media, and even managed WhatsApp groups for traditional healers. We essentially work together with patients and communities across the globe, and examples of such collaborations you've all heard already. But who is most affected? While COVID may have affected us all, the ongoing impact, however, remains uneven. Similarly, with climate change, the vulnerability burden is still borne disproportionately by those in humanitarian hotspots, and they are where MSF has worked for the last 50 years. Climate change is a humanitarian crisis, and the difference between the fields is in the capacity to respond, adapt, and bounce back. In humanitarian settings, compounding, converging, and cascading emergencies do not allow for an already weakened system to recuperate. To answer to needs at MSF, we are working to adapt our programs to be more efficient and climate smart in parallel with working to mitigate our carbon footprint and environmental harms. Operational adaptation looks at improving our context analysis and assessments and innovating in how to better anticipate, predict, and prepare for emergencies. Lessons from Pakistan the past years on the severe heat waves that hit the country, causing increased heat-related deaths and exposure events, pushed our teams to integrate heat wave planning into our emergency preparedness strategy through community sensitization, establishing water points, providing outpatient medical services, and supporting local actors in their preparedness. Coordination and collaboration with local emergency responders are critical steps. Malaria is easily the #1 reason for consultation and hospitalization in many of our projects, treating over 2.7 million malaria cases in 2020 alone, despite our actions in COVID. Since the past year, we are working to take our meteorological and climate anticipation project and linking it to our malaria anticipation project, which seeks to use climate information and environmental factors to better understand the impact on seasonal malaria and to anticipate the timing and intensity of seasonal disease burden. The next step will look into whether this information can be useful for operational decision-making and on how to better utilize early warning systems, identify opportunities for anticipatory action, and operational research that hopefully we can bring to the next scientific day. There are many more innovative ways to be climate smart.
To our speakers.
But we cannot do all this alone. As it is, humanitarian needs already outstrip the capacity of governments and global humanitarian actors to respond. And needs are set to multiply in ever-increasing complex emergencies, as demonstrated by COVID, in the context of anthropogenic climate change and environmental degradation. The response requires the whole of society. Everyone has a role and responsibility. The bottom line, climate change is a crisis that we cannot address in isolation. And as said, we must radically collaborate and cross boundaries, build alliances, and develop partnerships across all sectors. And today is the first step in that direction. I am very much looking forward to hearing and learning from our expert panel on how we can do this better together. Thank you.
Thank you very much, Maria. That's a very nice segue as well. But first of all, maybe there are some questions from the audience here in the room for Maria. I don't see any hands up. Okay. I have one online question for you, Maria, if you wouldn't mind taking it before we start with the panel.
Sure.
Okay. This is it's a bit political, perhaps. Is climate change response, does it also reflect neocolonialism, where local community engagement is not considered or consulted? What would you answer?
Can you repeat that?
Sorry.
Can you repeat the question?
Is the climate change response also, does the climate change response also reflect neocolonialism, where local community or engagement is not considered or consulted? Local communities are not consulted, I think.
So that is an interesting question, and in the environment that we see today, in the discussions on diversity, equity, inclusion, much discussions on racism and discrimination and decolonization. You know, the answer for climate change is to look at it as a collective, and it has to include local as much as global response. They have to be connected. And I think the call here is that we cannot do this separately, and we need to listen to the communities that are probably the most well adapted, know better their environment, and know better how to work with nature. If we just take indigenous populations, those who live in the forest, they are the guardians of the forest, who have many years worked and lived in protecting this environment. Without those forests, we wouldn't have the carbon sinks that we need today. But we need to actually open our eyes to that. We need to decolonize in a way, in the way we address global health today, and really act locally in as much as we want a global response. And we need to bring the community, the civil societies, all actors on the table. And that's what we need to keep pushing and raising awareness to. And this is why I think working with academics, working with different sectors, we can learn to build that bridge together and bring the voice to those who make policy decisions together. And I think this is why we are here as the community, to really learn from each other and listen from the local to the global.
Thank you for that comprehensive response, Maria. Thanks a million. I don't know if you're going to stick around to hear our next speakers, the panel, whom Farhat is going to introduce, both the subject and the people. I hand over to Farhat.
Thank you, Maria. I'm glad you did paint a picture that sends out alarm about the problem, that we need to solve the problem yesterday, and we are still sitting today and not doing anything. Before I invite our panelists, I would request all of you to hold on. This is almost the last session of the day. So, but then I'm sure the panelists, as We have gathered them together. We'll bring in very interesting perspectives of the panel title, that is Climate Crisis and Disease Burdens, the Science, Current Experience and Future Responses. I wanted to say something more about climate, but then Maria covered almost all of it. But there were a couple of things that I do still feel that need, I think, further re-emphasizing on how critical it is and how do we understand, because somewhere when we talk about numbers, they give you a better feel of what is happening around the world. So if we have to look at, as per IPCC, 69.9 global deaths in 2019 were due to diseases that are climate sensitive. That would give you an indication of where we are. These are diseases, we heard a bit about dengue in the morning, we will hear more about it in our panel today, diseases like malaria. If we look in our own surroundings, we do see extreme climate events, like you see the change, extreme heat waves, frequent cyclones. We just witnessed an extreme bout of rain, so, and also I understood today that Sri Lanka has 6 seasons, so also the blurring of seasons. No, it was Bangladesh, to be very right. Yeah. So we are not today suddenly recognizing there is a link between climate and health. It is something that has been there for many, many years, and there have been people from time to time sounding this alarm bell that we need to act, not act as only individuals, but act globally as one family, because it is not something that is only going to affect a certain part of the world. So if we look at something that was very interesting, we know that people move around the world for various reasons. There are people on the move that go around because of political reasons, they cannot live anymore in their country. So we are known to the term refugees, but there is something that is called climate refugees. And this was a term that was coined in the year 1985 by United Nations Environment Programme. And as per UNHCR, just to give you a bit of indication on what does it mean for all of us, we could potentially see 1.2 billion people displaced by 2050 if the current situation as it is keeps on going. It's with the current trajectory we're talking about. So we have to understand what does it mean, 1.2 billion people on the move. So without much ado, I'm going to go and invite my panelists. So I'll start with the first one, and I will give a brief introduction every time I will invite the panelists to speak on. So our first panelist for this session is Dr. Purnima Prabhakan. She is the Deputy Director for Center for Environment Health, Public Health Foundation of India. She is an epidemiologist and public health researcher with 18 years of experience with current areas of work spanning environment, health and non-communicable diseases, research, technical consultation, teaching, community engagement and health sector leadership for environmental issues. She is currently an additional professor, head environment health and deputy director of the Center for Environment Health at the PHFI India, where she leads a team of researchers and consultants on research, training, advocacy, capacity building and remediation for environmental healthy issues spanning air pollution, climate change, water, sanitation, hygiene, chemical and heavy metal exposures, and children's environmental health. Over to you, Purnima, to enlighten us with your presentation.
Thank you very much. Greetings to everyone in this audience today. At the outset, let me start by thanking MSF. I'm sorry, I have to. Sorry, apologize for that. The perils of working from home. At the outset, I just wanted to extend my gratitude and appreciation to MSF for this invitation this evening to this webinar. It's really a pleasure to be talking to MSF. I have interacted with them on several occasions, and it couldn't have been a better start with the opening plenary by Dr. Guevara, where she so eloquently outlined the crisis that we are all in the midst of beyond the COVID-19 crisis. So I think my focus in this talk will be on the challenges and opportunities for the health sector. And I think I was scheduled to speak after Dr. Adil Najam, who was going to talk about the climate-sensitive illnesses and the disease burden associated with the climate crisis. But I think because of a conflict in my schedule, I'm going first. So thank you for the opportunity to be here. So in the next few minutes, I wanted to bring us all on the same page. I don't want to preach to the audience, but why are we talking about climate change? We all understand now that it is the biggest public health challenge of the 21st century. But the good news is that it is also the biggest public health opportunity of the 21st century. And what we mean by that is that we probably are already well enough aware about the problem that we have on our hands. And we have very many tools and resources now that we could use to deal with the climate crisis. The question that I am going to address in my talk is, does the health sector have a role? And now that seems like a very obvious question, but I want to take it from two lenses. One is what Dr. Guerra very nicely put out in her opening talk about the growing burden of climate-sensitive illnesses. And therefore, the health sector does have a role because we need to prepare our health systems. And before even the preparedness, I think we need to build awareness amongst our healthcare professionals about this growing burden of climate-sensitive illnesses locally as well as globally. And the impacts are very many. I'm not even going to begin explaining this graphic, but just to say that the changing climatic conditions have a range of impacts on the health of populations in every part of the world. Climate change is really an equalizer. There is no geography that is spared. It's heat waves in one part of the world. It may be deteriorating air quality in the region where I live in India. It may be changes in vector ecology. It may be changes due to, disease burden due to impacts on our water and food supply. So whatever those impacts, they are wide ranging. And therefore we need to build the capacities of our healthcare professionals, doctors, nurses, and the medical students who are already in the training programs about the climate sensitive illnesses, the escalation that we're going to see in this disease burden. So certainly the health sector has a role in the climate crisis. But here is another lens that I want to bring to you today. This is about the paradoxical situation of the emissions that healthcare operations have. The healthcare's climate footprint is equivalent to 4.4% or nearly 5% of the global greenhouse gas emissions. And this revelation came to us quite recently in the year 2019 with this report that was published by an international NGO called Healthcare Without Harm. Many of you may be familiar with this. This is a very technical exercise that was done to evaluate what is the quantum of emissions from health sectors and health systems around the world. So cumulatively, it contributes around 5%. And if the health sector, which is hospitals and healthcare facilities around the world, were clubbed together and ranked along with countries everywhere, the health sector would be ranked 5th. We are responsible for greenhouse gas emissions as well. And that seems like a very paradoxical situation. So if we were to summarize our thoughts over there, what links climate change and healthcare? There's increasing recognition of the impacts of climate change on health. There's therefore going to be a growing dependence on healthcare services, but also our own emissions to deal with. We therefore need requisite capacity, both knowledge as well as infrastructure, to handle that growing burden of diseases, but at the same time, we need to reduce our own carbon footprint. And the question that we are asking ourselves today is, are we prepared? And really, many times, in many parts of the world, the answer is probably a no. We are not yet fully prepared to deal with this climate crisis together collectively as a health system. And I think COVID showed us that as well now. There's much that is left wanting in terms of healthcare delivery. There's inequitable distribution and access to healthcare. And the climate crisis is just going to accentuate that need. And this is really, therefore, a wake-up call for us. So what we are doing, I'm going to then walk you through some examples of best practices or at least a start that we have in India, recognizing the importance of the climate crisis, the Ministry of Health in the Government of India actually initiated a national program for climate change and human health. And within that program, our organization has started talking about the concept of climate smart healthcare. And when we talk about being climate smart in healthcare delivery, we really are talking about two pillars of work. One is the resilience or the preparedness or the adaptation response to deal with the growing disease burden, which I think all of us are talking about in a big way and in different parts of the world. But there is this other important pillar of mitigation, which is about reducing our climate footprint in healthcare delivery, or we can use a simple layman's term of greening the health system. And when I say greening, it's not just about planting trees, but there are very many initiatives that a healthcare facility can take to reduce its own climate footprint. And these two pillars of action, the resilience and the mitigation in healthcare, constitute the climate smart healthcare. So a prepared health system, but also a health system that is starting to decarbonize its activities. And just to give a sense of what a health facility's climate footprint constitutes, this is just a snapshot of the proportion of emissions from different activities within a healthcare facility. So there's a big proportion that comes from the use of energy. We also have a range of requirements, needs within a healthcare facility. We need basic supply of energy, we need water, we need transport, both for patient and physician commute, but also for our supplies. We need medical equipment, we need pharmaceuticals to be supplied to us, and they all involve a supply chain. There's also our healthcare waste. That too has a footprint. How we optimally manage our healthcare waste is also a very important part of our carbon footprint. And there's a whole lot of other things that we have to use within healthcare delivery. So the cumulative health sector footprint is a huge one, but a big proportion of that comes from the supply chain to any healthcare facilities. So what have we started doing in India is starting from these kinds of peripheral healthcare centers. This is a primary healthcare center in a state in the middle central part of India, but this is a private hospital in the capital city of New Delhi. And a simple step that all of them have started taking is to transition away from polluting fuels or from grid-powered electricity to renewable, cleaner forms of energy like solar. And a framework that our center is now developing for the national program includes all of these components. So it starts from selecting a site for your healthcare facility. For example, if you're in a very flood-prone area and healthcare facilities have been washed away in a flood, we can think about reconstructing or placing the healthcare facility based on the historical flood levels of that area. So take into account various climate vulnerabilities in your region and decide where you need to have your healthcare facilities. Think about what you can do for sustainable buildings and infrastructure. We need not just functional resilience in the face of acute climate events. We can't afford to be the first building to be washed away. We need to be strong in our infrastructure, but also very resilient. And therefore, we think about building and infrastructure. We have to optimize how we are using our natural resources. Water, can we think of recycling our water? Can we minimize water use? Can we harvest rainwater? So these are some of the initiatives that you can take in terms of optimal energy resources. Waste management, but also sustainable procurement. This is a very important space now. Can we build demand for healthcare equipment or pharmaceuticals produced by manufacturers and supplied by manufacturers that is only produced in sustainable production units? Are they taking into account sustainable manufacturing practices? Can we build a demand at the healthcare facility level for only procuring such goods and services? We'll do a big justice to reducing the supply chain's footprint. Of course, we need to be connected to climate information services because early warning systems are so important to have preparedness mechanisms ready and kicking into play as soon as we know there is an acute event that is going to hit us. At the center of it all is human resources. We need to build our health workforce in a very, very big way. We need capacity building, and at every level, we need climate leadership. And last but not the least, we need to unlock the financing mechanisms. We talk a lot nowadays about climate finance, about developing countries needing a very needs-based financing mechanism that is required for their climate adaptation and response. So we have included in the framework for the Indian National Program for Climate Change all of these components, besides the other components about dealing with climate sensitive illnesses, whether that's heat wave prone illnesses, air pollution, or flood prone disasters. We are also talking to our states about using an incremental approach. Everybody cannot do everything at the same time, but do use an incremental approach, starting with a baseline vulnerability assessment on not just your climate vulnerability in the region, but also what are the usual diseases that you see in your region. Start with those health audits, start with energy audits, and then plan, mobilize resources, and implement. And this is just an example of different initiatives that one can launch at the level of any healthcare facility. Look at initiatives under energy use, optimize your energy use energy efficient medical equipment, change to LED lighting, maybe cool roofs in a very heat wave prone area, and address your heating and cooling systems to become very energy efficient. I already mentioned the water initiatives, also optimal and safe waste handling and disposal. This is just to share a range of initiatives that has happened in very different areas and geographies across our own country. So this is a primary health center in a remote area that has been built, optimizing and leveraging natural ventilation and lighting. And here is an example of a boat clinic in the state of Assam, which has leveraged solar power to reduce, to render unhindered healthcare services to populations living along the riverside. There's also solar power that has been leveraged for vaccines, for example, decentralized renewable energy for cold chain. So we do not have to depend upon grid-powered, coal-fired thermal power plants for our electricity. And those initiatives are ones that we have been leveraging through the public health system in India. We also have a very big network of private hospitals in India. And to reach those hospitals, we have established a network of hospitals called the Health and Environment Leadership Platform. This is an India arm of a very global network that is hosted by Healthcare Without Harm called the Global Green and Healthy Hospitals. And today we have in our membership nearly 80 members representing about 7,700 private hospitals. And we are working with these hospitals to make them stewards for environmental awareness and themselves actually launch initiatives to become environmentally friendly and sustainable healthcare facilities. We are not alone in this initiative. There is a global launch of the Race to Zero last year, the COP conference that we are all aware of. Every sector is working towards decarbonization, and we in the health sector do not want to be left behind. And at the COP26 conference in Glasgow last November, health ministries of nearly 50 countries committed to decarbonization by 2050. And we are really looking forward to taking this conversation ahead for our region in the South Asia geography. And very soon, we are hoping to launch a platform for engagement around climate change and health issues in the South Asia region. And we really look forward to working with all our friends in the South Asia region for very many joint initiatives to address the climate crisis, collaborative and needs-based research, sharing of best practices, and how we can work together to decarbonize our health systems, but above all, to come together for climate and health leadership for impact. I'll stop there, and I'm not sure, I'm sorry if I've gone over time. Thank you, Dr. Pratt.
Thank you very much, and it deserves a round of applause. Dr. Purnima, really nice, not only talking about the problem at hand, but equally talking about some solutions that have been put into practice and how do we carry them forward. I'm aware that you have another commitment, so before I invite the other panelists, I'm just wondering if there are any questions from anyone in the room or online.
I will be here till for another 20 minutes, so if there is anything I can answer on
Sure.
as well.
There's already one
Sorry.
question for you.
There's just one. Sorry, Dr. Purnima. Thank you very much. That was very interesting. The question online is, do you see a drift in the decentralized dissemination of proactive models of healthcare?
Sorry, I didn't quite catch that. Do I see a
repeat
drift in?
the decentralized dissemination of proactive models of healthcare.
I think proactive is the key word over there. I think we are working in a very big way to increase that groundswell and momentum for awareness and sensitization of healthcare professionals in India, but also globally. In very many continents, we have been talking with health system professionals. So I think proactiveness is definitely there, and I think there is an appetite for change. And the health sector leadership has become the key. Like even the WHO says, I think the health sector professional voice is the one that is heard, and more than the doctors, I think the nurses. So we are really working to leverage that momentum and interest and sensitizing not just doctors, but also nurses and medical students in India. I think decentralized models of healthcare going down to frontline health workers. Everybody is getting sensitized about the issue of climate change.
Thank you. Thank you very much. Having the possibility of having you for another 20 minutes, so I'll leave and bring in the second speaker for the day. And the second speaker for the day is in the room and is known to many people here, at least in the offline audience. But I will still go ahead and introduce Professor Dr. Nilika Malavike. She was until recent as the head of Department of Immunology and Molecular Medicine, University of Shija Vardhanapura, Sri Lanka, and also an academic visitor at the University of Oxford since 2008 after completing her doctoral studies at the MRC Weatherall Institute of Molecular Medicine, University of Oxford. She is currently the head of Dengue Global Program and Science Affairs India for DNDi. She is a member of the Executive Committee of the International Society of Infectious Diseases since 2020 and a member of the Technical Advisory Group to the WHO COVID-19 Technology Access Pool. She is a Fellow of the Royal College of Physicians in London, the Royal College of Pathologists in 2015. She serves as an expert member of several governments' COVID-19 related technical advisory group. Welcome. And the stage is yours.
Thank you so much. I would like to thank the MSF for inviting me to talk about climate change and climate-sensitive vector-borne infections. So just to start, I think a lot of people must be wondering, especially in Sri Lanka, climate change has never been a topic among the medical profession. Never, not to my knowledge. And climate change is something that environmentalists speak about, other people speak about, but never doctors. So why are we speaking about climate change today? That is because the WHO this March declared climate change a public health emergency. And for many reasons, as you would have heard, but especially when it comes to vector-borne diseases, I think climate change has a huge effect on the vector-borne diseases. Now, if you look at the graph on your left-right, that is the dengue situation in Sri Lanka, where you can see over the years, starting from 2006 up to 2017, how dengue has spread, initially starting as an urban infection, spreading to almost all areas in Sri Lanka, and we do have outbreaks almost everywhere in Sri Lanka except in Nuwara where the altitude is high. Now, when it comes to globally, during the last 50 years, the increase in temperature has made it more favorable for transmission of Aedes-related infections, like 1.5% increase over the past 50 years. But according to predictions, and we know that the temperature is increasing, we have already felt the devastations that climate change has caused with temperature, rainfall, even in Sri Lanka. So there is an annual increase in 3.2 to 4.4% per decade in the ability of Aedes to spread infections. Now, although we are talking about dengue today, We know that Aedes mosquitoes spread many other infections like Zika, chikungunya, myorovirus infection is not found in Asia as far as we know. And of course, Culex transmits Japanese encephalitis and West Nile virus. And you might think, okay, we don't really have this. We have a vaccine for JE. Only dengue is a problem. Okay, only dengue is not a problem. So, for instance, in India, in over 13 states, and where there is a lot of testing happening in Kerala, they have identified Zika. They have been identifying Zika for a long time. We have never ever looked for it, and we have not found it. We know that we identified West Nile virus in Sri Lanka in 2014. JE has been there for a long time. So we have not looked for a lot of things, and just because we haven't looked for a lot of things, it doesn't mean that it doesn't exist. Also, because of this, the threat of the climate change and what it does to vector-borne diseases, the magnitude of the burden we are feeling today is going to increase. And I know there are a lot of clinicians sitting here today who actively treat patients with dengue, and hopefully, and they know what a challenge that is. But I don't think any of them would want the added challenge of increase in the dengue cases and addition of other vector-borne infections. Now, studies have been done in Sri Lanka about climate change and dengue by Dr. Hasita Thisera's group. And we know that from 2010 to 2019, there had been 3 El Nino temperature periods, climatic periods happening in Sri Lanka because of climate change. And what their study has shown that during these time periods, there was a significant increase in the vectors, Aedes vectors. There was increase in mosquito house index, the larval index, and all such indexes. So there were more vectors available for transmission of infection. So, but unfortunately, with the increase in temperatures, it is not that you get more vectors. Even worse things happen. So for instance, I don't know if you are aware that, if you have an infected person, the mosquito takes a blood meal from that infected person, the female mosquito who wants to lay eggs, and then goes and bites another person who is completely healthy. And from the time, from taking infected blood meal to go and infect a healthy person, a non-infected person, the virus multiplies within the mosquito, and that is called the external incubation period. With the increasing temperatures, this external incubation period declines. And also, the time taken for the mosquito larvae to reach their mature state also declines. So for instance, at 15 degrees centigrade, it takes 39.7 days for the mosquito larvae to mature. But at 35 degrees centigrade, it only takes 7.2 days. So you can see when the larvae mature faster, when the mosquito population is increased, and also when the infectivity period of the mosquito increases, that is bad news for all of us. And dengue does not affect all populations similarly. I know for people in the back, they can't read the slides, but the far left blue graphs are the dengue situation in Sri Lanka. As you can see, the vast majority of cases are in young adults between 20 to 40 years of age. And that has its own set of problems. The purple bars are in the Colombo municipality area. And you can see in the Colombo municipality area, things exist in Sri Lanka because we haven't been looking for Zika and other arboviral infections. So with the collaboration with Latin America, because we are the Asian side, and in Latin America with Nicaragua and Ecuador, where the epidemiology is different from Sri Lanka, we are carrying out this study looking at all these arboviruses. Because if you want to be prepared, you have to actually know what is going on out there. And so we are doing this comparative epidemiology with an urban site, which is around the Burlesgamu MOH area, and an urban slum area where there is this drastic difference in epidemiology to find out the differences in dengue transmission and also existence of other arboviral infections. And we have finished recruiting 3,000 individuals who we will be following for a 5-year period to understand how all these things affect transmission. And of course, as mentioned by Farhat, I am working for the DNDi, and which has included dengue as one of in their portfolio. And the idea is because such a lot of individuals are infected annually, around 400 million individuals are infected annually with the dengue virus, with about 100 million symptomatic infections. This is likely to increase in future with the climate change. And because of that, we need very quick solutions for these in the context of drug development. Now, to start with new chemical entities and take them towards a drug takes like 10 to 15 years, and we don't have that time. We want solutions fast. So the idea is initially or immediately, the short-term plan is to find out repurposing drugs, the existing drugs, to take, because we know the safety profile, all the pharmacokinetics, pharmacodynamics, and all that, and so to identify such drug candidates, to repurpose them to be used for dengue. So that's the whole plan, and thank you for listening, and I'm happy to take any questions.
Thank you, Professor Nilika. I would like you to join me here. And I'm delighted to have, please have a seat, Dr. Adil Najam with us once again in the Scientific Days. And we do believe that he has some pearls of wisdom for all of us in the room. Dr. Adil Najam is Professor and Dean Emeritus Frederick Espada School of Global Studies, Boston University, USA, and former Vice Chancellor of the Lahore University of Management Sciences. He was the lead author for the third and fourth reports of the Intergovernmental Panel on Climate Change, work for which the IPCC was awarded the 2002 Nobel Award. So over to you, Dr. Adil Najam.
Thank you. Thank you so much. Thank you so much. It is wonderful to be back with you. I am sorry that once again, I come to you through this sort of world of technology. I hope people can hear me. I hope people can see me. I would have loved to be there. I have been listening to the conversation. And one of the things, but first to thank Maria for mentioning what I had mentioned earlier, but one of the interesting things that I've seen is since the last time I spoke to MSF Science Days in Asia, which was just 3 or 4 years ago, a lot of the conversation I've heard makes what I was going to say outdated, because it is wonderful to see people already having taken that on. Taken on the idea of the age of adaptation, taken on the idea of why this is going to be different. Let me just get out of the screen in that sense. But what I want to talk about today very briefly is to maybe move forward from where I was last time I spoke to you and talk about where we are in this age of adaptation, and again, what does it mean for all of us, for you and for myself. I hope people can see my screen. Can someone just tell me if they see a black screen? You do, okay. And you would see my name there. I will be very, I want to rush through a few ideas, so I will be quick because I want to get to the conversation. But let me throw out just a few big thoughts. I wasn't actually planning to do slides, but just having heard the last session, I thought it would actually be useful. Very quickly, the questions I want to leave you with, I'm not going to answer them. What is the climate telling us? Right? So we very often talk about climate as if something that's to be managed, and it is in some ways. But where we are with this thing I call the age of adaptation, I'll come to it, we need to listen to what the climate is telling us. The arrogance of us thinking that we can control it was always misplaced, but what has been proved now is that we are not just incapable, but we're also unwilling to do what we can do. And therefore, listening carefully, first thing for an organization like MSF, but any organization, is do not take the climate for granted as you could before. It's not simply a background noise. And you'll see what I mean by this. The second is, and again, Maria, thank you for introducing this for me, is this thing that for the last about 9 years I've been harping on, that we now live in the age of adaptation. If you are in Sri Lanka, if you are in Pakistan, where I'm from, if you are anywhere in South Asia, anywhere in Asia, anywhere on this planet, you know that we are now in the age of adaptation. Adaptation meaning dealing with the impacts of climate change, right? Dealing with the impacts of climate change is no longer a future issue. It is what is happening now. And that's the second question. And finally, of course, what does it mean for you? What does it mean for me? What does it mean for the development sector? What does it mean for the humanitarian sector? Let me rush through. There's a few points I might repeat from the last time I spoke to you many years ago, but mostly this is new. I know that has gone away, but what that slide had was actually, I think, a very important message for me, and which is that climate, as we think about it, is changing. That we know. That's the science we know. What we do not know is if we, humans, societies, countries, organizations, are willing or capable of changing. In many ways, because we have failed in managing the change of climate, the bigger challenge we have is now, can we change to respond to the changes of climate? Right? Whether you're talking dengue or something else, that's become the challenge, and that is significantly different from what it was. How so? Let me start with this. 2020 is a marker year for many of us. 2020 is a year, you've heard this many times, that was like no other. COVID, right? And I'm sure all of your lives were changed. We discovered Zoom like we had never discovered it. We discovered lots of things. Our work changed, our life changed, our families changed, our health changed. Let me tell you what other things were happening in 2020 while we were all playing around with Zoom. Here is my 2020 and yours. There is nothing new in this slide, but I want to put it anyhow. January of 2020. Right? COVID, we are still sort of talking. You guys are, most of the world is not. January of 2020, hottest January ever recorded. Ever, since we've started recording global temperatures. January, hottest ever. February, second hottest February ever. March, second hottest March ever. April, second hottest April ever. May, hottest ever, May ever. June, hottest June ever. July, second hottest ever. Right? You saw these things every month on your newspapers, and then you started ignoring them because it just became a pattern. August, second hottest August ever. September, hottest September ever recorded till then. October, third hottest ever recorded. November, hottest ever. December, we got a little break, eighth hottest. If I do 21, a number of these were again broken. Looking at 22 where we are, half of these will be broken. Right? And what I'm putting here is this is the age of adaptation. This is not something that will happen in the future. This is something that is happening now. Last week, it was 100 degrees Fahrenheit here in Boston. Boston, guys. That's sort of, that's not where it is supposed to be. But you've already heard about Pakistan, all across South Asia, all across Europe, all across Africa. And so this is something that is real. This is something that is here. This is something that is now. I wanted to point out. I hope people can see my screen because this graph is important. The point I'm making is very simple. You know it, but we need to know it viscerally. Climate is no longer a future issue. I told you 2020, let me tell you the history. Ever since this is data for every month for ever since we have started recording global temperatures, right? And if you see that graph going in, 1.5 is that thing they talk about, it's not going to be met. We are going to not meet that target, I can promise you. I hope I'm wrong. I wish I'm wrong. It is no longer even likely that we will meet the 2-degree target. We lie to ourselves when we keep talking as if we are doing something. We are not. Right? That's what the science is telling you. I am not using future numbers. A number of years ago, I promised myself I will no longer use future projections because it makes people think this is a future issue. Now you are going to say, okay, that is fine, Professor, but this is global temperature. I don't live everywhere on the globe. I live in a particular place in the globe. I'm not seeing this. Let me show you what you are seeing. I hope again you can see the slides. This is a map of the world. Same data for look wherever you want to look, wherever you are interested in. What is happening to global temperature? ever since we started recording it, 1933, 1942, 1945, 1954, so on and so forth. Right? Now, this story you know, but we need to look at what the story has happened. What is the climate telling us? Right? We look at this one snapshot at a time and then we get busy in whatever else is happening. But the trend is clear. The numbers are clear. This is not about slogans. The climate is screaming out and telling us something. And that is what we need to hear. So that's the point, that it is in fact global, this 1.5 degree. I hope it is met, but there is no indication whatsoever that at least I can see that it is likely to be met. Therefore, we have to prepare, we have to live in the age of adaptation, as Maria was kind enough to repeat what I often say, it's here, it is now. What does that mean? I'm not going to go through this very much because I've already heard, you know this already, you've internalized this already, but let me at least highlight the headline. What happens in the age of adaptation? The first thing that happens, which I believe is already happening in your lives and mine, we start talking about climate not only as carbon, but as impacts. Right? When you talk about mitigation, reducing the risk of climate change, you are essentially talking carbon management. I reduce travel, I reduce my energy use, so on and so forth. We need to keep doing that. When you talk about adaptation, you're talking not just about what to do about climate change, but what climate change is doing to you. I was delighted in the last half hour to hear dengue talked about many times. I used this picture rather than the ones people usually use of polar bears. Because the polar bear picture, you know the picture about polar bear on an ice slab? That is a lie. The reason it's a lie is it makes you think as if nature is waiting for you to save it. Nature is not waiting for you to save it. Nature has seen what you and I do. Nature has no faith in you. I've spoken to a few polar bears. They're not waiting for us. When climate changes, nature hits back, right? Because the climate doesn't change only for you and me. It doesn't only change in cities and in where I live. It changes for nature. And when it changes for nature, as your experts have said, things change in nature, right? Dengue this has been my picture for the last 8 years. We are seeing this move of dengue. We heard about it in Sri Lanka. You're seeing it even in northern Pakistan. You're seeing it in the foothills of the Himalayas. Now, this is not all about climate change, but some of it is. Much of it might be people moving from one place to the other, taking pathogens, disease, other things with them. But when the climate changes, nature changes with it. And nature often adapts earlier than we humans do, right? That is why nature is important. You've talked about heat waves in Pakistan and how many people have died. So 3 weeks ago, the story of Pakistan was, and this is true in many countries, I'll just say Pakistan, that's where I'm from. 3 weeks ago, the big story in Pakistan, apart from the politics, which is always silly, the big story in Pakistan was hundreds of people were dying because of heat. Today, the big story in Pakistan is hundreds of people are dying because of a flood. I promise you, unfortunately, within 3 weeks, the story will be of hundreds of people dying every day in drought. That is what climate does. The footprint of climate impacts is water. You are going to be talking about water more and more and more as you talk about climate. This picture you see, that little blue dot, is all the fresh water in the world. That doesn't mean we don't have fresh water. That means we have to use it wisely because it's not evenly spread. If you think about impacts on climate, most of them immediately are about water. What happens when climate changes? Climate changes, water rises, sea level rise. Climate changes, water disappears, drought. Climate changes, water melts, glacier. Climate changes, water falls from the sky like no one's business, floods. Let me give you a sense of where you work, the humanitarian, right? This is how climate deals with it. We again have a flood right now, both in Bangladesh and in Pakistan and many other places. If you look at the story at Bangladesh, it's the same, right? We know floods. Floods have happened before, but the frequency and the impact of the floods increase. That becomes a threat multiplier. This picture is from the 2010 floods. I used it to explain what floods mean for us in Asia to my audiences, my students in the US. The blue area is what happens when where the flood was, right? High flood in Pakistan, 2010. I took that blue area, put it within a map of the US to scale. This is the area it covers from the border with Canada to down Florida. I put it on a map of Japan. It was bigger than all of Japan. I put it on a map of Europe, from Denmark down to France, right? So flood is not just my basement going wet. Flood means massive, massive impacts for people. Therefore, it means disease. Therefore, it means health. Therefore, it means MSF. If as soon as you talk about water, what are you talking about? Food. Because food, after all, is nature's way of packaging water so that we can transport it. Right? So as soon as we start talking water, you're talking food. I'm rushing through this. I wanted to stop a minute on heat. I know I'm going long. I'll just stop, please. Heat, we in Asia, I don't need to explain this to you. But we are seeing all across Asia. I've used the pictures from Pakistan. I can use them from India. I can show these to you from Bangladesh. I can show you these from East Asia. I can show you this from Thailand. The data is, again, irrevocable. These pictures that I'm putting up should not be real. There is no reason, given the wealth we have in the world, there is no reason, given the science we have, there is no reason, given the technology we have, the knowledge of medicine and health we have, that these pictures ought to be not even at temperatures that are unheard of. Right? Mobs should not look because of a heat wave in Karachi like this. Right? These are, again, real pictures. This is happening. Unfortunately, these no longer even make news because heat has now become a common thing. It's like daily weather. Today, so many people died. Okay, let's move. Right? That is the challenge. Refugees, people talked about. Again, I'll be very, very quick here. When we think about refugees, you guys work with this, you think of pictures like this. Right? Bad thing happens in place, and many people move from that place. That is not how climate might, or a lot of climate refugees don't work like that. What we are seeing, this is an old map. I hope you can see the color. This is from Africa. This is Guinea and Sierra Leone. If you look at the left bottom side, I'm rushing here, so keep your eye on the bottom left. This picture is of Guinea, January 6, 1974. Let me fast forward it. Same picture, December 19, 1999. What happened? The green turned into light green. Why did it turn into light green? There was a war in not Guinea, but Sierra Leone. What happens when calamities happen? People moved into Guinea. When people move, they put pressure there, right? This is about impacts on water, but you see the same here. My major point here, what does this mean? What this means is that what climate is doing for you, MSF, and me, Adil Najim, and everyone in the world is it is reminding us of what insecurity means again. Not security, insecurity. That's what people really care about, is when they're insecure. A way to think about insecurity, this is from a book I wrote in 2006, long ago, is insecurity is essentially about two things: violence and social disruption. Right? So insecurity can happen because of two reasons. Either I go and hit someone, there is violence, and they become insecure, or something happens where no one hits anyone, no one shoots at anyone, but the social disruption creates insecurity in my life. Right? If we look at that, it can happen at two levels, from state, countries, to society. When violence happens at the state level, the result is very clear. It is war. Right? That is clearly insecurity. We are seeing too much of that already in the world. But when violence happens at the societal level, which happens even more than war, insecurity comes from civil strife. Right? And you can look at the world, and that's what's happening. When social disruption happens at a state level, even if there isn't violence, people become insecure because of institutional failures, because of load shedding. That's the picture I have. When load shedding happens, what you do is you make people insecure. Their livelihoods become insecure. Their ability to educate themselves become insecure. And finally, when social disruption happens at a societal level, what you get is human insecurity. The message for you, MSF, is all of these insecurities are compounded by climate change. War may be unlikely, But civil strife is already happening because of climate. Institutional failure is already coming to a theater near you. And human security is here and now. I have taken too long, so let me please end right there and thank you for your time and for your kindness. That has always been great. Thank you very much.
Thank you, Dr. Adil Najam. Every time you just leave us with quite some thoughts. I'll request my fellow panel speakers if they can switch on their cameras and come online so that we could see if there are any specific questions for any one of you. I'm just looking at our IT support team. I don't know, Maria, if you are still online, would like to have you also there. Thank you. I'm just looking, giving the first opportunity to our audience in the room, if there are any questions for any of the panel members. I think we are all left with lots of questions. Oh yeah, there's a hand at the back. If you could take the mic there, please.
Yeah, so I actually want to pose this question to Professor Malavige. It's about actually drug repurposing when it comes to especially dengue infections. Do you think the fact that although there has been several medications undergoing laboratory investigations for a long time but has not actually reached bedside, could it be that we are probably looking at probably different outcomes? Do you think we should kind of shift our focus to more more clinical endpoints? Because there are several drugs which have shown antiviral properties, but probably when it comes to clinicals, clinicians might expect different outcome. Do you think that has been one of the reasons for a lack of actual medication being used?
Yes, so that's an important question. And of course, people have been looking at different endpoints. But also one important reason, I think, example we can take from COVID is the fact that we got so many drugs very early on, like dexamethasone, and then the trials on remdesivir. All that was possible because a lot of work was done simultaneously, not in single institutions, isolated studies, but large studies looking at all aspects of possible treatment for COVID. And we know that in a very short span, we got several treatments for COVID, including antivirals and host-directed therapy. So for dengue, of course, there have been many clinical trials. We have also done in Sri Lanka. In the Sri Lankan trials, we have looked at certain endpoints. Some other trials in other countries, they have had different clinical endpoints. But I think what actually would take us forward is having a lot of institutions coming together for a common cause, like we did for COVID, so that we can have a very accelerated approach looking at possible antivirals, if that is the case, or for host-directed therapy, or a combination. And it is very difficult for one or two institutions to do, to do that scale of things. So this is why I think DNDi has brought in a lot of partners from the region to start with preclinical screening of different candidates, antiviral and host-directed therapy, and then looking at the translational side of it, including implementation. And consulting all the relevant stakeholders to look at the relevant clinical endpoints.
Thank you.
Thank you. There's an online question, and this question I would invite all the panel members to see if they have any reflections. Could you share any insights on climate justice? Are vulnerable countries, the ones with much lower greenhouse gas emissions per capita, treated more unfairly than the big rich economies like USA or UK? Maria, Adil, who would like to take it there, and then we can pass it on to Nilika. Yes, please, Adil.
Thank you, and I would love to hear from our other panelists too. Yes, of course, it is about justice. In fact, the only thing it is about is justice, and it's about justice in multiple ways. One of those ways you mentioned, which is that, and I didn't go into it this time, I went into it last time, that where the emissions are coming from, meaning where the problems are being created, is not where the impacts are. Right? I create the impacts here in Boston because I choose to live 40 miles from my work. My brother and my nephews in Pakistan reap the benefit of that because the carbon molecule doesn't have a flag on it. Right? And if you look at a world map, I've shown it before, won't show it here, the world map of where the emissions are coming from, it is nearly a reverse image of where the great impacts are. But it is not simply about countries. It is about poor people. Even within countries, the poor, most vulnerable people are most vulnerable to climate, not because they caused it, but because poverty makes you vulnerable. It's not like nature doesn't like poor people. No one likes poverty, unfortunately. What it means is if you are poor, your ability to cope with climate goes down. You know this, earthquakes. Earthquakes aren't climate, but it's a good example. When earthquakes come, people don't die because of earthquakes. Nearly no one dies in earthquakes. What they die of is because their roof fell on their head. Right? And if you are poor, your roof is more likely to fall on your head. If you're poor, when disease comes, you are more vulnerable because you are less ready. If you are poor and floods come, your home will go away before the rich. So what I mean by that is, yes, you are right about international, but not to forget that the same patterns are repeated within our countries. And climate is a justice problem within countries. Climate is also a justice problem within generations. So in all of those things, justice to me, and my name is Adil. Those who know what Adil means will know why I'm saying this. It comes from Adil, which is justice. Justice is central to all climate change.
Thank you. Thank you very much. Maria, Nilika, anything to add on this?
Sure. I think inherent in the work of MSF is indeed addressing the challenges, especially for the most vulnerable populations. And there's nothing more highlighting than climate change of that discrepancy between the responsibility and vulnerability. And as Professor Adil had already mentioned, I tend to highlight these tale of two maps of where those responsibilities and where the vulnerabilities are. And unfortunately, the most vulnerable are the humanitarian hotspots of climate hotspots, and they tend to remain blind spots. And I think this is one of the reasons why MSF is more engaged today at the COP 26 and hopefully this year at COP 27 to really raise awareness to that, what you might call climate injustice, and bear witness on behalf of those who are most affected by them. And this is one of those things that we're trying to push on the COP, is that it is not only a health crisis, as we've just said, but it is most definitely a humanitarian crisis. And linking that together is really important to raise awareness about this climate injustice. And one of the things that's also interesting, and we put out a paper last year in the wake of the COP26, is that, in addition to adaptation and mitigation in our roles in trying to do that, as we've discussed, is how we look at climate financing. And one of the things that's still not met at the COP, as when they made that statement at COP21, is this loss and damage of 100 billion. It's basically a modest sum in comparison to the needs of humanitarian development today. And what we want to highlight is that those should not be mixed. One is a reparation, the other is addressing the needs that are very pertinent today. And, I think it's very important that we put our voices together to speak on this climate injustice.
Thank you. I would like to go on and on, but I'm very mindful of the time and I'm looking at the clock. Twice I've been hinted towards that. I would really like to thank all the panelists for making out the time and bringing in some critical things that we may be aware of but have not been thinking. And hope we all take actions in our small spaces. Thank you, each one of you. Thank you very much.
Thank you.
Thank you.
Thank you very much.
Thank you, Farhat and panelists. Dr. Nika, sorry. appreciation, excuse me. I would like to hand back over to Kalani, who's going to take over from me again and close the proceedings. Thank you for your attention.
Thank you, Helen. I think now we are reaching the end of today's proceedings. This year, Dean of the Faculty of Medical Sciences, Senior Professor
in progress.
Aloka Pathirana, and the Chairperson of the Research Committee, Dr. Baruni Tennakon, to come and join us on stage for the awarding of certificates. I would like to invite the Secretary of the Research Committee, Dr. Nilanka Pereira, to announce the winners. Over to you, Madam.
Thank you, Kalani. At the outset, let me briefly give an overview. We had 106 abstracts submitted. Out of that, there were 69 poster presentations judged before the conference, and the high-scoring abstracts were presented as oral presentations today. So we have winners in each categories. The first, the best poster presentation in the category of clinical medicine, quality and patient safety, and pharmacology and toxicology goes out to poster presentation 23, determination of in vitro antidiabetic and antioxidant activities of dietary supplement Coccinia grandis void, by authors Vasana KGP, Attanayaka AP, Aravala LDAM, Veeraratna TP, Jayathilaka KAPW. I would like to invite one author to come on stage and receive the certificate. Best poster presentation in the category of infectious diseases and miscellaneous. Poster presentation 1, patient perspectives of having cutaneous leishmaniasis and treatment with intralesional sodium stibogluconate. Authors Senaratna S, Leighton AM, Somaratna V, Paul MK, Kahawata I, Vikramasinghe R, Ranasinghe S. Best poster presentation in the category of preventive medicine and public health and miscellaneous. Poster presentation 19, heroin addiction relapse and associated factors, a study in a community-based treatment center. Authors Valpola DN, Samaranayaka TSP. Best poster presentation in the category of health policy and medical education. Poster presentation 34, evaluation of medical waste management practices among selected hospitals in Sri Lanka. Authors Vikramasinghe NMPM, Tudugala R, Vikramasinghe M, Piris MMK. Now it's time to announce the overall winners of the poster presentations. The third place goes out to poster presentation 26, studies on the anti-cancer potential of plants belonging to the genus Cisalpinia aninthe. Resma Jakub, Vasilska Inga, Svetik Lukas, Sinarska Elvira, Zengi Gökhan, Rajda Barbara. The authors are actually from Poland and Turkey, and we will not be attending in person, obviously. So the second place goes out to poster presentation 19, heroin addiction relapse and associated factors, a study in a community-based treatment center. Valpola DN, Samaranayaka TSP. best poster presentation at the ICM 2022 poster presentation session goes out to poster presentation 23, determination of in vitro anti-diabetic and antioxidant activities of dietary supplement, Coccinia grandis void, Vasana KGP, Attanayaka AP, Aravala LDAM, Veeraratna TP, Jaitilaka KAPW. Then we come to the last award. The best oral presentation goes out to postpartum weight retention and factors associated with postpartum weight retention in mothers attending child welfare clinics in a selected medical officer of health area, Colombo district. Authors Veerakon AY, Sirisena KKSN, Kalupahana MCE, Utpala PGP, Chamud DAS, Aditya NLV, Hettiarachi UPK, Gunawardana CSE. Thank you.
Thank you very much. I would like to invite the Dean once again, sir, Dean of the Faculty of Medical Sciences, Senior Professor Aloka Pathirana, to speak a few words to the audience before we wrap up.
Distinguished guests, my dear colleagues, students, ladies and gentlemen. I think the time has come for us to conclude the much awaited conference, the medical conference that we had of our faculty in collaboration with the MSF. I'm certain that you all would agree that the conference went off well, despite all the fears and uncertainties we had, even a few weeks back. We had a relatively young organizing team from our faculty and an even younger organizing team from the MSF to take this conference. And it was heartening, and I was really amazed how they planned this, and the attention to detail was super. So I'm very happy that we had this organizing team doing that for us. I must congratulate the organizing team from both the MSF and our faculty for a job well done. We couldn't have asked for anything better. We had more than 150 participating physically and over 700 participating online. Starting from the inauguration with the oration, the scientific sessions with all the presentations, symposia, etc., all were very well received. And we can be happy that we achieved our objective of disseminating scientific knowledge and building collaborations. I sincerely hope that the issues that were discussed would be addressed in the near future. The partnership with the MSF was good in many ways. It took the conference to a different level, which increased the participation of individuals both from here and from overseas. The flavor of the conference was tailored to satisfy the needs of many. I was impressed with the few panel discussions that I was there to witness, and particularly the one about climate change, which really opened my eyes. And it really showed how we should be concerned about climate change right here, right now, not in the future. And we feel this partnership with the MSF was very helpful, and that we could forge more collaborations with them to benefit both parties in the future. The support, I must say, given from the university headed by a Vice Chancellor, who is always keen to support any progressive activity, is commendable. Despite the difficulties, which were mainly financial, we prevailed. Once again, I wish to thank the organizers headed by our energetic and meticulous head of the research committee, Dr. Varuni Tennakon, and her team, and the MSF headed by Farhat Mantu and Helen O'Neill, Akansha Aror and Dr. Bishmaraj Srivastav for the support given and having faith in us in delivering the goods. Thank you.
Thank you very much, sir. And let me finally invite Dr. Thushari Disanayake, the Conference Secretary, to deliver the conclusive remarks.
Thank you, Kalani. A very good evening to you all. Now that we have reached the end of the MSF Asia Scientific Days and the ICM 2022, I sincerely hope you all had a fruitful day and enjoyed this joint venture. Organizing this conference was not at all an easy task, given the current situation in the country. We navigated through a lot of uncertainties, challenges, and difficulties. However, despite all this, here we are, have achieved what we wanted to. An accomplishment we all can be proud of. Starting from a fabulous inaugural ceremony last evening, we listened to an oration of the highest caliber. Today, throughout the day, we have had interesting, insightful, and interactive discussions and great opportunity to share the outcomes of our research. I believe many good experiences were shared and great lessons were learned. Further, I hope that you have also enjoyed networking opportunities throughout the conference, and the contacts that have been made here will continue in the future. We at the FMS very earnestly look forward to more future collaborations with the MSF to join their work in humanitarian missions, research, and medical education fields. I am confident that this partnership will grow into a long-standing and mutually rewarding experience. I would like to take this opportunity to thank everyone who made this conference a success. We had a long day, so I'll be brief. First, I extend my gratitude to Senior Professor Sudanta Liyanage, Vice Chancellor of the University of Sri Jayawardhanapura, and Senior Professor Aloka Pathirana, Dean of the FMS, for their blessings, guidance, and the presence whenever we needed. My sincere thanks to the joint organizers, the MSF team, and the Research Committee of the Faculty of Medical Sciences, University of Sri Jayawardhanapura. The MSF offered a wonderful partnership under these difficult circumstances. You all proved to be truly supportive and inspiring. Thank you very much, Farhat, Helen, Akansha, Raj, and everyone of the team for going the extra mile to make this happen. The FMS Research Committee, led by the enthusiastic duo Varuni and Nilanka, and all members, including Aruni, the Assistant Conference Secretary. Thank you for shouldering this mammoth task and seeing it through to the end. Further, a big thank you to all academic and non-academic staff of the faculty and the university, also the students who helped in numerous ways. I am much grateful to all speakers and panelists for their valuable contribution and all authors who shared their excellent work with us. Also the abstract reviewers, free paper judges, session chairpersons, and moderators for their valuable input and the time spent. Helen and Kalani, thank you for steering us through the program with your excellent comparing. Most importantly, I would like to thank all the participants, both here in person as well as online, who helped to make this a successful event. Last not least, I deeply appreciate our event organizers, Nalin and his team from Impress Events. You did a truly impressive job. Ladies and gentlemen, I am certain that the takeaways from this conference will further nourish our professions, stimulate our future work, and help build in stronger connections together. It's been a pleasure being with you, being with all of you today. Thank you.
Thank you very much, Madam, for sharing those sentiments. With that, ladies and gentlemen, we mark the conclusion of the MSF Asia Scientific Days and the International Conference on Medical Sciences 2022 here in Sri Lanka. It was truly our pleasure hosting you here at the University of Sri Jayewardenepura, and we had a wonderful experience with our team from MSF who came all the way and joined this venture. We hope you leave this hall today feeling impacted, inspired, and driven to continue your journey in innovation and research in medicine for the future. Until we see you again, it's a goodbye from us, and I hope to see you soon. Have a wonderful evening and a safe journey back home. I would like to extend an invitation to all of you to come join us on stage to take a big photograph. It's not that we do this every day, to remember this moment. So with that invitation, it's a goodbye from us. Take care. Ladies and gentlemen, it won't take much time. Let's all assemble on the stage. We would like to have all of you. We would like to have each and every one of you in these photographs. It will take just 2 minutes, so just make your way up to the stage.